So we are going live in 3, 2. So good afternoon and welcome to OrthoTV for a very, very special program, the 7th edition of Spine Weekend. And for further proceedings, I'll invite convener Dr. Shailesh Hadgaonkar. Over to you, sir.
Thank you, Dr. Shyam, for this wonderful academic meeting, the 7th Pune Spine Weekend. Myself, Shailesh Hadgaonkar, Dr. Ajay Kothari, Dr. Siddharth Aiyer, Dr. Pramod Bhilare, the Pune Orthopedic Society, Sancheti Hospital, and all of us. I welcome you all on behalf of this 7th episode of Virtual Spine Weekend. This year, as the COVID is receding, we planned for online, but next year surely we will be coming in live format, and as we used to do the live surgeries, that will happen next year. This time the meeting is mainly of 3 sessions. First session is the lumbar spine, and we'll be having some interesting cases, videos, and discussions, debates in this first session, followed by the second session of spine deformity, as Japan Scoliosis Society is affiliated with us, and as to match their timing, we have kept the session in the second round. And the third session is cervical spine, which will be again an interesting session, which is decision making in cervical spine. We kept it decision making in cervical spine, dilemmas in lumbar spine, which are very, very common for all of us. And we have a stellar faculty for this year's program as well. We have our academic chair for the complete program, the ASSI president, Dr. Shankar Acharya from Delhi. Thank you for giving us this great opportunity and being there with us for this program as academic chair, sir. We have 3 session chairs for this program. We are Dr. H.H. Chabra, sir, for the lumbar spine, Dr. Gautam Zaveri and Dr. Abhay Nene for the cervical spine, and Dr. Ajay Shetty for the deformity symposium. We have stellar faculty from all over the country and abroad. We have Dr. Kern Singh, Dr. Alok Sharan, Dr. Anand Tambe from US and UK. They will be with us. Also the Japanese Spine Society, Dr. Kota Watanabe and team will be there with us. Today's program definitely has one important feature with us. We have Dr. Ajay Chandanwale, who himself is a spine surgeon, and he was our mentor. And he is presently the joint director of DMER Mumbai, the director of medical research and education. We welcome you, Dr. Chandanwale, sir, for the inaugural program. We welcome Dr. Narayan Karne, sir, who is the president of Pune Orthopedic Society. We welcome Dr. Shankar Acharya, sir, for this inauguration, as well as Dr. Parag Sancheti, who is the chairman and a backbone for us at Sancheti Hospital for inaugurating today's symposium. Yes, Ashok.
Sir. So can we start the inauguration?
Yes.
Kurutvam kalyanam arogyam dhanasampadah shubham kurutvam kalyanam arogyam dhanasampadah shatru buddhi vinashaya deepajyotirnamostute deepajyotirnamostute shubham kurutvam kalyanam arogyam dhanasampadah shubham kurutvam kalyanam arogyam dhanasampadah.
I request Dr. Ajay Chandanwale, sir, to say a few words.
Good afternoon to Dr. Shankar Acharya, all the faculties, as well as the Japan Scoliosis Society, Pune Orthopedic Surgeon Doctor Society, as well as Dr. Karne, sir, all the faculties from national, international levels, and those faculties, as well as the students, those who are attending this 7th Spine Weekend. Day by day, the spine problems, they are increasing, and especially I came to know that only 1% out of lakhs the scoliosis, the percentage of scoliosis in India is 1% out of 1 lakh patients. So it's a great need for the society to have a good expertise spine surgeons within our country. And with the initiation of Sancheti Hospital, especially Dr. Parag Sancheti under the leadership of Dr. Shailesh Hadgaonkar, as well as collaboration with Japan's Scoliosis Society and the Pune Orthopedic Society, as well as OrthoTV. The initiation is excellent for the young surgeons as well as all the experienced surgeons, because we have a great discussion regarding the deformities as well as the problems regarding cervical spine and the lumbar spine. I really appreciate, I really recommend, congratulate Dr. Parag Sancheti along with Dr. Shailesh Hadgaonkar and all the faculties, those who are participating in this 7th Spine Weekend. Indirectly, though our surgeons are being expertise because of this discussion, indirectly the community is at benefit. So I really congratulate Dr. Parag Sancheti along with Dr. Shailesh to carry this function the 7 times successfully. And of course, I really thankful to them as well as to all the faculties, those who are from national and international level. Because of their great contribution, our young surgeons as well as the experienced surgeons from our country, they have a very good discussion along with their knowledge as well as the knowledge from the expertise. Thank you very much. I give my best wishes for this 7th Spine Weekend Conference. Thank you very much.
Thank you, sir. Thank you for kind words. I will request Dr. Shankar Acharya, sir, the president of ASSI, to say a few words.
Thank you, Shailesh. And I welcome all the delegates and the faculties and the participating societies, the Pune Orthopedic Association, the Sancheti Hospital, and the Japan Scoliosis Society, and all the international faculty, Dr. Karan Singh and others. And I think Pune Spine Weekends are usually very good weekends, and I've had the honor of participating live in 2 such. And of course, I think Shailesh and the whole team with Dr. Sancheti and others have carried this flag forwards. And I must also mention that Dr. Ashok Shyam has quietly and silently allowed all these live transmissions seamlessly throughout the world and has attained a stature amongst us, and everybody in orthopedic spine and others know him and thank him as well for his kindness and his help in this matter. And since it is a very long session, I don't know how Shailesh managed to keep a 5-hour session. I will not say any further words. I wish you well and congratulations and all the best. Thank you on behalf of ASSI and all the members of ASSI, and on behalf of my ex-president, Dr. Chavra, who is there, and Dr. Ajay Shetty, who is there, and all others who are, Dr. Rupinder, who is there. I welcome you all.
Thank you, sir. Thank you for your kind words. I will request Karne, sir, the president of Pune Orthopedic Society, who has given us great support for all these academic events throughout the year. Over to you, Karne, sir.
Thank you, Shailesh. Joint Director, DMER, Dr. Chandanwale, sir, President of the Association of Spine Surgeons of India, Dr. Shankar Acharya, Dean of Sancheti Hospital, as well as the Chairman of Sancheti Institute of Orthopedic and Research, Parag Sancheti, and my dear friends. Well, on behalf of Pune Orthopedic Society, first of all, I thank Team Spine because continuing for last 7 weeks, they are giving the excellent academic inputs, not only to the spinal surgeons, but also to the average orthopedic surgeons who do not do the spine surgery, but they see spine patient every day in their OPD, and they know now what can be offered to them. So though this is not only for the spine surgeons, neurosurgeons, or the fellows, but also for the general orthopedic surgeons to know what surgeries can be done now in their own city or in their place. I have to appreciate Dr. Shailesh Hadgaonkar. He is an active member of the executive committee member of Pune Orthopedic Society also, but he is one of the most dynamic person, has done the maximum number of the CMEs on behalf of Pune Orthopedic Society in this whole year. I thank him for that. And I thank all the speakers and from the national level as well as on the international from Japan, USA, and UK. And thank Japan Scoliosis Society also and the Sancheti Hospital who had made this particular program successful. Once upon a time, the scoliosis was supposed to be the one which is on our dreams. I'm in practice for the last 36 years, but we never thought that we'll be able to see scoliosis surgery anytime in our life. but now it has been done in my own hospital also. So the things have been advanced so much, and people are confident that they themselves also can operate as well as they can operate the patient in their own hospital. I thank all the spine surgeons for that. Without wasting much ado, this is really a marathon program. Hats off to Shailesh, whole team's spine weekend to arrange such a program of all the galactic speakers. And last but not the least, the OrthoTV team, who I know from where they bring all this energy. Simultaneously, they are doing all the programs at a one time, Bijlani and Dr. Ashok Shyam. And it is not only in India, but now they are becoming famous all over the world now. Best wishes for them also, and best wishes for all the program. Thank you very much.
Thank you, Karne sir, for your kind words. Ashok, is Dr. Parag around?
I think he's still busy in the Mumbai conference, but he has sent us a video which I can play for him.
Can you please? Yeah.
Hello everybody, I'm Dr. Parag Sancheti, Chairman of Sancheti Hospitals, Pune, India. It gives me a great pleasure to welcome you all for the Spine Weekend, which is the 7th edition, organized by Sancheti Hospital in association with Japan Scoliosis Society and the Pune Orthopedic Society. We have a galaxy of international faculty from USA, UK, and Japan, and of course our own national stalwarts are also a part of this spine weekend. I think academic activities like these are very important to stay abreast with the latest developments occurring in the field of spine, and I really feel the faculty which is present today is going to enrich all the delegates attending the spine weekend. I especially want to mention Dr. Shankar Acharya, President of ASSI, for his time and for contributing to the spine weekend. Also, Dr. Chabra, Dr. Ajay Shetty, Dr. Gautam Zaveri, Abhay Nene, Ram Chadda, and other faculties, thank you for your time. If it was not for the efforts of all our consultants at Sancheti Hospital, namely Dr. Shailesh Hadgaonkar, Ajay Kothari, Siddharth Aiyer, and Pramod Bhilare, this course would not have seen the light of the day, and I thank our own faculty for putting together this spine weekend. Last but not the least, let me thank Ashok Shyam from OrthoTV for giving us this platform to represent and show the delegates what has been happening and what are the current trends in the spine. In the pandemic period, the OrthoTV has proved us a boon, and the academic activities have not been left behind because of the pandemic, and thanks Ashok Shyam for that. I wish the spine weekend great success and want to thank all the delegates for having attending this meeting and for having found time to be present here today. Thanks all the delegates, thanks faculty, thanks organizers. Have a great meeting. Wish you all the best. Thank you.
Thank you, Dr. Parag, sir, for the kind wishes and great support for this academic feast and activity. I would request my colleague, Dr. Ajay Kothari, to say a few words and welcome.
Thank you. Good afternoon. On behalf of all the organizers, I would really welcome all the galaxy of stars and the faculties which are present on this podium. Also, I would welcome all the delegates who are attending this conference. And as Dr. Shankar Acharya said, that it's going to be a 5-hour event, but sir, and all the delegates, let me promise you that we will ensure that every minute of this conference will be utilized to the fullest. Thank you so much. I think without wasting much of time, I would hand over the mic to the first presenter. Thank you so much.
And as the session chair, I would request Dr. Chabra sir to take over for the first session.
Yeah, thank you, Shailesh. The first presenter is Dr. Himanshu Kulkarni. I would request him to start with this case presentation.
Good afternoon, all. Good afternoon, all. This is Dr. Himanshu Kulkarni, spine surgeon from Sangli. I am the opening batsman of this mega event that is happening today, which is Spine Weekend, the 7th edition. So, without wasting much time, I'll start with my case. I'm the first one. So, dilemmas in lumbar spine. So, this is my first case. So, it was a 44-year-old female, left leg pain. She had it for 1 year. Conservatively managed since last 6 months. She had no comorbidities. This is still happening in the past. This case has not yet reached to me. So this is what happened before, and I'm just presenting that. So she had no comorbidities. This was the preoperative X-ray. She was being managed somewhere else. So I don't have the preoperative MRIs available with me. So this was the X-ray, dynamic X-ray. You can see there is fair amount of asymmetric opening at L4-5. So this was probably a lumbar canal stenosis with instability. So preoperative MRIs I don't have. She was operated by L4-5 TLIF. The leg pain disappeared immediately after the surgery. Patient was allegedly very happy on the eve of the surgery. Patient was mobilized on the morning of post-operative day 3. And from same evening, patient had recurrence of left leg pain. The left leg pain was much severe than what it was before the surgery. And she had that recurrence on the post-operative day 3 when she was mobilized. So once that happened, the treating doctor got the X-ray done. And this is what the X-ray looked like. So as you can see, the cage has probably slipped posteriorly a little bit. That may be the cause of the pain, or may or may not be. So this was the post-operative X-ray after the surgery number 1. So the post-operative X-ray, small size cage, slightly backed out. So what they did was brace was given, conservative management was given in the form of steroids. So with the help of steroids, the pain came down a little, but it never went away. The intensity of pain got reduced, but pain was persistent, and they tried to conserve that patient for 3 months. So what next? If this patient was our patient, irrespective of what they did, so what should have been done? So Chabra sir, shall I ask or shall I go ahead?
No, please ask.
Okay, so at this we have all the mega bosses here. So I would just like to pop the question. So if this was our patient, what should we do? So what should be the message for the people who are watching? You have postoperative leg pain. You can see the cage is backed out a little, but you're not very sure whether that is a cage or that's a remaining disc fragment. So what should be done here?
So Himanshu, I would want to get a MRI scan with CT cuts.
Yes, ideally. So if patient has leg pain post-operative, you should investigate it very thoroughly.
Yes.
Before doing anything.
Yes.
Okay. And yeah, if we consider that this is the cage which is causing the problem, so they didn't do any CT or MRI, but considering the cage has backed out and it is pressing over the root, should these be our options? So you either go anteriorly, take the cage out and do LIF, or go posterior, take the cage out, put a bigger size cage and decompress the root which has been pressed by the cage, or go posterior, hammer the cage in and pack more bone graft. Third option is not very viable option, but first two can be considered if the cage is the one who's causing problems.
What I feel is that we really need to pinpoint what is the cause of the leg pain. Is it inadequate decompression? I think we are just focusing, being biased, looking at the cage. But is there infection? Is there some hematoma? Is there some irritation of the root because of the screw? So I think we need to first identify what is the root cause of the leg pain and then plan our treatment accordingly.
Exactly, sir. So this is point number 1, which I am trying to make at the end of the presentation. So whenever you have post-operative leg pain, you have to investigate that very thoroughly. You have to pinpoint the cause and then act, and not act blindly according just to what post-op X-ray says. So this is what was done there, the primary surgery. So I don't know what they were thinking. They just went in and got the screw was out. They didn't do a CT. They didn't do an MRI, nothing else. Probably I don't know what happened. They tried to take the cage also out, or they thought probably some screw was a little too medial, which was irritating the nerve root.
They must have thought.
They probably thought the screw was the one who was irritating. So they took out the screws and cage was left behind. So no CT, no MRI done at this stage. This is still happening in the past. Patient has not reached to me yet. So this is how it looked. So you can see the cage is slightly stuck to the inferior end plate of the superior vertebra. So obviously the patient had persistent post-operative leg pain for 4 months now. This is 1 month post second surgery. The second surgery is done. So that means there is more scar, more adhesions, more fibrosis. So this is all messed up. So now what do we do? As Ajay sir has very rightly pointed out, if you have a post-operative leg pain, something is failing, you have to know what is happening. So you have to investigate, you have to get the imaging done very thoroughly. So we got the MRI done. As we go towards the left, you can see something, it's a slightly metallic shadow which is popping out through the L4-5 disc, which is pressing over the root. In the axial cuts, you can very clearly see the cage has backed out and it is actually irritating the traversing root. Most important in this scenario is CT. So in the CT, in an enhanced cut, you can very clearly see the cage is actually in the foramen. So you can very nicely see here the cage is, you can compare the superior foramens here and you can see this foramen. The cage is absolutely in the foramen and that is causing the compression. You can see very clearly in the axial cuts also. So they have probably done a left-sided partial facetectomy and they had put the cage inside, but it was a very small cage probably, so it backed out. So you can see the cage is actually slipping posteriorly. So what now? What do we do?
But is this conclusive? As in the cage back out isn't very significant. It's on the posterior vertebral body line, but it's not backed out to the extent, you know, where all the alarm bells are.
Yeah, may I put in some thought over here?
Yeah.
Please go one cut back, Himanshu.
The axial?
On the CT, on the CT.
Okay.
To the axial CT. Yeah. See now, in the central thing, wherein you put the orange arrow, the cage is already backing out, and you can see the nerve root also over there, the traversing nerve root, which is getting irritated or touched because of by the cage. And I'm not really sure what kind of anatomy I see over here. This seems to be a residue of the inferior articular process of the L4 vertebra.
Retaining bone fragment.
Yeah, retain, and the nerve root is getting trapped or sandwiched in between the cage and the retained bone fragment. That is what it looks like. And even at day one, if you see that the disc was wide lordotic and the cage was pretty loose. So especially on day one, like in these kind of cases, you need to put a large cage, or you need to kind of flip them horizontal so that it fills in the anterior gap pretty well. A little bit demanding to do that too from the back. But yeah, this is definitely irritating the nerve root, and removing out the screws only has in fact probably made it a little bit more challenging for the cage to be retained at its place. It is definitely going to back out further.
Yeah, exactly. So the posterior constraint has gone. So
did you do any dynamic films?
Yeah.
Any dynamic films?
Dynamic films at this stage? Yeah, I had shown that initially. So these are actually dynamic films which we got done at our place. So this is flexion and extension.
Yeah.
You can see that there is cage movement in the dynamic films.
Yes.
Yes. So I actually wanted Chavra sir, your views on this.
So I think it is, though if there is dynamic instability, there should be substantial back pain as well. But the nerve compression may be more also caused by the dynamic compression, which is there, which is seen in this. So that makes it more apparent in the extension, in the flexion, right? Flexion.
Yes, sir. Flexion. So
I have 2-3 cases like this. I also received such cases and I operated this. Therefore, I will not talk much.
I think we need to move. So, Himanshu, just anybody who would want to give the way ahead, how they would manage this case.
Yes, sir. Dr. Chahal, sir, how should we go?
Yes, sir. Revision surgery, sir. Revision TLIF.
Okay.
Yeah. I think now we have burnt our hands sometime. Never push back a cage which has backed out.
Yes.
Either replace it with a bigger cage or just replace it with a bone graft. But don't ever push that cage again. It will come out.
Yeah.
Yes, sir. So anybody of the opinion that we should go anteriorly and take it out, it would be easier, or
it will be difficult.
It will be difficult. Yeah.
Okay.
I had a point.
Yes, sir.
I think Himanshu, I think we will have to anyways try and revise the fusion, because I think 3 months would be too short a time. So I think if you're going to be putting in screws, doing an anterior A-lift will also anyways require the patient to be maybe flipped over again for percute screws.
Yeah.
So maybe doing it one stage may be better, but it will be tricky. It might be quite adherent to the posterior aspect of the thecal sac with the traversing nerve root also in the same vicinity. I think on the AP X-ray, if we see the cage is pretty central, it's not so much paracentral. So yeah, it's quite midline there. So it's going to be tricky to remove, but then with the consent and full disclosure to the patient that it might have complications, we will have to go through the posterior. That would be my
If
thought.
you see carefully, it is oblique, Siddharth.
Yeah, that's a banana cage which is not
on the left side.
But
So
sir, even on the CT, if you see, most of the cage is still medial to the medial most portion of the facet.
Left side facet, it's close to that.
Yeah, so it's still medial to the inferior articular process. So I think it will be tricky there. The nerve root will just be next to it.
If you take out the facet, go from the left side.
Yes, that would be better.
Yeah.
So what we did was we went in again. So this was the third surgery for a patient. So didn't disturb the midline. I put back all 4 pedicle screws. Now I did right-sided facetectomy and right-sided discectomy. The distraction was done after the discectomy. After the discectomy was done from the right side, I distracted that. As you can see, it was slightly stuck to the inferior end plate of the superior border, superior vertebra. So small osteotomes were hammered superior to the cage. The cage was separated from the end plate. After it was slightly separated, I first dissected the left-sided root and I got it protected because any movement of the cage or backing out would have actually put more pressure over the root. So the cage was hammered with a punch from right side and it was made a little loose since after it was separated with the osteotome. Then cage was taken out from the left side, end plate preparation was done and the properly sized cage was inserted from right side. So this is what our X-ray looked after the surgery. So it was a little difficult to take out the cage, but we could manage taking it out from the left side itself.
Well done.
These are actually, I don't want to go in the long past. These are very recent articles about this and just 4 articles and most common risk factors for posterior cage backout or cage retropulsion are: first is pear-shaped body, which is the most common risk factor. Second most common risk factor is undersized cage and primary malposition. So if you put a smaller cage, if you put a cage that is little too posterior to begin with, these have high chances to fail. And third most common risk factor is osteoporosis, according to these papers. So since we are time bound, the take home message is size and position of the cage during fusion. It is the most critical step. As it has been pointed out previously, post-operative leg pain, it should be thoroughly investigated before trying to rectify. You cannot just go in and just take out the screws and hope that everything goes fine. And cage retrieval, when you're trying to do it posteriorly, when it's a third surgery, which is second revision, it needs methodical planning. Stick to the approach that you're comfortable with. If you're comfortable with anterior approach, you can do that. If you're comfortable with posterior, stick to that approach. You have to see your steps in future and plan it accordingly. So thank you. I hope it was of some use.
Thank you, Dr. Himanshu Kulkarni. That was a great case and a great message to all our friends who are participating in this spine weekend. So may I request Dr. Shumayu Datta to now present his case.
Good afternoon, everyone. Thanks to the Pune Orthopedic Society and Sancheti Hospital for having me. That was a great presentation from Himanshu. And I'll be continuing on a slightly different subject. So I'm Dr. Shumayu Datta. I'm a spine surgeon from Calcutta. And this case is a 65-year-old lady, a known case of neglected AIS. And she complains of mechanical back pain, which is tolerable, and severe bilateral lower limb radiculopathy. Leg symptoms are more than the back symptoms, and right leg is more than the left leg. Progressive neurological claudication getting worse over time. And currently her walking distance was only 2 minutes. The VAS score for her leg was 10 out of 10, and back was 2 out of 10, and ODI was 78. So examination, motor is normal, sensory is intact, reflexes are normal. So this is her X-ray of the lumbar spine. As you can see that the lumbar curve itself is 60 degrees, but I have better X-rays, so we'll just go to that. And that is AP. I've stitched two X-rays together, the CT scan, I've done a CT scan for her, and the lateral X-ray. So this is the image. And of course, everyone would like to see what the MRI also shows. So I'll go straight to the MRI. And on the MRI, we can see that these three bones, L2, 3, 4, are sort of autofused. And at 4, 5, there's severe stenosis there. On the axial cuts, the whole thecal sac is shifted to the right. The right side is also the concave side. And at L4, 5, here, you can see the stenosis. So now, Chabra sir, I would give it back to you to ask the question. So how many would prefer a deformity correction with decompression? Would it be a long segment, short segment, or just would anyone go for a decompression for this patient?
So just come again, which side is the pain?
The pain is more on the right side.
Right side.
Which is the concave side, yeah.
So do we have Vishal here? Dr. Vishal?
Yes, yes.
Yeah,
Good
Vishal.
afternoon, sir. Good afternoon, everyone.
So how would you manage the case?
Sir, this is in my hands. I think this is a failing battle. No matter whatever we do, in long run, this patient is going to come back. We do a deformity correction. The patient may have issues with that. We do only decompression. Patient may still have issues with that. So in my hands, I think we have to sit down with the patient and discuss all the pros and cons of only decompression to begin with, that which is the side where I would want to err. However, before even doing that, in such patients, I think if I have to go with multiple root blocks, I would not be hesitant to do that, because a listhesis at 4-5 with a stenosis which is not so very bad and recent onset symptoms in such patients at this age group, I think root block does really helps a lot. So root block to begin with, if it doesn't settles the pain of the patient, discuss with the patient about pros and cons of pure decompression, and I would only opt for tubular microendoscopic decompression for this particular level. Having said that, patient should be informed that the chances of listhesis progression stand from 13 to 30% in such patients where listhesis is only decompressed and not fused. So that chance the patient will have to take.
Yeah, thanks, Vishal. Is Appaji there? Or Dr. Pradyumna?
Pradyumna is not there. He has got some.
Fine. Rupinder, would you want to take this? Would you agree with Vishal or would you differ?
Root block, I don't think, because I think it's more of a stretch pain along with the compression. So I would try to do a decompression and see intraoperatively if it's because this in such gross deformity, even stress films would not give you a great idea instability component. Intraoperatively, if I see the facets are too loose and if I'm trying to decompress it and damaging them, I would just decompress and fix this single segment. But if it is stable, and I will just do a little bit of decompression over the top and come out.
Guru Raj, do you agree with this?
Actually, I agree with both Vishal and Rupinder. Root block always can be tried. How much it is going to be effective, that is again a big debate. I agree with Rupinder also. Mainly, it looks like a more of a structural problem and a stretch pain rather than a compression there. But then what we have to look at it is the lateral listhesis, which is at the apex at the thoracolumbar junction. So this is the sign that this is going to progress. And if we do somewhere around that area, whatever you do, minor decompression also, and you go ahead and take away the 1/3 of the facets also, it can slip. So as Vishal said, we have to be very vigilant and talk to the patient. What is their main aim of treatment? If it is only pain relief, that also only the leg pain, then simple decompression will suffice. But then the matter doesn't end there. They are going to come back definitely for sure. And we have to be ready for the second surgery for this patient. Because it's a kind of an adult scoliosis rather than a degenerative scoliosis. This is a scoliosis which was there and then which we are addressing it right now.
Shailesh, your last word.
I think I agree. And if the patient is with symptoms not getting better, persistent, root block probably will help therapeutic as well as diagnostic. We can try that once. But maybe unilateral decompression for the leg, which is painful, can be done with over the top decompression for the other side, keeping the midline intact, because there are chances of progression if you do a laminectomy at 4-5 in a degenerative scoli in lumbar spine.
Okay, Shumayu.
Yeah. My decision making was made a lot easier by the patient herself. She was a doctor's wife, is a doctor's wife. So, and she had traveled all across the country looking for a treatment. So she knew all the options, and they came to me with a very clear thought that we will not undergo anything where implants are involved. So decompression was the only option, and their only question to me was, could it be done minimally invasively? Because they understood that the spine is in a very precarious position, somehow maintaining its stability, and nothing should be done to destabilize that. So I went forward with, after counseling the patient in detail, obviously. So I went forward with the L45 MED, and I did this from the right side. So this is the ipsilateral decompression. Starting itself, usually when you do a ipsilateral decompression, the angle is about 20-30 degrees. But because of the scoliosis, we're starting at 40 degrees. And for the contralateral, the angle was a lot more. And I'll share a small 1-minute surgical video clip. So this is after
before
docking
you go ahead, Shumayu.
Yeah. Yes, sir. Yes, sir. Please tell me.
Go ahead, Shumayu.
Yeah.
I think we've lost him.
I think we lost Vishal, sir. Yeah. So we're docked on the right side. This is the right side is the cephalic end. The left is the caudal end, and the facet is on the lateral side of the tube. So we're boring just under the spinous process now. So I was very particular to make sure that we don't destabilize, remove any facet, or and this is after the bony work is done. So you can see the ligamentum flavum from contralateral to ipsilateral, and the central part is in the middle. So through and through. And
So
then
may I comment on this?
Yes, sir.
Dr. Chabra, sir, if
Yeah, go ahead.
So two things, sir. I think we all know that tubular decompressions, they have a tendency of creating some amount of facet damage. It's a known fact. So if at all, as I was on for only decompression, I would have rather done it from the convex side, from the contralateral side, rather than on the same side. And the decompression of the contralateral side would have been easier, because doing it from the convex side would actually take less amount of bone. It would be far more conducive and ergonomic to yourself. And doing it from the concave side, where the pain is on the right side, the facet is already subluxated. So in such patients where the facet is subluxated, I would do it from the side where the facet is more intact and broader, and it usually is a convex side. So that is just one small tip that I would have done differently here.
Yeah, Vishal, the other thing is you can always decompress a foramen better from the opposite side.
Exactly.
So that is the other point on it.
So my take would have been from the opposite side rather than from the same.
Your take on it, Shumayu?
Yeah, no, I think that's a very good point. But traditionally, whenever we go in from the more symptomatic side, so I didn't view it from that point of view. I thought if the right leg symptoms are more, let me go in and at least make sure that the right root is decompressed properly under visualization. And that was my
you can easily do both.
You can do both, yeah.
Easily.
So here, the contralateral side is the left side. And as you can see, that side is completely decompressed. So as I was saying, of course, you can do both from one port. And then once that was done, proceeded with the ipsilateral decompression. And as already predicted, the ipsilateral decompression was tougher because the thecal sac was pressed against the pedicle, but I used an 18 mm tube to make sure that I damaged the least amount of facet joint. I have to take out the least amount of facet joint possible.
So it is the angle that you get to reach the foramen, which is also important when you go from the contralateral side.
This is her post-op, and surprisingly, even though I gave her a guarded prognosis, she actually did quite well. It's been 1.5 years now, She's still comfortable. She has back pain, which you would expect. But that was not the main issue for her to begin with. Her ODI is 34, and she can walk. She doesn't do much. She travels a little bit and participates in household activity, and she's happy with it so far. So I think the take home would be not to destabilize the spine, to keep the midline and the facets intact, and as already said, maybe a minimally invasive decompression, preferably from the convex side. But I did it from the concave side because I didn't have the hindsight with me. Thank you.
Abra sir, can I ask a question?
Yeah, sure, Ajay.
Sir, I just wanted to ask the people who do tubular and who do microscopic decompression using a McCulloch retractor and over-the-top decompression, how different it is in terms of destabilizing the spine, in terms of the multifidus core muscles, etc., and in terms of decompression. So simple. One question is tubular decompression versus decompression with a microscope and a McCulloch retractor over the top.
So, Shumayu, would you want to take?
Yeah. See, if we're talking about the bony work is same in both, because whether you're using a McCulloch or a tube, you're saving the midline and you're not removing more than 1/3 of the medial facet joint. So the bony work is the same. Now, the advantage of the tubular dilators is you're dilating the muscles as opposed to releasing them from the spinous process. And I think that is a subject each one has to debate about, whether releasing few multifidi muscle fibers from the spinous process has any significant advantage as opposed to putting a dilator and splitting them. But the rest of the surgery is exactly the same. I personally don't think that the difference is huge, but contralateral work definitely becomes easier when you're with the tube, because then the tube gives you the angle to go over to the other side. With a McCulloch retractor, I think you would have to have someone holding the retractor and pushing it down so that you can get the visualization required.
I think we are running late, but Dr. Girish Datta, would you want to add to that?
Yes, with interlaminar endoscopy, a contralateral approach in this patient would have been just apt. We could have used the 8mm system here from the contralateral side and go sublaminar. Rather than taking off the whole lamina, we could have done a complete sublaminoplasty and decompression of the lateral recess as well as the foramen on the contralateral side. With endoscopy, it's going to be much more easier.
Any last word, Shailesh?
No, I agree. Basically, how much less soft tissue dissection you do, that's important, and how much bone you sacrifice, that also will decide in such situations. You use tubular or you use McCulloch, makes no difference.
I thank Shumayu. That was a great case, a great take-home message. It is always healthy to differ, but what you did had a great result. So it's only a question of matter of fact, which side are you more comfortable with decompressing with, but you had a great result in this patient, right? So wonderful case and a wonderful take-home message. So let me now request Dr. Mayur Kardile to present the third case.
Is my screen visible?
Screen is visible, but we can only see the zoom. Yeah.
Now?
Yes.
Yeah. Just a moment. Yeah. Is it visible now?
Right.
Yeah. Thank you. Thank you very much for this opportunity, Sancheti Hospital, the Spine Weekend team, and the illustrious faculty who's all over here. So my case is a patient with a fixed coronal plane lumbar deformity with multi-level foraminal stenosis and osteoporosis. So she's a 75-year-old lady, very active, had quite significant back pain, bilateral lower limb claudication since 6 months. The claudication distance was 10 minutes, but recently pain had increased to quite a lot of extent. The pain was mainly in the right calf and left thigh on the anterior aspect. The pain aggravates on walking, and now recently she also started complaining of pain while sleeping. VAS for the leg was 9/10. She had osteoporosis. T-score at the femoral neck was -3.0. No response, absolutely no response to conservative treatment with pregabalin, gabapentin, anti-inflammatory. And just that she had this pain while sleeping also, I suspected neuropathy. So got an NCV test done, which showed it to be more of a radicular pattern rather than a neuropathic pattern. And this was her X-ray. On the AP view, you can see a coronal plane deformity, 40 degrees of lumbar scoliosis to the right side, a fractional curve to the right side. And fortunately, the sagittal plane alignment was pretty good. She had a lumbar lordosis of 55 degrees and pelvic incidence of 50 degrees. So no PI lumbar lordosis mismatch. So got an MRI. The dynamic X-rays show grade 1 instability, subtle listhesis at L5S1, and quite advanced end-plate degeneration at L2-3 level. Now, this is the MRI, the right parasagittal images, which showed significant foraminal stenosis at L4-5 and L5S1 level. And on the left side, there's significant foraminal stenosis at the L2-3 level. And rest of the canal quite capacious, no central or lateral recess stenosis, except for some lateral recess stenosis at L4-5 level. And of course, fluid-filled facets at L5S1, which justify the dynamic listhesis that she was having.
Mayur, can you just go to the X-ray? Is it a lysis at L2?
No, sir, no lysis. So this is the X-ray. Yeah.
Okay.
It was a degen problem. So basically, you have a right side lumbar scoliosis. You have a fractional curve and foraminal stenosis at right L5S1. Again, foraminal stenosis at right side L4-5 and foraminal stenosis at left side L2-3 level. And osteoporotic patient.
How was the clinical disability?
She was in significant pain. She was like, for the past 10 days, I'm not able to sleep because of this pain. I'm okay while I sit, but the moment I stand and walk or the moment I lie down, I get this severe pain in my calf.
She must have taken a lot of treatments before.
Yeah, she had been all over, all kind of medical treatment, root block, caudal block, but nothing helped for her. So now, how would we want to go ahead with this?
So, Vishal?
Again, sir, I think the first in patients with such age group where age in itself is an independent factor of morbidity and deformity is there, these I personally consider them as a losing battle. No matter what we do, the chances of them coming back within 5 years for adjacent problem is always high. And that is why to start with the most minimalistic approach is the first thing that I would do. And not only therapeutic, but also diagnostic way to ascertain the exact cause of pain. I think root block is the first thing, and try to delay the surgical venture as far as possible.
Mm-hmm.
So that is the first approach I would do, sir. If that comes across, may I see the MRI, Mayur?
Yeah. So this is the right and left side.
Yeah, and axials. So targeted block on the side. I think here L4-5 seems to be the only thing that seems to be worrisome.
Mm-hmm.
Other than that, I think deformity doesn't draw too much attention in my hands. I'm not very deformity person in adult cases, particularly at this age group.
Okay.
There are so many other challenges that to be taken care of while managing deformity.
Mm-hmm.
So I think my approach would be minimalistic, targeted 4-5 to begin with root block. If I am asserted that the pain is coming from there, then.
Thanks, Vishal. Rupinder? Is Rupinder there? Shailesh?
Yeah, I also want to understand how bad is the clinical deformity. That's one. How bad is her sitting pain and back pain? Because at times you realize that this looks subtle, but there can be a significant deviation of the pelvis and torso, and those are the cases which are challenging.
Yeah. See, honestly,
if it is neutral, then I will prefer to go with maybe decompression in the lumbar segment. Root block can be given just for the can be tried. There is no harm in doing it. If you are lucky, you may get out with some time. You can get better and do some rehab. But decompression probably will get the answer for this.
The root block has been tried, right, Mayur?
Yeah. She had a root block.
Okay.
Don't know the levels was done elsewhere, but she said that she just had relief for a couple of days and then the pain was back again.
And Mayur, do you have a sitting X-ray? Because this is standing X-ray.
Yeah, these are standing X-rays. Sorry, sir, I don't have sitting X-rays for her.
So then there can be a dynamic deformity. Yeah.
So honestly, like
I think Shailesh, I would actually rely on standing X-rays in spine deformity more than in sitting flexion extension.
You need both.
So here, I think
you need both.
Yeah, of course. But I think the standing X-rays would give me a better about the collapse of the deformity and lateral listhesis. In deformities, I think lateral listhesis makes so much more decision-making changes than pure per se flexion extension. Also in deformity, I think
compensated. If you sit, then it's lateralized more. So if you're standing, it gets compensated. Therefore, sitting X-ray is important, isn't it?
Yeah. So honestly, her problem was not a deformity. She was well okay with the kind of deformity that she had. The leg pain was much more pronounced than the back pain. So, but however, when I go through this, like of course, I would love to do a decompression for these patients, but what I would be really uncomfortable with is having a asymmetrical disc space collapse at L5S1 and L4-5, wherein the nerve root gets trapped between the pedicle and the superior articular process. So that's kind of a bony problem that they have. And in my hands to really get that nerve root decompressed, I either have to jack up the disc height or I have to do a facetectomy to release the nerve root. So that is where I was leaning into this. So
I think we are running short of time. So unless anybody has any suggestions, but I would want to know if the patient had anterior thigh pain or not.
Yeah, she had left side anterior thigh pain.
So fine. So left side anterior thigh pain as well. Guru, quick comment. So go ahead.
Yes, sir. So if it is left anterior thigh pain is there and it is also significant, then the things become complicated. Basically, then you would want to do a diagnostic block. Even if the block has been tried before, I won't actually just rely on that. I would do a diagnostic block in a staged manner and then exactly assess where is the pain coming from. And basically what happens is with the anterior thigh pain, decompressing a higher level becomes little tricky with the deformity because the pars is very thin. You need to study your CT scan very properly and then take a decision. And whenever you try to do just a decompression, keep a fusion option ready and explain to the patient and keep it. Otherwise, you decompress, you just come out, then the pain might increase rather than decreasing. So you have to explain the patient that you are trying this procedure, but then you might end up having a fusion. So assess them properly, do diagnostic root blocks, and then take it further from there.
All good. Yeah. So let's say now, honestly, I was leaning more towards the fusion for her because of the mentioned reasons of foraminal stenosis. So if you're on board for a fusion, would we be accepting more of anterior approach or a posterior approach, the A-lift, multi-level A-lift, or a posterior T-lift approach?
So in this case, Mayur, because the sagittal alignment is maintained, I would do all posterior MIS.
Exactly. That's a great point, sir.
Because
yeah, she had a beautiful lordosis. There was no PILL mismatch. So yes, the posterior approach would be the preferred approach for her. And how many levels?
Yes, if I am fusing, I'll fuse everything. Otherwise, I will do just decompression.
So everything in the sense, like, would you start
from L1 to pelvis?
L1 to pelvis. Great. And then any strategies to deal with osteoporosis, strategies for sacropelvic fixation, and how to mitigate the risk of PJK? Because when we are doing all these adult deformities, that is the biggest thing that we need to look for or try to mitigate is the risk of PJK. So these were all the thought processes that were going on in my mind. So finally, I ended up doing a L1 to S2 alar iliac fixation, along with now going on it one by one. I did a fixation because I was worried about the foraminal stenosis. There was fractional curve on the right side, so I did a right-sided TLIF at L5S1 and L4-5, jacked up the disc height, freed the nerve roots over there, and then from here above onwards, above L4, I've kept the midline intact. There was foraminal stenosis at on the left side at L2-3, keeping the midline intact. Just did a left-sided facetectomy, jacked up the height over there, balanced the spine, and then fixed from L1 to S2, S2 alar iliac screw. Now, for mitigating the risk of pullout, first thing that I've done is used a corticocancellous screw construct and did a vertebroplasty or cement augmentation at UIV. And yeah, the sacropelvic fixation, S2 alar iliac screws are the strongest hole that we can get in the spine and have a firm base for fixation. So that was the reason of using the S2 alar iliac fixation and mitigating the risk of PJK. Can I go ahead?
Yeah, please.
Yeah. So mitigating the risk of PJK, I've kept the midline intact, kept all the supraspinous and interspinous ligaments intact above L4. And I have also done a prophylactic vertebroplasty at UIV+1 to prevent adjacent segment fracture or have a osseous decompensation or a osseous PJK. So these were the things that I looked for into this. Yeah, Dr. Gururaj wanted to say something about it.
So the only one thing is this prophylactic vertebroplasty, how much it is going to help, we are not really sure, because see, if your cement is superiorly, usually when the fracture happens, it will happen at the inferior end plates when the PJK happens. So actually, when you do this prophylactic vertebroplasty, you are again pressing this inferior end plate between the cement and the lower rigid segment. So I'm not sure how much it is going to help. But then the rod bending at the proximal most segment, I would keep it a little bit kyphotic.
Yeah.
The rod. So I won't go it like a harmonious lordosis. So basically, if you make the upper portion rod a little bit kyphotic there, that will help maybe in preventing the PJK.
That's a great point, sir. So I forgot to mention that, but yes, I did a slight kyphotic bend at between L1 and L2. And I think we can see that on the X-rays. So that's a very important point, not to stress the UIV while we put in these rods. So let it just sit there without any stress.
Post-op, Mayur, how did she do? Can I ask?
Oh, yeah, she did very well. Like on the second day, she was ambulating well. So I'll quickly take you over that. Now reassessing the parameters later, we got a great correction on the coronal plane. We got a great correction on the sagittal plane. Now, very interesting to know over here is that PI does not get changed. That's a constant parameter. The lumbar lordosis from 55 degrees went to 40 degrees with the posterior procedure. So in my hands, I don't know, but posterior procedures are always kyphosis inducing procedures. So had this patient been a hypolordotic patient or with a straighter lumbar spine, I would have erred more towards going on anterior procedures to reconstruct the lordosis.
Actually, it's better your lordosis decreased a bit. It's better. It will prevent PJK actually.
Yeah,
absolutely.
Yeah. So yeah. So and this is her just 3 days post-op, walking around, no issues. And yeah, this was a video, not playing though. Yeah. So mobilized on second day, third day she was quite comfortable, and fifth day she went home. And this X-ray is about 1.5 months post-op. So I've operated her about 2 months back. We still need to see how she does moving from here. But absolutely no leg pain, no back pain now. And I've kept her on teriparatide therapy to build up her bones. So after 2 years, I'll just move her on to maybe oral bisphosphonates or maybe olimab to keep her bones strong.
I think we are running late. We'll need to move forward. That was a great case, but I would only want to ask the panelists their views. We have had 2 cases, one where there was a selective decompression done, another where there was fusion along with it. How do you decide, for the benefit of our participants, how do you decide when to go where? So let's start with Vishal.
I think there are multiple factors in my practice I would consider, but the most important factor is counseling.
First, would you fuse this case or would you selectively decompress?
No, I think, as I said, sir, only root block to begin with, and if anything is required, localized decompression and probably short decompression, short fusion.
And what? Yeah.
And why?
So
why?
short,
Because there is a
fusion,
reason
so,
to it.
yeah.
Yeah.
Why? So what would your indications for fusion be in such cases?
So long segment fusion in my hands, sir, the only reason I would do a long segment fusion all the way to D10 is when I see a deformity which is collapsing, where there is a standing X-ray, as I said, which on lying down is better, but it is collapsing. And the segments are just sitting one or another with lateral olisthesis and deformity more than 40 degrees. So deformity more than 40 degrees, a collapsing scoliosis, and deformity which is multi-segment going all the way crossing thoracolumbar junction are the only cases with lateral olisthesis. All these factors together should be the only ones where I would do fusion. A stable scoliosis less than 40 degrees, one segment as the cause of symptom, I think I would do a localized decompression and fusion.
And what would your indications be for selective fusion? You said for selective fusion, what would your indications be, and when only decompression? Yeah, Vishal.
Me, sir?
Yeah.
So again, sir, so proven instability, like in this particular case, why I want to do a localized fusion is because the disc is tall, the facet is subluxated, and I feel that even if I do a only decompression, because of the disc height being very, very tall and lateral olisthesis noted, asymmetrical collapse, the chances of this listhesis at that particular level progressing is very high. So for the case what Shomayu showed, where the spine is already stabilizing, even a subluxed facet, only decompression from the opposite side should help. Whereas a patient with tall disc height, subluxed facet, where my decompression is going to take down a bit of facet with a tall height, I think I would do a localized fusion there. And again, as I say this, sir, I come to and firmly believe that the reoperation rates at 3-year, 5-year, and 10-year in pure decompression, small decompression, small fusion, and long decompression, long fusion is the same. So reoperation rates is the same in all three, and that is why I would start small, and if at all required, I would do big at a later date.
Yeah, Rupinder, would you tend to differ? Any quick points if you would differ from this? I think we may have lost Rupinder. So, Shailesh?
I agree what Vishal is saying. You have to be very selective because there are chances and problems in any which ways when we consider deformity correction. But the patient's demand also we have to keep it in mind. At times, some patients are very selective and they want a complete job to be done. And at times they confuse us also. But I will say less is more, if at all. That should be a safe bet in patient treatment, if at all.
Mm-hmm. I think the first and foremost need is counseling the patient, talking to them, telling them about all the options available and what you firmly believe will be the best for the patient.
Yeah. Thanks. We can go on and discuss on this. These are areas where we can have points and counterpoints on either side, but then the world is moving now gradually towards more selective fusion in adult degenerative scoliosis, trying to do less. But this was a wonderful case, and I think we had a great message for all the participants. Do you have a final carry-on message, Dr. Mayur, or can we?
Yeah.
Yeah.
Yes. So now I would just my thought process about why going all this long is that definitely if we do a selective fusion at L4-5, we're kind of closing very close to the apex, and then again at the apex we again have a foraminal stenosis on the other side. So that was the thought process, that I did not have any option rather than going into all this long segment fusion for her. But yeah, wherever it is possible, wherever you can, just do minimal, try to decompression better than fusion. That would be my take home message. But my deciding factors would be the foraminal stenosis and of course the buckling of the spine, if at all that was there. That would help me or more towards the fusion side.
So great cases, I think. Thank you, Dr. Mayur. We need to move on. We have had some great discussion. So we will move on to video presentation by Dr. Girish Datar on endoscopic discectomy dilemmas. Over to you, Dr. Girish.
Thanks a lot, Chabra sir. And I'll share my video now. Hello, everyone. Thank you for giving me this opportunity to speak on this platform. Today, I'll be speaking on interlaminar full endoscopic discectomy, why and how I do it. Before we see why we do it, we will first understand how this surgery is performed. This is a representative case, a 42 years old male agriculturist. His history of pain in the left buttock and left lower limb since 3 months. Pain has increased since 8 days. He's unable to walk, has difficulty in urination since last 2 days, and constipation since last 2 days. Neurologically, his left EHL is grade 0. His right EHL is grade 3. Bilateral ankle deep tendon reflexes are depressed. He has saddle anesthesia and patchy loss of sensation in both lower limbs. If you see the sagittal section and the axial section of the MRI, you see a large herniation at L4-5, which is extending cranially as well as caudally. So it's an inferiorly migrated and superiorly migrated herniation. The herniation is grade 3 and predominantly located centrally and bilateral paracentrally, predominantly on the left side. If you see the X-rays, there is a list, and the level of the iliac crest is at the level of L4 vertebral body. Now, the patient position is in prone position on a radiolucent table with fully prepped and ripped. An image intensifier free mobility is essential in this. Now, most important here is you would mark your docking point on the image intensifier, based on the image intensifier, and once marked, you would infiltrate the skin and the subcutaneous tissue and the muscle layer with some diluted adrenaline so that you have a bloodless field when you are making your incision. The lateral drape is important here because the image intensifier is going to stay in lateral throughout the procedure for you to guide in case you want to know your location. You make an incision of about 7 to 8 millimeters and then dilate the soft tissue with the help of a small mosquito, and then you may introduce your dilator. Over the dilator, you would introduce your working sleeve to dock at the right place on the cranial lamina. Before you put in your endoscope, this procedure is performed under constant irrigation, normal saline irrigation. So you would adjust all the draping in such a way that you maintain a sterile field, and as well you are able to collect all the water that is drained out during the procedure. The first thing when you put your endoscope, you encounter is the extraspinal soft tissue, which is attached to the cranial lamina. So you would first take off all this extraspinal soft tissue, which is absolutely essential. Also secure all the bleeders in the extraspinal area so that you don't encounter bleeding in the later part of the procedure. So all the soft tissue which is on the lamina and at the base of the spinous process needs to be removed for you to understand the gross anatomy. You commence your process of laminotomy by starting from the inferior articular process. So trimming the part of the inferior articular process medially, proceeding ahead with the cranial lamina and going towards the base of the spinous process. So the extent of bony decompression is going to be based on radiologically as well as intraoperative findings that you have the attachment of the ligamentum flavum. You would then start with your Kerrison bronchus to do the remaining part of the laminotomy and trimming of the inferior articular process. Sometimes in the process of doing a laminotomy, you may encounter some kind of bleeding. So your diamond burr is handy. You can also use bone wax to stop this bleeding. You would continue doing the burying the base of the spinous process for you to have a contralateral access. I prefer to do it before I open the ligamentum flavum, and that is that is useful because then you are able to protect the thecal sac from inadvertent injury. So till if you once you have drilled the cranial lamina till the attachment of the ligamentum flavum, you would want to detach the ligamentum flavum from the cranial lamina and strip it off completely. In cases where the herniation is not so large, I don't prefer to open, I don't prefer to remove so much of ligamentum flavum, but just make a small slit in the ligamentum flavum or just do a limited phlebotomy to get into access into the epidural space. But here, since the herniation is pretty large and extending cranially as well as caudally, I would do a wide decompression so that when delivering the herniation, I don't inadvertently injure the neurological structures. Now, the Kerrison ronges in endoscopy are different variety. They are made of very thin foot plates, so you are able to gain access directly into the lateral recess to identify the lateral edge of the neurological structures. So here you can see that I'm decompressing more cranially as well as caudally to identify the lateral, define the lateral margin of the neurological structures. So once you have identified the lateral margin of the neurological structures, I would use a dissector. To gently retract the tissue, neurological structures medially. So you can see the herniation is extruded, so it just pops out. So very gentle removal of the herniation is done. Here you can see the herniation coming out. So once the major part of the herniation comes out, then you would concentrate more on the cranial and the caudal migrated parts, and you would use a kind of a nerve protector, retractor, to remove the remaining part of the herniation. This is the cranial part of the herniation after retracting the neurological structures. I would also do it for the caudal migrated part. Now here in the caudal migrated part, you can see a large herniation at the base. Now before I remove this herniation, I would ensure that I have a good bloodless field in the lateral recess. So I use a radio frequency to secure all the bleeders in the lateral recess. We gently dissect out the neurological structure from the herniation because there is a chance that it may be adhered. And then gradually, I use the nerve retractor or neurological retractor to gently manipulate the neurological structures, and you can deliver the herniation. So once all the major fragments are removed, then you would concentrate more on the smaller fragments, osteophytes, and the intradiscal part of the herniation, which are loose fragments. So you can do the discectomy and also modulate the annulus with radio frequency device. So once you have completed the entire decompression, you would confirm by seeing the contralateral. You can see the root on the contralateral side. You can see the ipsilateral decompression. And this is the decompression ventrally in the midline. You can see the root here. The axilla is pretty caudal here in this case, and you can see a good pulsating thecal sac. Now we come to the question of why we do an endoscopy or why we do an interlaminar endoscopy. Now there are a couple of reasons why we do interlaminar endoscopy. So I would classify these advantages in 3 different categories. One is technical reasons for the surgeon. So it's ease of operating in the depth, has superior visibility because of constant irrigation, as well as the high definition systems or cameras. Limited bone resection can be performed, just what is necessary. This does not void the facet joint, has a shorter operating time of 55 minutes. In this case, you usually have it about less than 1 hour. The contralateral access is easy as compared to other minimal invasive surgeries. The advantages for the patient is it's a single incision, which is paramedial incision. It's sutureless surgery with no minimum to no blood loss. There's no pain, minimal to no pain after the surgery. Usually patients stay overnight because these patients are operated under regional anesthesia. So prefer to keep them overnight. And the patient will be able to resume active lifestyle soon with rehabilitation or exercise program. The price for this surgery is comparable to open surgery, as amount of consumables, anesthesia, and hospital stay much less. And the technical advantages of endoscopy is that you don't do muscle dissection, it prevents secondary instabilities, and it's an advanced methodology for the patients. Hope I'm able to throw some light on why interlaminar endoscopy is useful and how it is performed. Thanks a lot for this opportunity again, and thanks a lot for your attention. Thank you.
Thank you, Dr. Girish Datta. Any quick questions before we move on to the talks? So if there are none, if there would be still be questions, we could take them at the end after all the talks. I believe there's a slight change in schedule. We will have Dr. Vishal Kundnani now presenting on how to deal with unhappy lumbar surgery patient. Dr. Vishal.
Thank you, sir. Thank you for accommodating Shailesh. And I hope my slides are visible.
Yes, very much visible.
So slight change not only in schedule, but also in the topic. Rather than dealing with a broad topic of how to deal with an unhappy patient, I'm probably going to come up with a more commoner scenario where the unhappiness is restricted to one pure cause called infection, surgical site infection. And I'm going to be presenting some slides on this to highlight the dilemmas and challenges that one and all face while dealing with a post-operative infection. Like in this particular case scenario, a 47-year-old male executive obese guy with symptoms requiring a surgery, underwent a surgery, decompression and fusion at 4-5. And on day 3 post-op, while you go on the round, patient's symptoms in the leg have improved. There is mild to moderate back pain, no fever, and mild inflammatory symptoms are there. However, there is soakage. The whole dressing is wet, and you find plenty amount of serous discharge, which is not a usual scenario. So, Dr. Chabra, what would you, how would you approach such patients with 3 options available? Wait and watch. It's definitely infection, go for higher antibiotics, or it is surely infection, explore and debride.
I would try to evaluate the patient, see the counts, go in for a culture, but I would have a very low threshold to debride if there has been an instrumentation there. But if the counts are fine, patient doesn't have any toxic symptoms, I could also observe for a day or 2 and then go ahead. But the threshold for going in for exploring and debridement will be quite low. So I'm expecting.
Thank you, Dr. Chabra. I think the crux of this talk is having an absolutely low threshold to be aggressive to deal with such cases. Even if it is not infection, you will do no harm by opening and debriding the patient. However, you will do so much more harm if you do not have that low threshold what Dr. Chabra just highly mentioned about. And this is the crux, and that one single point that have absolutely low threshold, have a very high index of suspicion when you're dealing with post-operative infections, that every soakage can be due to an infection which is inside there. And unless and until patients, you are aggressive enough to deal with this, you will be probably dealing with disasters at a later date. So these are the cases where we often tend to have questions about, do labs really help CBC, ESR, CRP in the first 7 days? They probably have no immediate value, at least not as a single point of investigation. MRIs actually have no value to differentiate between post-op edema versus infection, and stepping up antibiotics probably may or may not help you. And that is something, these are the commonest things that we all do. But one thing that we always shy upon is whether to explore or not. Probably this is something that we are going to be discussing about. And all these questions and dilemmas, whether to take a swab and start higher antibiotics or explore and debride right now, is the question that we often come up to. And these questions, whether lab parameters have any reliability or not, is what we are going to be dealing with here. Surgical site infections, they are not uncommon. More than 1% patients where you do instrumentation, 1 out of every 100 surgeries that you do, that means every year you'll be probably dealing with 2 or 3 such cases in your practice where instrumented cases would get infected. And this is something that comes from a meta-analysis that almost 2% patients would have infection, some superficial, some deep, and infection is something that you should be really ready to deal with. And this talk is probably to get you a value of ethical practice in post-operative infections. We also know that post-operative infections can not only alter the outcome, but the outcome can actually become worse if not dealt with optimally. And also when the post-operative infections are dealt with optimally, the results can actually be like any other case where infections have not happened. And the dilemmas, how do we prevent surgical site infections? How do we diagnose surgical site infections? We know that early intervention is required, but whether the soakage is due to infection or not, and if there is exploration, should we retain or remove the implant? And if we did a debridement, should we do a closure primary or delayed or with a VAC, is something that we would always have questions in mind. So let us deal with them equally in one by one. I think the first strategy to infection is prevent it. And how do we prevent post-operative infection is know the risk cases, be very well prepared to deal with these risk factors, have absolutely ultra clean aseptic precautions, and tailor make the prophylaxis. You cannot give antibiotics of one type to all and cover it like a blanket prophylaxis to all. You have to tailor make it. And in fact, there are recommendations that doing a nasal swab pre-operatively, like joint replacement guys do, to see what kind of bacteria do they have MRSA or not, and tailor make those prophylaxis before the surgery is something that is very important, and step up the intraoperative measures, particularly in patients with risk factors. We are all very well aware about the risk factors in surgery which can lead to infection, but something that we all must pay attention to in current age is the body mass index, which is in itself independent risk factors, and this is something that has led to more number of infections than all the other risk factors kept on one or the other side. And this is something that you must counsel your patients and be prepared to deal with. Any patient with higher body mass has a higher risk of surgical site infection, and you should be doing far more control measures than any other case scenario. Another thing that I routinely do is to check proteinuria. So all patients with diabetes may not be having risk factor, but patients with diabetes having protein in urine, this is something that we may always try to find out pre-operatively. If any such patient has proteinuria pre-operatively, you may want to hold the surgery, control this, and only then move ahead with the surgery. Again, aseptic precautions in OT is a standard, and I'm sure we all have been following this. If not, please follow all these technologies that are already available. Something that comes very, very handy is the most effective way of preventing post-operative infection that has already been studied, even in Indian papers. That has proven that it is better to have betadine irrigation. Of course, intra-wound vancomycin is there, but when compared between the two, betadine irrigation has been found superior. So in all patients, wherever you find more than one risk factor that is present, try to have betadine irrigation, all such patients. And of course, if you feel that the risk factors are more than 2, I would actually combine it with betadine irrigation followed by intra-wound vancomycin powder application. So these are the things that will help you to prevent post-operative infections in all such patients. Despite this, sometimes you may still meet patients like this where you have already followed all these preventive measures, but you still feel post-operative soakage is still present. In such patients, it is extremely crucial to diagnose infection extremely early. Now the question is, how do we diagnose them early? This diagnosis and management early or being very aggressive depends on purely 3 factors, which is clinical, laboratory, and radiological. And 90% of emphasis in diagnosing infection is not on lab or MRI or PET-CT scans, but it is purely on clinical scenarios. And that is purely based on one thing that Dr. Chabra highlighted, to have a very, very aggressive mode of approach or a low threshold for infection, because the moment you diagnose these early, you can actually prevent any kind of aggressive surgery at a later date. In fact, it has been proven that early diagnosed postoperative infection, 90% of these cases you can actually retain the implant, and you can actually enhance the fusion rate and achieve primary closure, which if delayed diagnosis comes across can be a bigger problems at a later date. And so early detection and diagnosis is something that guides you to have early intervention. And for early diagnosis, something that comes handy is clinical signs and symptoms. And what are the clinical signs and symptoms that comes handy to you? I think the few things that should raise extremely high suspicion is disproportionate and progressive pain postoperatively, which otherwise you know that postoperative pain is there, but sometimes the pain may be really severe. You've done a discectomy and patient complains of severe back pain. You know that you're probably dealing with some kind of infection in there. Progressive neurology or delayed radiculopathy happening, suspect infection in such cases. And of course, wound leakage in the form of pouring pus is an obvious sign of infection. Don't shy away from opening these cases immediately. Any systemic sign of fever or any systemic sign of erythema, peri-incisional erythema is something that again should prompt you to be very aggressive and going and doing a debridement and wash in such patients. The alarm signs are, of course, fever, severe pain, angry looking wound, and high counts, which otherwise usually don't get elevated postoperatively. These are the things that you should be very alarmed about and be aggressive to go and open and debride such wounds. For other cases where only discharging wound is there, a midline path of observing such patients for a couple of days more, where if the wound settles down in a couple of days, I think hold on with the approach. However, if the wound keeps discharging from the wound, something you should think of going in ahead. CBC, ESR, CRP, they have proven to be of very less value because CRP tends to be high for at least 14 days after the surgery, and postoperative values have to be measured in sequential manner to see if there is an uptrend. If there is an uptrend, you know that you are dealing with an infection. But for a single phase ESR, CRP do not have any diagnostic value in diagnosing infections because they can easily be elevated in postoperative phase. So is with MRI, that postoperative edema is very common. So MRIs may not be able to differentiate between a postoperative edema versus the infection, and that is why the diagnostic value of MRIs in diagnosing infection is very low. Even in patients with aseptic postoperative discitis, you may still see some changes in the disc area. So MRIs may not be diagnostic. And the few things that MRI may categorically tell you that this is infection is erosions in the end plate, which otherwise don't happen in aseptic cases. Intraosseous foci, like you can see one here, can again be a sign of infection, again focusing and telling you that you better be aggressive at this date. Otherwise, you'll probably be leading to more soft tissue collection and destruction of the end place, requiring a far aggressive surgery. PET-CT scans have proven to be of value in diagnosing early infections, even in patients when there is no discharge at all with persistent pain in such patients. However, it's not something that is resource friendly in most centers across the India. However, this comes handy when you are suspecting that the symptoms are not settling, or patient has low-grade fever, or patient has persistent pain, or infection can be there, which can be picked up on PET-CT scan, differentiating it from post-operative changes. However, early diagnosis based on clinical symptoms is something that will always come handy to you. And I think having a low threshold is the one thing that you always must keep into mind. Now, coming to what kind of infections you may deal, you may be superficial, deep, or systemic. A systemic wound is one which requires aggressive debridement and repeated debridements, and never do a primary closure in them. However, for superficial and deep ones where they remain above or below the facial panes, a primary closure can easily be achieved in such patients. Just moving on to the more dilemmatous situation, whether to remove implant or retain the implant. I think if you have dealt with it early in the phase of infection, then you can easily retain the implant, because the presence of implant may not lead to persistence of infection if you have debrided it early and adequately, whereas removal may be required if you find that during your debridement the implant is already loose, or if you have come in late. And in fact, it is recommended that you must always remove the implants if they are in place, if you did a late diagnosis, or if there is a delayed infection which comes 3 weeks post-surgically, and if there are multi-level implants along with pseudoarthrosis. These are the implants which you may want to remove. When to close, how to close in such patients. I think primary closure is always recommended when you are dealing with all the patients early in the phase of infection, and in the patient where there is only a superficial infection. However, in patients with systemic disease, primary closure is not recommended. And in fact, patients with toxic signs of fever or sepsis always try to only debride, because you may have to commit again. And I think VAC dressing is something that is recommended, particularly in patients while debridement. If you feel that you've created a bigger defect or there is already signs of myonecrosis, closure only with VAC dressing is something recommended in such patients. So to summarize, the only way to deal with infection is to prevent it. However, if you have not been able to prevent it and dealing with a post-operative wound leakage, I think clinical acumen and high index of suspicion results in early diagnosis and can easily prevent you from a disastrous catastrophic surgery at a later date, requiring far bigger problematic surgeries in a later date. So early diagnosis, high index of suspicion, and try to retain the implant if you are having a high index of suspicion to find these infections early in the course of disease. Implant removal only when the implant is loose or there is a delayed infection found in such case scenarios. Thank you so much, Dr. Sabra, for accommodating me early. Thank you, Shailesh, for getting this early in there. Thank you.
Thanks, Vishal. We can understand that there can be emergencies in practice. So as can be infection, which is also like an emergency where you need to intervene early and aggressively. We could take a couple of quick questions if they're there, since Vishal needs to leave. Any difference in practice from amongst the panel? Rupinder, do you agree with everything? Yep. Yep.
Any role of serum procalcitonin?
Again, sir, serum procalcitonin is another protein that is found in serum and is positive in patients with infection, but it is also positive in patients with inflammation. And so post-operatively for 7 days, serum procalcitonin levels also remain high. However, the quantitative value of serum procalcitonin, if it is more than 1, then it is said to be very highly suspicious of infection. And in inflammation, it always remains less than 0.05 for at least first 7 days. After 7 days, the serum procalcitonin is far more specific, even specific than the raising ESR and raising CRPs. So after 7 days, yes, it makes some sense to do serum procalcitonin. But for first 7 to 10 days, I don't think it has much diagnostic value, and it is as good as ESR or CRP.
Thank you.
Yeah, even after 7 days, it may be also a sign of sepsis. But in a country like India, a peripheral smear gives an equally important value and can predict if there is a left shift that there is a sepsis which is taking place. Any other question? Quick question.
I think both the talks were excellent textbook plus experience, Vishal and Dr.
Datta. Yeah. So we, in the interest of time, we move forward. Thanks, Dr. Vishal. And we will have Dr. Guru Raj presenting on lumbar discogenic stenosis, a dilemma.
Good afternoon all. Thank you, Dr. Chavra sir, and thank you the Pune team for having me here. Is my screen visible?
Yes, good.
Yes. Okay. The post-operative infection, post-operative spinal infection, even though it's rare, it's important. Like that, one of the most common problems which we see in day-to-day our practice is prolapse into vertebral disc, or what we call here it as a discogenic stenosis. Even after we say it's our bread and butter and it's one of the basic things, even in exams, it's one of the most difficult topics to address. And even if in clinical practice, it's one of the most difficult problems to tackle. So why is that? And why are we discussing this topic today? So that's a 37-year-old male patient, classically presenting with the back pain and left leg pain. So we see these kind of patients very often. And we all know that there can be options in managing this patient, depending upon the duration, depending upon the neurological deficits, and many more factors. Conservative is always the first thing which comes to our mind. And conservative means it can be active supervised treatment or a non-surgical injectional therapies, and then surgery. When it comes to surgery, again, it's fought with the dilemmas whether to do a open discectomy or a minimal invasive discectomy, and when to do fusion or when not to do fusion. So why it's a mystery? Because it's an ongoing process. The presentation can change from when you are seeing the patient, even whether you are seeing the patient at 1 week after the onset of symptoms, or whether you are seeing the patient at 6 weeks or at 6 months or after 2 years. So because disc degeneration itself and the prolapse of the disc degeneration is an ongoing process, the presentation and the symptoms and signs can be different. So we have to understand this thing, and we have to understand the natural history of a simple disc prolapse. And because it's variedly present, it's confusing. Why is that? With the same MRI findings, we can have different kind of symptoms. Patients with the same kind of MRI might present with leg pain. They might not present with leg pain. The severity of leg pain can be different. Some people present with deficits. Some people present with ortho deficits. So the clinical symptoms and signs can be different with the same MRI. But then again, the same symptoms, but then there can be a different MRIs to it. Third, same symptoms, same MRI, and different management, because there are n number of options available to manage the same problem. So that is why it's a mystery, or it's a dilemma. Rather than a dilemma, I would say it's always there is a confusion in the mind whether this approach is going to work in this particular patient or the other approach is going to work in this particular patient. And then again, different options are available. In the same option, same surgery can be done in a different way by different surgeons. Even if we are doing the same tubular microscopic assisted discectomy, the way the people approach to it is different. Some people might do just fragmentectomy, some people might do a partial discectomy, some people might do a subtotal discectomy, and then some people might do just a small removal of a bone. Some people might remove more bone. So different ways to basically well the same cat. So that is why there are multiple questions, multiple options. That is why it creates confusion in everybody's mind. So what is the consensus? So we all know that cauda equina due to prolapse interval disc is an emergency, and it needs definitely a surgery, and it has to be done as soon as possible. But we all know that it happens in only less than 1% of people. And we also know that natural history of the disc is to resolve. And in most of the patients, conservative treatment works. So there is no confusion in our mind about regarding these things. And we also know that surgery is required only in selected group of patients. So what is the success mantra when it comes to managing a simple intervertebral prolapse disc? So the most important thing is patient selection. If you select a proper patient for a proper procedure, you will always end up in a right side of the field. But then right side of the result. Maybe that is why there are some guidelines or there are some rules to it. So that is why I said poorer patient selection, that is what needs to fail back surgery or a bad outcomes in prolapsed intervertebral disc. So guideline number 1, we all should know that natural history of the disc is to resolve. Acute symptoms, whenever patient presents to you with acute symptoms, 95% of the patients respond to conservative treatment, and they do have good results. So presence of symptoms, even if they are really severe, is not the only indication of surgery. If you select based on only one thing for a surgery, you might end up having a bad results. So the other thumb rule is we should offer conservative treatment to all except in a progressive neurological deficit patients. So what is the phases of conservative treatment? You need to initially in acutes, when there are acute symptoms, you need to control pain, maybe by giving rest of 24 hours to 48 hours, then medication, maybe we can opt for a root block also. And then once the acute pain subsides, we have to modify their lifestyles. We have to involve them actively in their treatment and reduce the sedentary lifestyle and increase the activity in their day routine life. And then we have to stabilize the core muscles by strengthening, by doing core stabilization exercise or core strengthening exercises. Second, guideline number 2 is failure of conservative treatment. As soon as you see in your OPD and a patient has undergone some conservative treatment and then it is already 6 weeks, 8 weeks, it is not the only indication for surgery. You need to evaluate thoroughly why the conservative treatment has failed. Whether the patient has been inconsistent with the treatment, whether the patient has not taken proper conservative treatment, or whether the conservative treatment itself has been not sufficient. So we need to evaluate why this conservative treatment has failed. So when do we discontinue this conservative therapy? Duration, I have put a question mark because there is a big ambiguity here, from 6 weeks to 8 weeks to 6 months, 1 year, because it differs from patient to patient, and what discussion you have with the patient and what are their demands. Based on all this, you might have to discontinue conservative treatment. And when do we basically stop conservative treatment and start thinking of surgery is when the symptoms are progressing in spite of a good conservative treatment. The pain is intractable so that it's hampering with day routine activities, and there is a secondary stenosis along with the prolapsed intervertebral disc. So what next? Whether it's always surgery? No, it is not always surgery. You might want to opt for root blocks. You might want to opt for more conservative therapies. And then there are some rules to it. When you want to do surgeries, when you want to be a successful surgery to for a prolapsed intervertebral disc. Well, first rule is you have to do a correct diagnosis. Second is you have to have excellent clinico-radiological correlation. Third is you have to have a progressive symptoms. And fourth is you have to counsel your patients very well to have a good results, because most of the pain, and we know that these pain is more of a psychosomatic origin. So we need to address not only the somatic pain, we need to address the psychological aspect of it also. So what is the correct diagnosis? We need to rule out extra spinal causes for the same symptoms. So this is an example where 23-year male presented with chronic dull aching pain, low back pain since 6 months, and right leg pain, difficulty in walking, sitting, and sleeping. And knee and thigh pain is more than a calf pain, and SLR is around 30 degrees, and no neurological deficits. So as soon as we see this, there is a HIZ area seen in the L5S1, and then there is a degenerative disc. So because the pain is intractable, you might want to think in terms of nucleoplasty or endoscopic intradiscal procedure or a fusion procedure. But stop there. Just go ahead and see the SI joints also. If you see there's a sacroiliitis happening, and it mimics basically radiculopathy. If you go back and see in this slide, the knee and thigh pain are more as compared to the calf pain. So you need to differentiate from different pathologies how the symptoms can differ in a very minute way. So we need to be very careful about these spinal massettes of facet syndrome or facet cyst, which can mimic like a slip disc, sacroiliitis, hip joint pathology or pelvic girdle pathologies, and non-compressive radiculopathies. Also, you have to be ruling it out. Rule number 2 is excellent clinico-radiological correlation. What I mean is what disc you have to have the same dermatomal pain or same symptoms corresponding to the nerve root. So in this case, 57 male presenting with L4, L5 PIVD, you can see right leg pain. There's a calf pain is more than thigh pain. So it correlates with the findings seen on the MRI. But in this same page, in another patient with 37-year-old male, left anterior thigh pain in a left L5S1 PIVD, you have to be careful. You have to go and see the higher level disc, whether there is a foraminal or extraforaminal disc also happening at the higher level. So that is why you have to have good radiological with symptoms have to match to it. And basically you have to see for tension signs and specific signs for prolapsed intervertebral disc. And whenever you have a L3-4 or L2-3 disc, see for femoral stretch or anterior thigh pain. Rule number 3 is a progressive or worsening symptoms. Worsening ADL is a good indication for doing surgery. No surgery if the symptoms are already resolving, whatever the duration it might be, and it is not affecting their day routine activities and not affecting the mobility, because these patients are going to be unhappy after you do surgery on them. And then rule number 4 is adequate counseling. I think adequate counseling is the 50% of your successful surgery. So you need to explain them what is the maximum probable benefit to the versus minimum probable benefit they can have, and what minimum they should expect and what maximum they should expect from your surgery. And especially when it comes to they have pre-existing neurological deficits like numbness, whether it is going to improve or whether it is not going to improve. If at all it improves, how long might it might take, and whether they are going to have a residual back pain, or sometimes maybe back pain might increase after your intervention for some time. And if they have motor weakness, whether it is going to improve or not going to improve. You need to discuss with them in detail about the post-operative course and their active involvement in terms of recovery. And we also have to clearly explain them other complications like recurrence, infection, maybe neurological deficits and all that. So how to do, basically the other question is whether how to do access, whether we have to do a conventionally, that is open surgery, or minimally invasive, whether we do a bony resection in terms of laminectomy or laminotomy, how much disc to be removed, whether we just do a fragmentectomy or a subtotal discectomy, or is there any role of fusion in specific scenarios, that also have to be addressed. So I'll just skip them. So we know that conventional open is too invasive. It causes epidural scarring, and it has got no additional benefit over MIS surgeries in most of the patients we operate upon. So that is why always the MIS goes over the minimal access or a minimal invasive surgery when it comes to doing the treatment of prolapsed intervertebral disc. Basically, you can do a microscopic lumbar discectomy or a decompression using a tubular retractors, or you can do a endoscopic discectomies. So it is just an example. You can see that with a small incision of less than 2 centimeters, you can get away by doing a discectomy. So basically, minimal invasive surgery requires expertise, and it has got a learning curve, but the most of the surgeries can be managed using MIS approach, and indications are ever expanding with increasing experience in them, especially in obese patients where you might have to have a long incisions. If you use a tubular discectomy, you can get away by doing small incisions. So again, you have to look for these special situations where you can have a foraminal and extraforaminal discs and high lumbar discs, and you might want to see multi-level discs. These all have to be approached in a different way. For want of time, I am not going in detail of them. And again, the special situations are a massive disc which are leading on to cauda equina syndrome. So we all have to be aware of these characteristics where you might want to counsel the patients better, and you might want to start thinking about fusion in massive lumbar disc where the disc is centrally located, it's very much migrated downwards or upward, a calcified disc, or there is a big annular incompetence when there are adhesions are expected, or a recurrence disc, whether the disc is intradural. You should always have a big central disc with the cauda equina without any motor deficits. You should always have a high suspicion of having an intradural disc and the disc which are extending into the foramen. And when the symptoms are bilateral, and in all discs, you have to do a basically dynamic X-rays to see is there any instability. In these situations, you might want to think regarding fusion. So you also have to be very aware of these unholy alliance of a large disc with obese people, elderly age group, and then you have to see facet tropism. You might have to cut more facet to take out this large disc fragments. And if you have grade 1 modic changes, which is causing severe back pain, again, you might want to think in terms of fusion. So in all this, there's especially managing disc has got a steep learning curve. With experience and with every day's practice, you learn something new and you learn to manage it in a different way. So that is why if there is disc is always a big dilemma. So carry home, we all know that the natural history of the disc is to resolve. Most of the patients do respond to conservative treatment. Correct diagnosis and ruling out extraspinal causes is very, very important. You should have an excellent clinico-radiological correlation for your surgery to be successful. And you also always have to look at progressive symptoms. And the most important thing is adequate counseling of these patients. Thank you. And I would like to welcome all you for ISSICON 2021. So we are going to have workshops on 18th of November, and from 19 to 21, we are going to have main main conference. It is going to be exciting because it's the only conference where we deal mainly with spinal cord and spinal injuries. And it is a holistic approach we have in this conference. So I welcome you all. Thank you.
Thank you, Dr. Gururaj. That was a wonderful talk. I think we'll take any questions after the talk by Shailesh on OARM navigation in revision lumbar spine surgery. So,
yeah. Just a second, sir. I'm just connecting. Is it?
yeah, we can see. We can see.
We can see you.
Yeah.
No. Can you see this presentation?
Yeah, right. We can see it.
Yeah, we can.
Yeah. Thank you all. I will not be taking much time as we are running short of time. And when such patient comes to us, this is an elderly gentleman, previously operated spine, and there is toppling. And when someone comes with significant back pain, difficulty in standing and walking, then we start thinking, why me? Why so late? Can I deny the surgery? And should I refer it to someone? And all these things keep in our, is always there in our mind. And we know we have the limitations of our human joints. I'm not going to be in depth of all this, but we always believe that we have some limitations, and the future, the navigation, the robotic is definitely going to help all of us in minimizing our surgical technique, minimizing the blood loss, efficiency, accuracy, and precision. This was our basically revision spine publication in a textbook. But why we are talking about OARM and navigation now? And because we have realized that there is a great future in this technology, and one never knows what will happen tomorrow. Therefore, wise men should do the tomorrow's task today itself. And this is what we talk about. Again, when we talk about this case, and we plan for OARM navigated revision for this particular patient, because all of us know that the problems which can be there in revision spine, previously operated, lot of fibrous tissue, lot of bony mass integration, difficulty to identify appropriate pedicles in previously operated spine, instrumentation is a problem. Again, we have to connect, whether you have to use the connectors, all these things can be an issue. And getting appropriate pedicles in the adjacent segment, lot of bone loss, getting the trajectory in the deformity, this can be an issue in such kind of cases. And this is where this technology is of a great help. That's what we have realized in last 2 years, and we're doing this. When this patient was operated elsewhere, if you see, there was a lot of bone graft which was put, and posterolateral graft was put elsewhere. And slowly there was the adjacent segment failure, and we started seeing these are all the pictures which we have taken from the patient retrospectively. He has taken opinions from all over the country and even abroad. Somehow he was worsening, but he was managing. He was neurologically intact. When he actually presented to us, there was a dynamic instability. In lying down, he was 5x5, but on standing, he was buckling. All these things were happening, and we investigated him thorough. And if you see, there was narrowing at the conus level. We planned for multi-level adjacent segment fusion, and really it was a great benefit of OARM. I will not go into the detail about this. Once you do the OARM and navigation, you take a 2D and 3D.
The lateral is now
To take a 2D and 3D, you always get the exact markings, and you can always navigate by seeing in front of your eyes. And that's the beauty of OARM. You don't miss a pedicle. If you see, the previously operated case, and now if you see the length and the trajectory of the screws is maximum, and we can get absolutely good triangulation. We can get good convergence of the screw, and this patient was significantly happy. And this is what is the big advantage. We don't need to think too much, and outcomes, we can really get very, very good outcomes. Is it that the Shyam is of no help? No, Shyam equally. See, ultimately, OAM or navigation will not make a bad surgeon good. It will make a good surgeon better. And that is what I always talk about. These technologies will make a good surgeon still additionally little better. But traditionally, we always did everything freehand. And that's also a very good judgmental surgery, which we always did. This precision, what we talk about, even in osteoporotic, now we recently have presented our 177 screws with the placement of 99.67% of accuracy in pedicle in osteoporotic spine. And that's where the OAM navigation is going to help us. If you see the old papers where perforation, misplacement of pedicle screw, there was a lot of error. And if you realize, around 3 to 55% of pedicle perforation was there in the previous studies. Now it is coming down to almost 98 to 99% accuracy. And this really is going to help us the patient safety outcomes in any which ways. Even as you mature after a few cases, it's very easy, and you start dealing in less time, because you're just exposing, or MIS way, you're just directly targeting your levels, and you don't need to think too much. It's very, very less stress to the patient surgeon. You have to just go like a normal routine case and do your revision whichever way you want. And it's like a GPS inside your OT, like it's guiding you for any complexity in a revision case. Again, navigation is very, very useful in spine as well as in neuro surgeries. And these are the very simple gadgets. It's not very difficult. When you start doing the surgeries, you realize that this is really an additional tool. This was a Eurospine paper which was published, and it spoke about 99% of the accuracy in 3D navigated screws. That's itself is a very big paper, and this was in 2013. Again, question which comes is how much is the radiation? And if you see the dose, now we have realized that it's really not much. In a MIS, it's comparable, or in 2-level, it is almost similar, and it's multi-level, it is probably less. There is no radiation to the surgeon. You are taking it every day in and out, and for a surgeon, there is no radiation as you are out of the theater. We always take a consent of the patient, and it's a minimal radiation. We are studying on that also. What initially thought of, it's a 13-second shooting. It's not much. 13-second of a OAM shoot is not much. That's what I would like to tell, because there are a lot of myths people talk about. The latest machines have excellent radiation safety gears also. And if you see that in any navigation, these are the navigated screws where we can directly, even cage screws, everything can be used by your vision, under vision, and under navigation. You don't have to think whether you're having any problem, because you're seeing everything in front of you. We have our experience of these cases in complex deformities also, osteoporotic fractures, even cervical spine, pedicle screws. Everywhere it's 100% accuracy. That's what I would like to talk about. And in revision spine, if you see, this is what we always talk about, the bicortical insertions, and you can actually see when you're putting the screw that you can get a good bicortical purchase, you can get a good triangulation, you can get under trapping of the screws, and put the screws, the screw length, diameter, actually you can plan the way you want it in a porotic screw. If there is a collapse or bone loss, you can plan your screw trajectory in that direction. All these things are going to be very, very useful. Even minimally access surgeries, you can do it for revisions in OAM and navigated screws. This was our original paper in 2011, and this was talking about the less invasive posterior lumbar interbody fusion, and that's what we do it using the OAM navigation now, and it's a very, very good advantage for routine practice. And I'll just show you 2-3 examples. This is a 2-3 L4-5 fusion operated 14 years back elsewhere. The patient comes back with L5S1 disc with back and leg pain, 8 to 10 months of conservatism, pain blocks elsewhere and not better. And he comes to us. We thought of planning for a complete job, and we did a T-lift at L5S1. And it's a big advantage when we see that this is the forearm picture at the end of it. We just thought of checking the trajectory in this revision, and you can see exactly how the direction of the screw goes, and it's of a great help. And this patient now is doing very, very good post-surgery. As a lady who is suffered with L4-5 disc with back and leg pain, persistent pain, and she was operated because of there was stenosis at L4-5. She was fused L4-5 and she was doing fine 6-8 months, and then she went for paragliding and again jumped. This led to a jerk, and there was a large disc which came out, and this is what the disc was. And again there was wet facet, 3-4 large disc. It becomes very easy when you use a navigation. You just need to do it very cautiously, and you really can get very good outcomes. I will not take much time as we are running short of time. Thank you very much for patient hearing.
Thank you, Shailesh. And that was a wonderful presentation. We have had very good case discussions, video presentation, and talks. I believe we are running short of time and may not be able to take any questions. Shailesh, up to you. If you want to take, if there are any burning questions, 1 or 2 we can take for each of the faculty.
May I have a question in here, sir?
Yeah, Siddharth.
So for Dr. Datar, the case he presented was clinically a cauda equina syndrome. So would he suggest as a learning curve an endoscopic interlaminar, especially when a large migration upwards, downwards, along with a large central fragment? Would a conventional microdiscectomy be prudent in case of a clinically cauda equina presentation where there was bilateral lower limb deficits?
Yeah, thank you for the question. First and foremost thing, one should not attempt cauda equina in the initial part of your endoscopic learning curve. That is very important. Interlaminar endoscopy, though the anatomy is very similar to what we do in posterior systems, is completely different with endoscopy because the control on the instruments as well as the amount of decompression that is required is a little bit of a guesswork, which is more initial phase. Once you are more comfortable doing bilateral over the top outside in decompressions, then it would be an easy job for you to do it. The case that I showed was not for the learning curve, but what possibilities are now possible with the endoscopy. I hope this answers your question.
Yes, thank you. Thank you so much.
Thanks a lot.
So, any other last question before we move on to the next session? So if there are none, I would want to thank all the faculty, Dr. Himanshu Kulkarni, Dr. Shumayu Datta, Dr. Mayur, Dr. Girish Datta, Dr. Guru Raj, Dr. Shailesh, and Dr. Vishal for a wonderful session. And over to you, Shailesh, for continuing with the session, with the program. Right. Thank you.
Thank you, Chabra sir. As a session chair, you did a wonderful job, and all the faculty for a great inputs, a lot of learning from today's lumbar spine session. I would request Dr. Ajay Shetty, the session chair for deformity, to take over from now on. Ajay, over to you.
Good afternoon. It's a great pleasure to be here. My sincere thanks to the organizing team, Shailesh, Ajay, Siddharth, and Pramod for having given me this opportunity. On behalf of ASSI and myself, I would welcome the moderators of the session, Dr. K.V. Menon, Vishal Peshetiwar, and Surya Prakash Rao. And my sincere welcome to our colleagues from Japan, Dr. Watanabe, Dr. Daisuke, and Dr. Yagi. I think we had a busy schedule and we have a much more busier schedule now. At the outset, after this, I think I would like to invite Siddharth to start his talk, first talk on the evaluation of scoliosis. Siddharth, can you start sharing the screen? Not able to hear you, Siddharth. Shailesh, you are able to see Siddharth's...
I can see, but I cannot hear him.
Yeah, same with me.
I think he needs
Can you
to
hear me
unmute.
now?
Yeah,
yes, Siddharth, can you just go to the... Yeah.
Yes.
Yes. So thank you everyone for the opportunity. I'll be starting with the clinical evaluation of scoliosis as my topic. So when you're presented with a scoliosis in the OPD, the main questions that you would like to have answered is what is the etiology? What is the growth potential of this particular patient? What is the skeletal maturity levels? And then you want to assess the curve for its magnitude, flexibility, and its risk for progression. All this in the final endeavor is to choose the best plan of care for this particular patient. So if you're looking at evaluation, I think it all starts with a very good history. It is most beneficial in identifying the etiology is the part where you confirm on the history what is the age of onset of symptoms, because particularly in congenital and early onset scoliosis, the presentation is much earlier in life. Infantile, in the idiopathics, infantile, juvenile, and AIS again have been segregated based on age, therefore helping you understand the etiology based on the age. You would also want to know how long the curve has been present in the patient and has there been any change in the progress of the curve, especially in the background of patients who are in their growth spurt, either their primary first growth spurt or the pubertal growth spurt. Also, some congenital curves such as hemiavertebras with a contralateral bar may have higher risk of progression, as also is the case in dystrophic curves such as neurofibromatosis that have entered into a dystrophic phase of growth. On the history, you would also like to go back into the birth history to assess the milestones, to assess any congenital accompanying anomalies of the cardiac or renal or gastrointestinal that were present at the time of birth that needed intervention. These again help you identify the etiology and point towards a congenital origin for your scoliosis. You would also need to know the past treatment that has been taken for all these problems, including cardiac surgeries or surgeries that were relating to neural tube defects, which might have been open at the time of birth. Another important point in the history is to assess for pain. Normally, idiopathic scoliosis, such as adolescent idiopathic scoliosis, are painless. But whenever you are seeing a patient who has a considerable amount of back pain, you must go back into your assessment to identify the pain generators. Quite often, you might have a case of a lysis at the last segment, as in this case, where there was a lytic listhesis at L5S1. Associated very rarely, you can have complications, especially in AIS, it's rare, but in the other, such as congenital and neurofibromatosis with severe degrees of deformity, you do get respiratory insufficiency, especially in early onset scoliosis. Rarely you can get neurological deficit, especially when it's associated with dystrophic curves or also when there is a kyphoscoliotic element. This is a case of a neurofibromatosis where you can have rib subluxations into the canal, which can also rarely cause neurological deficit. Moving on, after the history, in your clinical examination, you would like to go under 4 or 5 specific sets. So the general physical examination, specific examination of the curve in terms of region, morphology, and flexibility, a quick routine neurological assessment, then a specialized set of assessments to see the growth potential in this particular patient. And then we go on to the radiological assessments, which will complete the evaluation of your patient in the clinic. So the general physical examination, I'll just point out some key features. So I think height is very important. You should note serial sitting and standing heights in your patient. If you see the 2 bar graphs, the duration or at which time the peak height velocity is attained by 5 children may be different, but generally the peak height velocity in terms of how many centimeters they might grow in a year is more consistent, and this is most coinciding with the chance of growth spurt and when the curves are likely to worsen. So you would like to keep a quick close height watch on the height. Skin markers such as cafe au lait spots or neurofibromas, hairy patch, these can also be features that will be associated with a particular form of scoliosis such as neurofibromatosis. On your general examination, you would also like to look at ligament laxity, which may be associated in certain cases such as Marfan's, a foot deformity, asymmetry of the foot, or any sort of foot deformity such as cavus should alert the surgeon to the possibilities of a neural tube defect or intrathecal spinal cord anomalies such as diastopatomyelia or meningomyelocele or myelocele in the particular patient. In case of some syndromes such as Marfan's, the body habitus itself might suggest to the surgeon that there is a possibility, especially with high arch palates, tall stature, arm ratios that are very large, associated chest deformities such as pectus excavatum or carinatum. If you are looking at very severe curves, it is mandatory that you should assess the cardiac and respiratory function. Sometimes a bedside single breath count is a good way to assess whether the patient will need a formal assessment with the pulmonary function test. Any patient that is reporting exertional dyspnea must also be assessed for any cardiac underlying lesions that may have been missed in the previous years of life. We come to the next point, which is the assessment of the curve. You want to know the region of the curve. So looking at for the particular, the hump, whether it's a scapular hump, the rib hump, or the loin hump, which of these is the most prominent. I think a very good learning point for residents and fellows would be to first identify right-sided curves. They're less likely to be associated with other issues. But whenever you have an atypical left-sided curve, it must be evaluated with an MRI, especially if it comes under juvenile age groups. You would also like to know the shoulder asymmetry, the overall coronal and sagittal assessment of the clinical views of the spine. You can consider basic clinical assessment of flexibility by having the patient do a side bending in your clinic, or in small children, a slight vertical suspension with traction to the head can also give you an assessment on the curve flexibility. Important point to watch out for in adolescent idiopathic scoliosis, most often the curves will be smooth with good compensatory curves. The moment you see a curve that is short, sharp, angular with an associated kyphosis, it should alert you to the possibility of non-idiopathic or syndromic associations. So like I said, if you have a short curve, short torso, it might be associated with congenital scoliosis. A very large degree curve sometimes can be associated with intrathecal tumors. The third point in your clinical assessment would be to assess the growth potential. The riser sign, the Minarchy, triradiate cartilage, these are easy to assess. They are fairly straightforward. One of the other that you can use is either the olecranon fusion on the apophysis fusion, which coincides quite well with peak height velocity. The Hong Kong group uses radius and ulna physis closure. There are other modalities such as the Sanders classification, which can be on the hand fusion fusion of the second epiphysis on the hand X-ray, and you can have Tanner's grading, which a patient including the secondary sexual characters. Good point to remember is you draw out your triangle with the 3 zones, triradiate closure and risers 2. These are zones 1, 2, and 3. Generally, these are the high risk potentials where a significant amount of growth is still left, and you should watch out for these zones because they might be patients who may have progression in their curve deformity. An important point is, especially in patients who are coming to you for juvenile scoliosis or for early onset scoliosis, crankshaft is an important problem that you might have to deal with. So this is something that you have to look at, especially in patients who have come with riser 0 or at too young an age to consider for formal fusions. Neurological assessment. I think apart from the routine assessment of the neurological systems, I think asymmetrical reflexes is something you can watch out for. Asymmetrical abdominal references could be a subtle sign of a possible intrathecal abnormality. Finally, you would want to know what is the cosmetic concern of the patient, whether it's the rib hump, whether it's a loin hump, whether the waistline asymmetry is the primary concern or a shoulder level asymmetry for the patient. We come to the last step, that is the radiological assessment. I think what you need is a good standing whole spine X-ray that includes the cervical spine and the pelvis. You would like to identify all your key vertebra on this X-ray, including the end, neutral, and apical vertebra, and also draw the stable vertebrae with the CSVL. You then mark out your curve angles for both the major curves and the secondary curves or the compensatory curves. And more than just one X-ray, I think what's more important is to assess the criticality is to assess the behavior of these X-rays over a period of 6 months or say a year, which would then assess how much progression is possible. The lateral is also important. Sometimes you can have sagittal plane stiff curves that are thoracolumbar junction, which may be kyphosis, or in the proximal thoracic spine, which might be in kyphosis. These are also important to look for any lytic listhesis. If you have a hyperkyphotic spine, sometimes there may be risk factors for proximal junctional failures, and that is something that you need to watch out for. I think flexibility assessment, there are a large number of data and sets that are used. Some people prefer supine bending films, some people prefer push prone films, some people prefer fulcrum films. I think each of these flexibility films have their own advantages and disadvantages. For traction films, I think they work best with neuromuscular scoliosis elements, help you understand how much the curve will correct. So we use supine side bending films and traction films in our practice. But having worked at Hong Kong, I know that the fulcrum bending films are more predictive of how much curve correction you will achieve. It is helpful in selecting cases that would fall under selective thoracic fusions, although you need a special set of bolsters for this. In this paper, the authors pointed out that they were able to save up to 62% levels on their fusions when using fulcrum bending films to predict their lowest instrumented vertebra. The last slide or the penultimate slide, I think what next, there's one more thing that we have to discuss. Is there a role for MRI? Maybe not so much in idiopathic scoliosis, but definitely in the other, such as neurofibromatosis, syndromic associations, early onset scoliosis, and even juvenile scoliosis. So any atypical curve, atypical in both age, progression, pain, or side, any curves which are sharp and angular associated with kyphosis, any curves which have associated neurocutaneous markers or features of spinal dysraphism should have spinal cord imaging in the form of MRI done. This was a paper from Ganga Hospital where they noticed incidental spinal cord anomalies in about 16% of patients of 177 consecutive scoliosis that was screened. Another paper of the JBGS which suggests that high diagnostic yield of MRI is with atypical curve patterns and where there are some neurological indicators to suggest spinal cord anomaly. So I'll thank you at this point and stop. My thanks to all the presenting associations, the Japanese Scoliosis Society, the ASSI, the Pune Orthopedic Society, the Maharashtra Orthopedic Association, and to Sancheti Hospital.
Thank you, Siddharth. It was quite, detailed. I know 10 minutes is quite short a time for you to cover all the aspects of it. And here, a special invite again. Thank you all from the Japanese Scoliosis Society. Most of them we know very well, especially Kota, who has been to India many times and a part of our meetings. Kota, good morning and I think it's good late in the evening for you.
It's 8 p.m. in Tokyo, Japan. So
thank you
good
for
evening.
joining us on a Sunday. Okay. Now, what are the important things you look for in a patient with adolescent idiopathic scoliosis, a presumed adolescent idiopathic scoliosis, when you are examining, which alarms you or make you think that there is something is not adolescent, it's not an idiopathic curve?
Sorry, is it a question for me? Or?
Yes, Kota. I mean, I would like to know which are the important things you specifically look for,
okay,
which might give you a clue in a patient in adolescent idiopathic scoliosis.
Yeah, you mean in the first visit to the patient clinic, right?
Yeah.
So I always check their abdominal reflex to rule out the patient with neuromuscular scoliosis, such as Z-links, Chiari malformation, or such like that. So I think the specificity of the abdominal reflex is very high. So I always do that, and I also recommend the young doctors to do their to check the abdominal reflex at their first visit. And then if they're suspicious of having some neurological problem, we will order the MRI image of the cervical spine. So that's my point at the first visit.
Okay. If the patient is undergoing a surgery for AAS, would you get an MRI done in all your patients?
Yes, definitely.
Okay. Surya Prakash, what's your experience in
earlier in my government institutional practice from 98 to 2007, I always used to check for detailed neurological examination, and only if I find an abnormality or something which is not fitting into the typical idiopathic pattern, I used to get an MRI done. But after late, I've realized for the last 10 to 15 years of practice, where the patient actually walks in with an MRI scan, whether you ask it or you don't ask for it. And then unless an MRI scan done, patients are usually not happy. So I think technically we can debate whether it is required or not from academic point of view. But practice perspective, I think I do MRI in all spinal deformities which come to me today.
KV, would you like to add something which is very, very important in evaluating a patient, not radiologically, clinically in decision making when you have decided to operate on a patient for scoliosis? What are the important things you look for when you have decided to operate on a presumed probably a type 1 curve?
So, I mean, I think the speaker has covered, Siddharth has covered almost all the points. Besides that, the only thing that I would do is pulmonary function test and some anthropometry. This is more of institutional practice than anything else. Pulmonary function is mandatory, I believe, but the anthropometry is not really mandatory. It's only to give you some statistical data of what was the original trunk height versus limb height, and what is the predicted height increase that you can get, and numerical data like that. So that's more of an institutional practice. But pulmonary function, I think, is mandatory, and I would do it in every case.
Daisuke, greetings. Welcome to our meeting. Would you like to add, hi. Would you like to add anything which you do specifically, which you look at?
Well, I think, the speaker has covered most of the points that are important. We always ask them about different psychosocial status, maybe. Maybe that can also rule out some of the neurological problems that they may have. That's about it.
Okay. Thank you. I think we'll proceed on to the next speaker. I would invite Dr. Agi, who is also one of the invited speakers from the Japanese Scoliosis Society, to give us a talk on the planning future levels in adolescent idiopathic scoliosis. Dr. Agi, please.
Thank you very much for having me for this wonderful session. My assignment in this session is deciding the future level in scoliosis surgery. Among them, I am going to focus on the distal fusion level in selective slow fusion. Excuse me. These are my disclosures. The selective selective fusion for link 1 and 2 AIS result in the successful outcomes, including both radiographic and clinical outcomes. This is the representative case of link 1 curve. Excuse me. the typical the right thoracic curve with the hypothoracic kyphosis. The post-operative X-ray shows both better correction of both coronal and sagittal plane with balanced waist and symmetric waist and balanced shoulder. So the advantage of selective thoracic fusion consists of sparing the mobile segment of lumbar spine, which is most important, and also the less surgical invasive result in the faster recovery and maybe cost-effective. However, several disadvantages must be acknowledged. These are known especially for lumbar modifier A curve and development of coronal decompensation. This is typically for modifier B and C, and also the residual lumbar curve and its progression in the distal junction kyphosis. Among them, the adenoma is one of the most important issues we need to be addressed, which is the progression or extension of the primary curve after fusion. As you can see in this slide. The reported incidence of adenoma is widely, but it's mostly around 50%. But the long-term consequences are known, but possibly accelerating the degeneration of intervertebral disc below the fusion. But the revision, the necessary of revision may or may not be. It is not, it's too controversial. The several definitions have been described for the adenoma, but among them, I believe that an increase of more than 5 degrees in angulation of the first disc below the instrumentation vertebra at the follow-up is, I think, the most commonly used definition for adenoma. Several related factors has been described: younger age, skeletally immature, smaller distal grade, and L4 to the right side, and the level of lower instrumented vertebra, and amount of correction of main thoracic curve. Then among them, the selection of LIV is significantly related to the onset of adenoma. The dilemma is longer fusion prevent adenoma, but lose the more lumbar segment. So there are many controversies, and so far no consensus has been made. So let me explain the landmark caudal vertebrae, end vertebra, neutral vertebra, stable vertebra, and CSVL. In 2013, Professor Matsumoto at the LTV, last touching vertebra concept, which is most caudal vertebra that touch the CSVL. Historically, the LIV selection for Lenke 1, which is King Mo type 3, 4, and 5, should be a stable vertebra. But the revolution of, I would say, the revolution of instrument, we can get better correction with the shorter fusion. So there is a necessary need to redefine the level of LIV. This is a report from Professor Sarasuk, which was described in 2003. They described that neutral vertebra is an important factor. And if the preoperative neutral vertebra and end vertebra shows no more than 2 level gap difference, LIV can be neutral vertebra. But if the gap is more than 2 levels, LIV should be neutral vertebra -1. So this is number 1. So this is number 2, LIV should be neutral vertebra -1. In 2011, Professor Wan described that, reviewed 45 Lenke 1-year curve, and among them 23 developed adenoma. And those who had adenoma had the adenoma increased dramatically when the preoperative LIV +1 deviation from CSVL is greater than 10 millimeters. So they described to choose the DV, which is the first vertebra in separate direction from sacrum with the deviation from CS grade of greater than 10 degrees for LIV. And Peter Neutron and Robert Cho described that when we carefully look at the X-ray of Lenke 1-year curve, you will notice that Lenke 1-year curve can be categorized to 1AL and 1AR, which is how L4 tilted. For and the Lenke 1 al, the fusion decelerates to one level above the neutral vertebra, and which is a 1 or 2 level above the stable vertebra. But for Lenke 1 L curve, at least one level below endovertebra is necessary. In 2013, Professor Matsumoto and Dr. Watanabe described that they reviewed 112 Lenke 1A curve, and adding on developed 21 patients, 18.8%. And the independent risk factor is post-operative main curve apical translation greater than 25 millimeters. And the level of LIV is shorter than last touch vertebra. So the prevention of adenoma in Lenke 1A curve, the correction of apical translation and LIV cyclitude as LTV or distal is the most important issues. So this is the 16-year-old female patient. The LIV, we choose the LTV for LIV. Then the patient does not have adenoma. For this patient, this is a 16-year-old female patient whose LTV is L3, while we selected L2 for LIV. And eventually she had adenoma for both of 2 years. So let's move into the modifier B and C curve. The problems of selective fusion, as I showed in the previous slide, the lesser lumbar curve and coronal imbalance and adenoma. This is the 13-year-old female patient, type 1C N curve. The major curve is 62 degrees and lumbar curve is 45 degrees. So we performed selective thoracic fusion for this patient. So patient have a residual lumbar curve, but we are sparing the more motion segment. If we go to the L4 or L5, we can straighten up spine, but we'll lose the motion segment. So this is a long-lasting controversies, and so far no long-term follow-up study with evidence has been exist. And recently, spontaneous correction of the lumbar curve has been described, and which is a range from 53 to 70% of the pre-arbiter magnitude. This is a typical X-ray for the spontaneous curve correction. The patient's lumbar spine eventually decreased and almost straight at the 3 years post-op. Ishikawa et al. Also, this actually our study group actually reviewed the spontaneous curve correction after selected thoracic fusion for Lenke 1C curve, and then we confirmed that spontaneous improvement was shown in the final follow-up for both coronal balance and trunk shift. This is a typical case. This is a 15-year-old female Lenke 1B curve. The patient has LIV. We selected LTV for LIV, but this patient has added on at 3 years post-op. So Dr. Fuji and et al. Reviewed the selected thoracic fusion result for Lenke 1B and 1C curve, and 22% of the patient have had adenoma post-op. Then looking at the relation of caudal landmark vertebra and lower instrumental vertebra, if LIV is selected at more cranial to stable vertebra, this is a risk factor for the adenoma. In summary, selection of LIV has been still controversial. LIV may be chosen after or caudal to the LTV for modifier A, but for modifier B and C, fusion at least to stable vertebra may be necessary. Thank you for listening.
Thank you, Dr. Agi, for an excellent summary of the planning of treatment and fusion levels in AIS. KV, would you like to add something to it? Do you use the substantially touched vertebra, the last touch vertebra in your practice, or do you use anything else?
Sorry, I don't don't use the last touch vertebra or the last substantially touched vertebra as a matter of routine. What I do instead is I do the same thing on side bending films. For example, I would erect a center sacral vertical line on the side bending films and on both the side bending films. And what it would show you is how far you can push the stable vertebra up. Dr. Yagi mentioned something very important. In the Lenki B and C, it is critical to fuse up to the stable vertebra. It is preferable to go to the stable vertebra rather than go above that, as in the case of an A modifier. So how far up can you go? How far can you push the stable vertebra upward is what I am trying to assess. And to do that, I use the center sacral vertical line on both the side bending films. Very often you can save one or perhaps even two segments on the lumbar vertebra, which are critical. So that's what I do. I would not use the last touch vertebra or the last substantially touched vertebra as a matter of routine.
Okay. Daisuke, would you like to add anything? How do you choose your lower end vertebra?
I think
especially
very nice concept given by KV Menon. I used to use that earlier, but now I've realized that you take a traction X-ray and then you draw the central sacral vertical line. That also gives a fairly good idea where how you can push up the stable segment a bit more. So nowadays I'm using the traction X-ray, and then I'm drawing the central sacral vertical line where I know exactly where my fusion ends. So that's when the entire idea is that to know if the disc below the fusion segment, the end fusion vertebra, is opening on either side, and the disc is horizontalizing with the iliac crest. These are the two considerations I take. I think all of us are speaking the same language with different technical notations here and there.
Okay, that's true. It depends upon the flexibility of the curve. Daisuke, would you like to add something?
Yeah, well, thank you. I think everyone has shown that traction films and bending films and last touch analysis is also important. As I go into my talk, I use the real-time traction table during the operation to see the actual flexibility while I'm doing the corrective maneuvers. So that's about what I can add on to something that you've been talking about. Yeah.
Yagi, you have been talking mainly about the lower instrumented vertebra. What about the upper instrumented vertebra? I mean, do you have anything in particular to choose, especially in scenarios where there is a doubt for you to go? When do you decide to go higher up? Or when do you decide to go to T4 or T5? Do you anytime go to T5?
Yeah, that's a good question. Due to the limited time, I did not speak about that, but we usually choose the end vertebra -1, end vertebra -1 for ranking 1 recur. But if the patient has a lordotic spine, we occasionally go to T2, 3 to get some correction, to get some kyphosis. But other than that, we try to limit end vertebra -1 for 1 acre. Thank you.
I mean, do you have anything particular to prevent the shoulder imbalance when you are doing it? I think we will discuss that once Daisuke completes his talk on correcting maneuvers. I would like to invite Daisuke to present his talk on the corrective maneuvers in scoliosis deformity.
Yes. So I would like to thank the organizers for inviting us to today. The titles that given to me was the corrective maneuvers for AIS. We've been having experience on conventional rod rotation maneuvers ever since the modern implant surgery was introduced into our institution. However, we face some of the difficulties and limitations of rod rotation itself, because mainly the large force is applied on concave rods mainly, and the rods and screws. And the extension force applied on the one rod construct reduces the kyphosis of the rod itself, that we use the strong arms to create thoracic kyphosis, but it reduces while we are doing this maneuver. And the rotational force that is applied to rod rotation maneuver increases the rib hump. So you're going against or going towards the rib hump while you are doing the rotational maneuver. So regardless of doing this, as in Dr. Ito has published on dual rod rotation technique, where they use two rods to rotate. They use polyaxial anchors, and polyaxial anchors also have reduced rotational potential, and no actual change in the force applied on the concave rod, even though you use dual rods to rotate the rod. And then it also similarly increases the hump. And another aspect that is important is the sagittal balance. And when you're using rod rotation, the apex of sagittal balance, the thoracic kyphosis, will equal the main curve apex, where usually it is quite lower than the suggested thoracic kyphosis. Therefore, the movement of the apical vertebra is mainly rotation plus a large amount of translation to the posterior element of the spinal column. So the ways not to reduce the rotational rod rotation in increasing the hump is probably using the translation more in your maneuvers, whatever you're doing. But the limitation of translation also reside within the force applied to the rod and the screws, while if you are translating the most apex, which is the most distant screw, you're actually putting more force on that apex screw and also to the rod itself. And the vertebral rotation. When you're doing vertebral rotation, some of the vertebral rotational maneuver equipment has been out in the market. And this limitation also comes from the vertebral column only rotates on one rod. So if you're using two rod construct at the same time, there is not really a rotation to your vertebra, but somewhat translational force that comes to the two rods construct. And with the evolution of the screws, we are able to easily apply the rod and screws into the pre-bent rod. But classically, the monoaxial screws are the best in terms of controlling your spine. However, if you are trying to push this monoaxial screw into the rod, either the screws pull out or the rod bends and you lose your kyphosis. So if you're using uniaxial, it's easier to place your rod into your screw. However, you're losing some of that force in doing so. However, we have learned that these uniaxial screws provide much better kyphosis and sagittal balance compared to the monoaxial construct, especially if the patients are really rigid calves. And we've been, having quite a discussion on flat backs after these surgeries for a long time. And this evolution of screws has been one of the solutions to date. You can see that the polyaxial screws can lose around 10 degrees of axial rotation compared to the uniaxial screws or monoaxial screws. And the stiffness of the rods also contribute to how you can induce kyphosis in scoliosis patients. And you can see that if you use a 5.5 titanium alloy, you are losing around half of that stress and stiffness compared to 6.0 cobalt chrome. So selection of a stiff rod may have a role in terms of creating thoracic kyphosis. And anchors, the number of anchors also can contribute to how much do you need force to create a good balance sagittally and coronary. So pedicle screws with very, very small pedicles are the characteristics of idiopathic scoliosis. So people use, many bolt tip techniques and navigations and in-out techniques and so forth. But what's important is for every case, you need to assess how many anchors do you want to put into that patient. If the patient's really flexible, you may not need to put in so much of those anchors. But if they are very rigid, you need to have more anchors to control your spine. And then comes the releases. So if the patient is quite rigid and does not have that flexibility you have to start posterior release or anterior release in some of the cases. So facetectomy is the first level osteotomy that will be applied. And you need to think, you don't want to create too much releases in terms of bone fusion afterwards. But if the patient is very rigid, you would have to, step up to more invasive and more diligent releases, such as the pontiostenotomy or both posterior and superior facetectomies in multi-levels in some of the cases. So I use, all these techniques and try to get the flexibility as much as possible or minimally as possible in order to gain some of the ideal correction. So in my clinical practice, I use a traction table, which is called the correction box, which is something new out in the market. And then if the patient is quite flexible, main curve of 60 or less, active bending of 50% or more, and compensatory curve not constructural, and thoracic kyphosis is not so negative, then I use coplanar method or rod length reducer to induce flexible carbs. These two techniques are based on single rod construct on the concavity. So if we're using single rod technique, it has to be a flexible carb. And in rigid cases with carb angle more than greater than 60 and active bending is less than 50% or structural and thoracic kyphosis is hypo, then in the cases, depending on the cases, but I use video-assisted thoracoscopic disc release plus simultaneous translation on 2 rods and DVR, or recently we've been adopting the dual differential correction with the method and dual coplanar method. So I can show you, this is the traction table, the correction box where we can apply correction before we make an incision on the table, like the traction table. So the patient is set by the pelvis, and this is not a patient, but this is a resident. But so we apply the traction force and apply the rib also, and then on the C-arm, we can see how it is managed and kept in place before we make an incision. In some of the very flexible cases, just by doing this, patient has very, very small curve, less than maybe 20 degrees. So it's much more easy to do the correctional maneuver itself. And then in flexible curves, we apply the vertebral coplanar alignment method developed by the Spanish doctors. And we put on the convexity, the correctional rod, and by lowering the correction rod applied upon the distant of the correction rod versus the real rod, derotates the spine itself. And this is how it looks in the OR. So after the posterior release of how much you need, you apply these slotted reducers, and then apply the we would apply the correctional rod on the concavity in order to be ready after the convex based correction method. This is held by the assistant in order to hold the correction in place. And then we move on to the rotational correction, where we put rotational force on the concave side, and then apply the rod. And then actually add on the DVR. And then, so now you can see that it is held on one single rod construct. So the advantage is very simple. And you can see that in mild curve patients, this works quite well. So another mild curve solution is the rod reducer, and it's a single rod concavity on convexity correction, as similar to the coplanar method. But it has some risks because the assistant is holding onto these reducers, which is maybe uncontrollable in some cases, like this. And you need to push in and pull up to create the thoracic kyphosis. So accurate estimation of the force that is needed to apply this is quite important. So we apply the reducers by temporary rods onto the caudal and cephalad vertebrae, and then apply this force using the reducers and keep it held there. And rotation is also applied by the assistant, which you may not be able to control that. So the risk is there. And then you apply the primary rod, and this is held for a certain amount of time before you apply the next rod. So at the moment, it will be held in a single rod endurance. Similar things to apply compared to coplanar method is the limitation is there in the single rod construct. Now, the challenges to 3D correction is if the patients are very rigid and has hypokyphotic thoracic curves. In solution is to do that is to shorten the anterior elements or extend the posterior elements. Or in doing so, we would probably need a rigid vast release, especially 360 release in some cases, and you need rigid implants. So we've published this year on this simultaneous translation on 2 rods for hypokyphotic patients. The technique is shown in the paper as seen here, and you place as much as anchor as possible with correction, also a reduction of the posterior elements. And then we put both rods simultaneously into the reducers that are placed on every screws that possible. And then we tighten the reducers while the assistant holds the primary rod to the sufficient sagittal balance that you have created on the rod from end to end, where it's quite easier to make the translation of the vertebral body to the rod itself simultaneously on both sides at the one time. And then finally, we adjust it with DVR, but not really rotating on two rods, but more of a translational force. So I can show you a very rigid case where I applied thoracoscopic disc release, priority to posterior instrumentation. So this is how the discs are incised and ALL is cut. And then we do VATS for 3 to 5 levels as possible. And then we apply the screws and then check the screws, posterior release, and then apply the reducers on every level. And then put through the rods, 2 of the rods at the same time. And while the assistant is holding the rod in place for appropriate sagittal balance, we tighten it from end to end. And then finally apply the DVR. So trying to disseminate all the force applied to all levels by not having the force applied too much on segments, very limited segments. I think you have done some of the dual differential correction systems provided by K2M and MEDSA. And MESA is quite low profile, single rod concavity correction. It is somewhat cumbersome. Recently, we've adopted dual coplanar method using some of the MIS devices to rigid curves. Similarly to other systems, we apply the screws, but we apply coplanar method in both concavity and convexity at the same time. It's similar to simultaneous rod rotation techniques, but we put 2 rods in and then lower the correction rod. So this is how it looks. And for 5C curves, sorry, I'm not going to touch on anterior techniques today, but for 5C, coplanar method is also quite efficient in terms of applying rotational force through the convexity of the curve itself. If you use an anterior system, I think we can gain or less the fusion level by 1 to 2 levels. However, the cosmetic issues are also a problem in terms of anterior surgery for 5C cases. Okay, and this is how it looks after the surgery. So we looked into the cases using these hypokyphosis patients, and using the conventional rod rotation technique above, compared to that, we were able to gain more thoracic kyphosis and apex translocation in thoracic kyphotic apex. And rod deformation after the applying of the rod can also account for less loss of correction using 2-rod construct like this. before the insertion of the rod, we measured the curves. And then after the insertion of the rod, you can see that the rod was deformated in rod rotation techniques. However, if you use dual rod construct, this can be minimized, as you can see. And we can appreciate that as the curve gets larger, the active bending before less than 30%, as the curves are rigid, then the rod deformation gets bigger. So you are losing rod deformation. So in summary, some of the colleagues have been using, overbent concave rod in many of the techniques applied. However, it has some of the biomechanical analysis has shown that differential rod contouring does not really help in terms of concave rod applied forces on the concave rod. So it can, in my impression, differential rod contouring can appreciate in terms of pre-bending or over-bending the rod, but the forces applied to the apex or the most stressful portion of that rod does not really change biomechanically. So in order to gain good thoracic kyphosis, you need to do a release. If you need to calculate how much release you need and or how much screw density do you need in the concavity, and if the stress on the rods can be reduced or not. So I would like to stop there and thank you today for listening and for the invitation.
Thank you, Jai. It was an excellent talk and probably some of the techniques which you are not yet exposed to. I mean, it seems to appear that you are now depending more on the convex rod or the convex techniques of correction rather than using more based on the concave side.
Yes, for flexible curves mainly, yes. Concavity, mainly for rotational correction, has much more advantage in terms of using the concave force applied to the rod itself.
Kocha, do you use the same techniques in your practice, or is it changed over the years, or still you do what you have been doing earlier?
Actually, I always use the correction using the rod on concave side, but I did some case for example the Coprana technique or something like that. But actually, it's the surgical procedure is very complicated, and I don't like that. So, but that's because I come back to the correction by the concave
what you are comfortable
side.
with.
Right.
Maybe you are probably one of the few still using the side loading systems. And what is your take on various corrective maneuvers?
So some of the techniques which Dr. Dai showed are evidently new to us. We don't have those resources. I have been relying almost entirely on the traditional concept mentioned earlier. I use the concave rod for maximum correction. The convex rod is mainly a secondary rod. I hardly ever use any dual rod techniques because Dr. Dai specified that many of the techniques, coplanar and otherwise, or translation techniques, have got several advantages by using a dual rod simultaneously. So that's apparent, but that's not something that I've used. The side loading per se has got critical advantages only if in a Lenke type 2 curves. When you have double thoracic curves, it's got an advantage for the proximal thoracic curve. The concave rod rotation becomes a little bit of a mess if you're using top loading screws. So that's where the side loading really helps. The other curves, it doesn't really matter whether you use top loading or side loading.
Dai, before we move on to the last talk by Kota, I'd just like to know, like you have been now evolving, changing over your techniques. What do you feel in terms of, is it just a learning new techniques, or do you think in terms of your results, you find they are superior in terms of achieving kyphosis?
Yes, thank you. So it's it's the end of the evolution of my learning, going to different places and looking at various surgeries. And also, I think that we can share the same thing, that once you are comfortable, you don't really want to change everything, right? So that is the limitation of these types of research in terms of new techniques. So I think, you know, it's really needed for the evolution of the, you know, of the world in terms of advancing and minimizing patient risks. So I would encourage the, you know, young surgeons to look around for new techniques always, so that you would have new visions in terms of doing so. Thank you.
Thank you, Jai, for an excellent talk. We will move on to the last talk of by Kota on the management of congenital, before last talk, management of congenital deformities.
Okay, can you see my slide?
Yes.
Okay, so I'm gonna start my presentation. So first, thank you so much for inviting me to the Spike Weekend. It's a great honor for me and also for the Japanese Spine Scoliosis Society. This kind of educational collaboration will be the new format in this pandemic and may better continue in the future. So first, I would like to introduce a little bit about our Japanese Scoliosis Society. It was founded in 1968 and comprised of 833 members. We will have 55th annual meeting after 2 weeks on November 5th and 6th, 2021. So I'm gonna back to my talk. So we all know that the congenital scoliosis has a variety of phenotypes. The picture on the left is a simple hemivertebra at the trunk lumbar area. In contrast, the picture on the right is a complex deformity consisting of a multiple anomalous vertebrae and fused ribs that is most difficult to treat. Recently, it was demonstrated that 7 to 10% of the congenital scoliosis has TBX6 genes mutations. The indication for treatment are decided by the prognosis of the deformity. The fundamental cause of the occurrence and the progression of deformity is growth potential differences between the convex side and concave sides. If the growth of the convex side is superior to that on the concave side, the deformity will progress. The factors that determine the prognosis are, of course, the age of the patient. They will have a risk of progression until they reach bone maturity. The other factor will be a type of malformation and the localization of the spine. The failure of formation is one of the representing types of malformation. They have fully segmented, semi-segmented, and non-segmented types. Among them, fully segmented and semi-segmented types have a risk of progression and may require surgical treatment. The other type of malformation is failure of segmentation, which results in unsegmented burr formation. They will be complicated by rib stenosis. So in 2009, Dr. Kawakami created a three-dimensional classification for congenital scoliosis, considering the laminar morphology. Unfortunately, the classification could not become popular among the surgeons since it consisted of complicated algorithms. However, the classification tells us that the mismatch between the vertebra and the lamina exists, which is critical for surgery. This slide shows the progression of curve angle per year. Fused vertebra had a little chance of progression, followed by wedge vertebra, hemivertebra. The unsegmented burr with hemivertebra is the worst type. Regarding the localization at the spine, the thoracolumbar area has highest risk for progression. Usually, there is no indication for conservative treatment for this pathology. Neither breast treatment nor physiotherapy can influence asymmetric growth of the spine. Only the exception might be the effect on fractional curve, usually below the congenital deformity. So we usually have 3 options for surgical treatment: hemivertebral resection, vertebral column resection, growing instrumentation, and possibly hemiepiphysiodesis. So regarding hemivertebral resection, the indication will be, of course, hemivertebra. Usually, it can be completed with short instrumentation and fusion. Historically, some hemivertebral resection was done anteriorly, but nowadays, I believe most of the hemivertebral resection was done by posterior-only approach. Vertebral column resection is a powerful surgical option for congenital scoliosis. The indication will be a multiple hemivertebrae and compressed anomalous vertebrae with or without burr formation. But we have to recognize VCR increased risk of perioperative complications. Dr. Lenke reported that 46% of the patient has abnormal neuromonitoring or massive hemorrhage during surgery. So this is a 12-year-old girl with multiple hemivertebrae at the lower thoracic area. She has 47 degrees of scoliosis and 64 degrees of kyphosis. So we plan to dissect T8, T9, T10 hemivertebrae. So after pressing the pedicle screw above and below the osteotomy site, we relax hemivertebrae starting from the pedicle. Following the resection, we put the load. So following the resection, we put the load on both sides. Then we apply the compression force to close the osteotomy site. We then correct the residual kyphosis and scoliosis by in situ bending. And now closing the osteotomy site. And then finally, we put the cage to maintain the spinal cord length, since too much shorting will be the risk for spinal cord injury. And then we put the bone graft. Sorry. Okay, this is X-ray after surgery. Scoliosis and kyphosis was well corrected. So growing rod will be indicated for long multi-segmental curve with substantial residual growth. The downside of this procedure are that the technique needs severe surgery and a higher risk of complications. So this is a 6-year-old girl with Noonan syndrome. She has unsegmented burr and multiple anomalous vertebrae at the mid-thoracic area. So we started the growing rod. The image on the right shows the superimpose of 2-year post-op and that soon after first growing rod surgery. As we can see, the deformity was apparently corrected. Recently, we did the final fusion for her. The correction is acceptable, I think, if we consider the natural course of these phenotypes. My last topic is hemiepiphysiodesis. In this technique, epiphysiodesis is performed both anteriorly and posteriorly on convex side and allowing growth on concave side. So it is the same concept as the treatment for valgus knee. This is a 2-year-old boy. He has unsegmented burr on concave side and multiple hemivertebrae on convex side. And also he has a fused vertebra, fused ribs on concave side. So we did hemiepiphysiodesis, and then the curve was corrected to 40 degrees after 1 year post-op. This slide showed about the changes of curve angle of the main curve. As you can see, the curve was maintained until year of 11, and then the curve progressed again. So, okay. So this slide shows X-ray 10 years after surgery. Then we did a final fusion for him. So we finally performed posterior fusion, spinal fusion from T5 to L2, Ponti osteotomy from T6, 7, 7, 8, T10, 11, 11, 12. So we this is a X-ray after surgery. So I did just the Ponti ostomy at unfused area, and then we didn't do the VCR for this patient, so we could treat this pathology without doing the VCR. So I think this is one of the merit of hemiepiphysiodesis. So in summary, congenital scoliosis has a variety of phenotypes. Indication for treatment are decided by the prognosis of deformity. No indication for conservative therapy in majority of the cases. 3 options for surgical treatment: hemivertebral resection, vertebral column resection, growing instrumentation, and maybe hemiepiphysiodesis. Treatment strategy should be decided considering the goal of the treatment and the risk and the benefit of the treatment. Thanks so much.
Thank you, Kota, for a summary of the management of congenital scoliosis. Surya Prakash, probably you are one of the persons who might be having a lot of experience on this. What is your experience on the bar excision in this group of patients?
Generally we do bar excision as a part of an osteotomy only, but isolated bar excision with epiphysiodesis, I have no experience.
Okay.
As a part of an osteotomy of spine, especially in congenital scoliosis associated with significant kyphosis, bar excision I have done as a part of an osteotomy to correct a deformity. But like what has been classically described by doing a bar excision and then trying to doing an epiphysiodesis without instrumentation, I have no clue. I've never done it.
Kota, you said about epiphysiodesis. Do you think, when do you choose them? When you identify them very early, when the patient is much younger, or?
I think my indication for hemiepiphysiodesis nowadays either congenital scoliosis upper thoracic area. So I think it is most challenging cases. So I think if the congenital scoliosis located upper thoracic area, we cannot apply the growing load, and then Befter sometimes will not work. So I think only the choice is hemiepiphysiodesis or early fusion for this pathology.
Okay. Thank you, Kota. I think because of want of time, we'll move on to the last lecture of this session. Priyank Patel will be speaking on neuromuscular scoliosis.
Thank you so much, sir. Thank you, Dr. Shailesh Hadgaonkar, for having me here. Thank you, entire team of the Spine Weekend. I'll quickly share my presentation.
Good evening, everybody. Muscles have an important role in maintaining the balance of our spine. In neuromuscular scoliosis, what we have is a lot of muscle imbalance. One group of muscles could be very tight and spastic, whereas other group of muscles could be very loose or flaccid. As a result, there are deforming vector forces, and these children land up with long collapsing C-shaped curves. More than often, they are associated with severe degrees of kyphosis as well. These children could be floppy or could be very tight. Often you see pelvis included in the curve as well. The classical Kings and Lenkes classification, which we use for AIS, fails in these curves, and selective thoracic fusion is absolutely out of question. Sagittally, you will find these may have either severe kyphosis or increased lordosis causing swaybacks. There are several causes of neuromuscular scoliosis, ranging from neurological causes like upper motor neuron or lower motor neuron diseases, and muscular causes like myopathy, or in certain cases, central neurological issues. In general, the incidence of neuromuscular scoliosis is less as compared to the AIS group. However, in patients with neuromuscular disorders, the incidence of scoliosis is very high, in the range of 50 to 100%. Patients with neuromuscular scoliosis are very peculiar. They have general conditions which are not similar to AIS. They could be walkers or non-walkers. A lot of them have respiratory issues, and life expectancy in general is less than their AIS counterparts. All these factors have to be gauged before we plan the treatment of these children. They also have very poor bone stock. So there is high rate of pseudoarthrosis and implant-related complications in these patients. With poor muscle vascularity, the rate of infection is also high in them. Muscles are also often variably imbalanced. They could be spastic, not necessarily paralyzed. This can make assessment of a curve very tricky, which looks like a standard thoracic major curve. On correction, you could suddenly see that the patient is completely going off balance because the lumbar curve starts adding on. Goldberg in 91 observed that we can conclude only that cerebral palsy surgery makes patient different, but not always better. Like in this patient where we did a lumbar corrective surgery on this child with a significantly rotated lumbar spine, we did an anterior surgery, got a good correction with a good lumbar lordosis. However, at 6 months, if you see, the patient is totally off balance and the curve has added on. So the patient is different, but not necessarily better. There are no patterns for curve selection in this. You cannot classify them. They have a 3-dimensional deformity which progresses randomly, and there is no cutoff which has been mentioned for angle or age to decide on the timing for surgery. There are no auto-corrections or recompensations by the muscles. So there is no scope of selective fusion. If you take these patients up, you should go the whole hog. Like in this patient where we use a Hartshill rectangle, cut off the lower end, fixed it in the pedicle screws, and use sublaminar wire for correction. A similar case with Lucas trolley, where the lower part of the construct has been pushed into the iliac bones. If you need, you could add an additional anterior correction as well. This is another case of neuromuscular scoliosis where we have used this Hartshill rectangle and cut off the lower end and fixed it in a hybrid fashion with pedicle screws right up till the sacrum, and sublaminar wires have been used for reduction. At the end, we've got a reasonably good radiological and clinical picture. One more peculiarity about these patients are the pelvic obliquity. Pelvis in these patients are also malaligned. They become a part of the curve. Pelvic obliquity could also be sometimes not because of a structural problem, but because of infrapelvic cause like muscular or limb length discrepancy. Many times you can see that the hips have been dislocated. So analysis of the pelvis can be very tricky, but is very crucial. Imagine a patient with a limb length discrepancy, the patient has an oblique pelvis, and you end up correcting the curve and correcting the pelvis. You're very happy with the result, but as soon as the patient starts walking, the curve starts falling off on the side of the lower limb length. Or if a patient has a fixed pelvic obliquity with an oblique takeoff, and you just correct the curve without correcting the pelvis, you will see that the patient is falling off. You have to also make sure that the base of your construct straightens out. So the goal of the treatment in this patient should be to get the spinal balance right, improve the gait and function of these patients, improve the sitting balance. By improving the sitting balance, you'll make sure that the hands are free and they are more functional. And at the end, to improve the respiratory capacity. Patient should always be involved in the decision-making process along with their relatives. There are several non-surgical methods which are used in neuromuscular scoliosis. You can try bracing in young children or in children whose life expectancy is less. Steroids have been tried in patients with Duchenne's muscular dystrophy. Whenever you take a patient up for surgery in a neuromuscular scoliosis, think about long segment fixations, think about sublaminar wire, use a lot of bone grafts from iliac crest, and definitely no costoplasty, as you don't want to add to the respiratory complications. This is one other patient where we have used sublaminar wire and hard shield rectangle as a hybrid fixation to correct this long floppy curve. Try to avoid only anterior surgeries, as they almost always add on or decompensate. An anterior surgery should be supplemented with a good, robust posterior surgery, which you take it down either to the sacrum or the pelvis as the patient requires. So now the big question always arises that should you fuse the pelvis in neuromuscular scoliosis? Now, why the controversy? Imagine a patient where you have corrected and fused the patient up to the pelvis. You have got a fantastic correction and a very good sitting balance. But now, a lot of times these patients use the lumbosacral junction to help mobilize. So sometimes after getting a very good rigid fixation, you notice that the ambulation or seat transfer can become a problem. Sparing the lumbopelvic mobility often helps the patient with mobilization. It is observed that if you manage to straighten out the L5 vertebrae, the iliolumbar ligaments are strong enough to help with the pelvic obliquity. So in general, think about stopping at L5 if your pelvic obliquity is less than 15 degrees or the COBS is less than 40 degrees. You have a good coronal balance which is achieved. The patient is a walker. The curve is higher up above L2 and surgery is done early in life and in patients with no severe lower limb contractures. There are a lot of problems associated with fixing the pelvis because of huge pull-out stress and in general poor bone quality. You can see a lot of patients with implant failures. It is a technically demanding procedure. You can get a loss of lumbar lordosis at the end. There's high rate of pseudoarthrosis, skin-related morbidity, higher chances of infection, increased blood loss and longer operating time. So in the end, the big question is it really worth doing the surgery in neuromuscular scoliosis at all? The controversy still remains when you start comparing the morbidity versus the complication rate versus the final benefits of the surgery. The reported complication rate in the management of neuromuscular scoliosis ranges from 44% to 62% in the recent literature, right from infection to ventilator dependence, malnutrition, weight loss, and poor wound healing. An article in Spine in 2011 identified non-ambulatory status and preoperative curve magnitude of more than 60 degrees directly associated with major complications. One other article where they studied 50 patients with neuromuscular scoliosis. All 50 of them had some or the other complication. The risk factors for respiratory complications increase when the curve is more than 69 degrees. The force vital capacity is less than 39.5%. The FEV1 is less than 40% and age is older than 16 and a half years. Generally, the blood loss is 7 times more than regular AIS patient. Often these patients are malnourished. Keep a watch on the preoperative nutrition and optimize it. Total lymphocyte count and serum albumin level are good markers to watch for. A lot of these patients post-surgery have neurological deterioration and worsening of the ambulatory status. The patient should be adequately counseled for the same, and post-operatively they need a lot of functional training and neuro rehab. So at the end, I would say that preoperative patient and procedure selection with meticulous preoperative workup, counseling the patients well, will see more and more happy patients at the end. Thank you very much.
Thank you, Priyank. I think it completes the whole of the session. But before that, KV, can you make a comment? Like, do you find, especially in patient who is significantly disabled, I mean, what's your experience in operating on these group of patients? And whether you would like to go down to the pelvis in a patient who is ambulatory?
So I must admit that I don't have a lot of experience because the place where I come from, we have eliminated things like polio several years ago, and I don't see a lot of them. The cerebral palsy patients and the other neuromuscular disorders, very few of them eventually consent to have any kind of surgery. So my experience has been really small. Having said that, whatever little small experience I've had, I'm reluctant to fuse ambulatory patients onto the sacrum. I would rather leave them a little bit decompensated rather than fusing onto this. That's been my experience. It's not a large experience, as I said.
Aggie, I mean, do you have experience in managing neuromuscular scoliosis patients?
Yeah, in my institution, we have several patients, but I think there's no tricks or knacks to safely treat this patient. I think the important thing is working very close to the pediatrist, or neurologist, or cardiologist, and to see how the patient's risk, because the neuromuscular sclerosis patient is a very heterogeneous population. So the patient background cup size are all different for the patient. So then if there is a modifiable risk, we need to change and improve this risk to mitigate the surgical risk. So yeah, thank you.
Okay. I think, thank you very much. I mean, our sincere thanks to the Japanese Scoliosis Society, Dr. Kota, Dr. Daisuke, Dr. Yagi for taking their time to be with us at the end of the day and also on a Sunday. Our thanks to all the other speakers, Siddharth, our panelists, Dr. KV and Dr. Surya Prakash Rao. And over to you, Shailesh.
Thank you, Ajay, for a wonderful chair for the nice deformity session. And I again would like to thank Professor Kota, Daisuke, and Mitsuru Yagi for a great contribution from Japan Scoliosis Society, Dr. Priyank Patel from Mumbai, Dr. Siddharth from Pune, who have contributed to this wonderful session of learning. And at the same time, I would like to thank our scoliosis stalwarts, Dr. KV Menon sir and Dr. Surya Prakash Rao, for giving their inputs during this session. And I would like to end this deformity session here and we move on to the next session. Thank you, everyone.
Yeah, thank you. Thank you, sir.
Thank you. We have our next wonderful session and invited talk from US, Dr. Alok Sharan. Good morning, Alok.
Good morning.
I hope everything all right. And we would like to hear from you on awake fusion. He is the pioneer and doing a lot of work in awake fusion surgery. And let's hear from Alok.
Okay. Good morning, everyone, and good evening in India. Can you hear me well?
Yes, sure.
Okay, yes. Let me share my screen. It's great to see everyone again. I hope soon to be able to come to India so I can see everyone in person again. It's been a long time. Here are my disclosures. You know, there's no question in my mind that we have gone through a very transformative period in healthcare, both in India, here in the US. I think it's time for us to start thinking differently about how we practice medicine, what our healthcare system is going to be like. There's no question that in spine surgery, we have been seeing a tremendous evolution in the use of robotics and navigation and minimally invasive technologies. And I would argue that while these technologies have made spine surgery safer, they haven't quite gotten us to the goal of achieving the best possible outcomes that we can achieve for our patients. I think now, especially after this COVID period and seeing what kind of destruction it's caused to people, I think that we have to start moving now towards thinking about performance and how we could try to optimize the performance of our patients and move beyond just, let's say, correcting their pain or let's say correcting their curve, but really trying to figure out how we can optimize our patients so that they can live the best life possible. My focus today is going to be, as you heard from Shailesh, awake spinal fusions, but specifically the role of regional anesthesia in spine surgery. A concept which is not new for surgery in general. People who do hip and knee replacements have recognized that the move to regional anesthesia has really transformed the field. I think now as spine surgeons, we have to sort of adopt those lessons that our hip and knee colleagues are doing and really apply it to spine surgery to be able to get a great optimization of outcomes. Now, we have been doing regional anesthesia now for over about 5 years now in spinal fusion surgery, this procedure which Shailesh mentioned called awake spinal fusion. So what I'd like to do is update you now on where we stand and what we have done. But to begin with, I want to be clear. Awake spinal fusion is not just a new surgical technique. It's a protocol. It's an enhanced recovery protocol. And our explicit goal for performing the awake spinal fusion procedure is to allow our patients to recover faster, help them mobilize quickly with overall less pain so they can get back to being who they were before their pain started. This, in essence, is what the protocol is. And understand that there are multiple steps involved in this protocol to get the outcomes that we're getting. And it starts with something simple as just sitting down and educating the patients properly. I think that we don't spend enough time with preoperative education, but this is so critical to get the results that we get. Of course, properly assessing their risk. And I know earlier there was a great talk about looking at nutrition and their protein and trying to understand how we can optimize and really diminish their risk. But the crux of the awake spinal fusion program and protocol is a combination of both spinal anesthesia along with this regional block called the TLIP block, and then ultimately try to minimize how much narcotics that they use afterwards. At this point now, we have performed 150 awake spinal fusion surgeries. On average, our patients are going home the same day, about 0.8 days are length of stay, but 50% of them are able to go home the same day. A lot of times because of social issues, they stay overnight in the hospital. But the good news is that the majority of these patients now are not taking any kind of narcotics or really any kind of pain meds now after 1 week. The use of spinal anesthesia, of course, is not new in spine surgery. I mean, there have been papers since 2005 written about the role of spinal anesthesia, mainly for laminectomies or microdiscectomies. The novelty, of course, of what we're doing is the application of spinal anesthesia for spinal fusion surgery. And many of you have heard this story before, but this was a 62-year-old female who I had taken care of about 4 or 5 years ago. She had a spondylolisthesis. She had pain in her back, pain in her legs, and she had previously undergone shoulder surgery and had woken up from that shoulder surgery and had developed delirium. She was a single lady, widow. Her kids lived too far away, and she knew she needed to have spine surgery, but she did not want the option of general anesthesia because she knew about the effects of delirium and general anesthesia. We had talked about the role of using spinal anesthesia for this case, and she was one of the first patients in whom we had performed her spinal fusion awake, and she did wonderful. And she was so happy with the results that we kept on continuing it. And as we switched over from general anesthesia to spinal anesthesia, we started seeing some remarkable results. This here is Tomas. This is his x-ray. He had an L4-5 microdiscectomy, and then he re-herniated a few years later. And so we decided, because of his large stature, to perform a fusion on him. This is Tomas about 2 hours now from surgery.
That's the word on the street.
How many hours ago did you have spine surgery?
Like 2, maybe less, 1.5, less.
Yeah, good. And so when we started seeing the application, when we started using spinal anesthesia instead of general anesthesia, we started seeing that the patients were waking up sooner, and that overall their pain was much improved. In fact, actually, these patients had about a 50% reduction in their pain. And as they came out of the operating room and they were in minimal pain, we realized that as long as we kept up ahead of them in terms of their pain, they really didn't have much pain after surgery. And so we were just amazed at the results that we were seeing with spinal anesthesia. And with that, we found that our length of stay was going down too. Because the reality was patients didn't need to stay in the hospital anymore. But it wasn't really till about maybe 3 or 4 years ago that a major breakthrough came. I was with Bhavik Garg, who many of you know, and we were teaching a course together in Delhi. And Bhavik had mentioned a paper that was published in 2015 describing this novel block called the TILA block, thoracolumbar interfascial plane block, and the results that they were seeing over there. We looked at this paper and we found essentially this. We know that the majority of the pain that you experience after a lumbar procedure comes from the paraspinal musculatures. And the paraspinal musculatures are innervated by the nerves and branches of the dorsal rami. If you can block the branches of the dorsal rami nerve preoperatively, pre-surgically, there'd be a dramatic relief in pain control. And so the TLIP block, on the left-hand side, you can see a picture of the anatomy. On the right-hand side, you can see a picture of the ultrasound. And essentially, the essence of the TLIP block is to essentially deposit medicine between the multifidus and the longissimus muscle to get all the branches of the dorsal rami nerve. And if you can do that, and if the medicine can sit there, you can essentially get effective pain control for these patients post-op. Now, in that study in 2015, Dr. Hand, who was the lead author, one more point. Since then, there have been some modifications of the TLIP block. You can see LMP is TLIP block, and then LLP is a lateral TLIP block, where they're going in at the interval between longissimus and iliacus. I think there haven't been as many published papers to date, but in essence, it's achieving the same thing. So we're seeing now variations of the TLIP block coming in place. At this point now, I try to always just do the LMP, not the LLP. But what was interesting was this. This is what a picture of the TLIP block looks like. So this is a live ultrasound picture. So you can see here in black is the spinous process. Here is the multifidus muscle, and then here is the longissimus. In a second, you're going to see the needle coming through. So you're seeing the needle coming in over here now. It's reaching the interval, which is this black space right over here. And you can see the medicine coming through. Now, some people do this block via X-ray. I found that doing it by ultrasound is nice because you really get a real-time look at the muscles and then the spread of the muscles in the fascial plane. We've become very facile now in doing this, but found it to be very effective overall. But Dr. Hand, actually, when he first published a study in 2015, he had done a very elegant study. Oops. He had done a very elegant study where he took volunteers and performed a TLIP block and measured their level of sensory changes. And you can see in red the initial level of sensory changes, but after 20 minutes, how diffusely the sensory changes occurred. So he proved out that you could get a very wide anesthetic effect with these blocks. There have been multiple studies that have been performed now with the TLIP block. This is a study that was published looking at 72 patients where they received general anesthesia versus general anesthesia plus a TLIP block. And they found that overall, the patients had lower Fentanyl requirements and lower VA scores. And at this point now, this data has been validated in so many different ways. But we found very early on that once we started integrating the TLIP block into the awake into the spinal fusion surgery, there's about a 65% reduction. And we use a drug called Exparel. I'm not sure if Exparel is available in India, but essentially it's a long-acting Marcaine, which has been really a tremendous game changer for us. With that, as the patients are having less pain, we're actually able to get them off of narcotics very quickly. And then more importantly now, we're actually able to mobilize these patients quicker and they're able to go home essentially the same day when allowed. So this regional anesthetic technique has been really a game changer for us. At this point now, I perform the majority of my lumbar fusions in a minimally invasive fashion. We use spinal anesthesia, not an epidural anesthesia, but we use spinal anesthesia. We use the TLIP block, as I mentioned before, along with, of course, proper pre-op education, risk assessment, and minimal narcotics. At this point now, our protocol is such that we try to get the patients home and ready to go within 4 hours. This is Kevin. Kevin had a reherniation at L5S1, developed degenerative disc disease. We elected to do a spinal fusion on him. And this is the kind of results that we expect, but this is about 4 hours after he hit the recovery room, dressed and ready to go. and Kevin's 48 years old. So these are the kind of results that we're expecting now. And essentially what we're looking for is beyond just the pain relief, the fact that they can mobilize quickly and just be back to normal as soon as possible. So you can see now that there's been a lot of adoption of awake spine surgery. Dr. Karan Singh, who I think is speaking later, he has started advanced using the awake technique for endoscopic procedure, which I think is absolutely amazing. You may have seen just recently an article by a friend of mine, Dr. Vijay in Connecticut, where he performed his first awake spinal fusion. And based off of the results that he's seeing now, he's seeing that patients will be coming to him demanding it. Where I practice in New York and New Jersey, just recently, we had patients flying in from both Michigan and Maryland asking for awake surgery. So we're seeing that patients now, as they're becoming savvier, are looking for this option, and they're trying to find surgeons who are performing this kind of procedure. So ultimately, at the end, as I said before, it's time to think differently. It's time to reimagine what spine surgery can be like. We have tremendous tools in robots and navigation. I think now we have to begin to think about how can we optimize the performance of our patients better. Here in the United States, we're seeing tremendous adoption at centers all across the country and people who are performing awake spine surgery. And this number is only growing. But what's been really, really neat is that just recently, a group of spine surgeons in Oxford, England, just finished their 5th awake spine surgery. We'll be writing up an article about that soon. I have a good friend in Italy who is doing awake X-lift procedures, and he's got a tremendous series around that. And of course, in India, we know Babak and others are doing tremendous work around awake spine surgery as well. So we're seeing tremendous adoption of the procedure, both domestically here in the US and then internationally. If you are interested in learning more about awake spinal fusion, we're putting together a course on a website called Doc Social. So I encourage all of you at some point to register and then look at it. So with that, Shailesh, I want to thank you again for the invitation to speak again on this procedure.
Thank you, Alok. It's a great concept. Ajay?
Excellent talk, Alok. Sounds promising. The only controversy that comes here is, of course, any surgery under a regional anesthesia in a high-risk patient has its own merits. But sometimes the anesthetist, say it a double-edged sword that, you are not in the control of a prone patient, because under general anesthesia, patient is under your control. But under regional anesthesia with a prone patient, there is no proper control of the patient in an anesthetist's hand. So what's your take on it?
There's a couple of things. It's going to require the anesthesiologist to think differently, because they do prone procedures with the patients awake. So it's a comfort level for the anesthesiologist. In our 150 cases, we have never had to turn someone over back to supine and intubate them. So we've been that. The other critical thing is that we never put the patients in a situation where they're going to become disinhibited. So for example, we don't use propofol. At most, we just use Versed and Benadryl, so the patients can be awakened so they can give you that kind of feedback. And so it is a different change in the way that anesthesiologists have to think about the case, because they like to be in control and it's easy. It's a little bit more work for them. But the critical thing is that if you do the work up front in the operating room, then downstream, you can get the results that we're getting.
Great, Alok. Sounds promising. I think there seems to be a good future for this. So with this, we would like to thank Dr. Alok Sharan for his excellent talk and really, giving us a new sight for such a common surgery we do day in and day out. Thank you, Alok, for taking out time on a Sunday morning. Now, move on. We would go to the next session, that is decision-making in cervical spine. And now I would like to invite our session chair, Dr. Abhay Nene and Dr. Gautam Zaveri. And along with him, our faculty, Dr. Pramod Lokhande, Dr. Rajesh Parasnis, Dr. Neeraj Vasavda, Dr. Shrivastava, Dr. Arvind Kulkarni. So I would like to hand over the session to Dr. Abhay Nene. All yours, Dr. Nene.
Thank you so much. It's been a wonderful deformity session, but we are moving on to the head end of the spine, and that's the cervical spine. And that's the tricky part for most of us. And this session is lined up beautifully with case presentations to tickle your, your decision-making processes in your head. And after that, we're going to have some videos and some lectures. So it's hold on to your seats. It's a session before the India-Pakistan match, but it's going to be as exciting. You can trust me on that. Thank you for joining Pramod, Rajesh, Neeraj, and Dr. Srivastav. We'll open up the session with three lovely cases, and I'll invite Dr. Samir Ruparel to present his first case. It'll be great if, Samir, you can involve all our faculty in your Q&A in the case. Over to you, Samir.
Thank you so much, sir. First of all, a very good evening to seniors and colleagues. And I would like to thank Sancheti Hospital as well as the Pune Orthopedic Society for giving me the opportunity to present this case. So I will just share my share screen. So the case that I'm going to present today is a very simple one, but at the same time, it is also most commonly found case that we see in our emergency department. So I'll start with the history directly. So this was a 49-year-old gentleman who came with a history of a road traffic accident. He came with complaints of only neck pain, no radiculomyelopathic symptoms, and on examination, there was tenderness in the cervical spine, and he was neurologically perfectly fine, walking around and normal. So what would be the next step in this kind of a patient? Since he is neurologically fine, just mild neck pain, shall we discharge the patient with medications and follow-up? If we are discharging the patient, what kind of immobilization should we do? Or we should investigate the patients with X-ray, CT, and MRI, and if so, what? So the discussion is open to the panelists so that we can get the answers from them.
Maybe you can direct the question to one faculty, Samir, so we save time.
So, Parasnis, sir, can we know what are the indications of doing further investigation in such kind of a patient so that we don't miss a spine injury over here, as well as when and how do we immobilize the patient, sir?
See, presence of neurological involvement is one sign, but you already mentioned that he doesn't have any neurological problem. So excessive neck spasm, restricted movements, associated other issues like tingling, numbness, headache, giddiness, or if he has any history immediately after the surgery, any bout of unconsciousness or transient neurology. So slightest of doubt, you should immobilize these patients from the site of injury to the hospital in the casualty till you have complete assessment. And once you have a thorough assessment clinically, then you can decide what further investigations you want to do. We all of us do the X-rays, the trauma series X-rays. And then further, whether to do any scans will depend on your clinical evaluation and the primary X-rays.
So further asking the same question. So trauma series, so you mentioned about the trauma series X-rays. For the benefit of the audience, can you let us know what exactly is very much necessary for us to know what is a trauma series X-ray? What is very much necessary to be seen on a lateral X-ray? And what different kind of X-rays would you order for the patient?
Yeah. You want to ask somebody else directly?
Kothari, sir?
So, Samir, answering your questions, I think this would be general in terms of a cranial injury, chest, abdopelvis, or long bones, etc. And then it would be more specific in terms of spine. So I would be more specific in terms of spine here, that as Dr. Parasnis said, suspected neurological deficit or documented neurological deficit, patient has got severe neck tenderness, then any which ways, if the patient goes for a CT brain, we would involve as a protocol that we do cervical spine CT, in our hospital as a routine protocol, so that majority of the cervical spine injuries, I think because of the overlap of different bones and limited exposure, it is missed. So whenever any patient in polytrauma or endo injury goes for a CT scan, we tend to incorporate the CT scan of the cervical spine in that patient, study the scans, and if suspected, I think go on for better imaging in terms of an MRI or maybe different X-rays. I think we would not incorporate the chest injuries or the abdominal injuries or the pelvic injuries. I think it's beyond the scope of this lecture.
Yes, sir. So basically, this patient, when he came to us for the trauma cervical spine injury, when the patient had a midline tenderness, we got these X-rays done. We got an open mouth AP view because there are many times that you miss the upper cervical injuries in this patient, as well as a plain AP, as well as a lateral view, which should extend up till the C6-7, and it is properly dead lateral X-ray, because many times there are facetal injuries which are missed. And this was the X-ray of the patient which showed a unilateral C5-6 facet dislocation for this patient. And it has been reported in the literature that almost 16 to 20% of these patients are missed when they come to the casualty or the emergency department. So once we had this diagnosis with us that the patient had a road traffic accident, 49-year-old gentleman, neurologically normal, with a C5-6 facetal dislocation. And what should be the next step? Shall we further investigate the patient being neurologically normal, or we should directly go with the close reduction for this patient?
Okay, Srivastav, can you take that question, sir?
Yeah. So in such situations where you have diagnosed, before telling the answer to this question, for everyone, I would like to speak that in cervical spine, sometimes even if you have taken X-ray of different regions, there are two regions which are usually missed, and that is, cervico-dorsal junction. That is very important. Many times you miss the injury in that area, and of course, you mentioned already that upper cervical spine injury is also very commonly missed. Even if you have taken the X-ray, sometimes X-ray is not of good quality, and that is the region you should try to find a good, a dead lateral view where you will be able to diagnose the mild amount of subluxation. Of course, MRI will definitely give you an idea about the posterior ligamentous complex injury as well as the discal injury if there is a subluxation. So any case when there is no neurological deficit, all the centers, they don't ask for any MRI unless you have a very significant radiological finding which tells you that subluxation or dislocation. In that case, before reducing it, it is better to do MRI. Like in this case also there is a subluxation, so you are aware about the discal injury, whether the disc has gone into the canal partially, and during the reduction, there may be significant pushing of this disc posteriorly. So that becomes the reason for doing the MRI.
Right. So this is what we did in our patient. We got the MRI done to rule out if there's any discal injury, and if the discal injury harms the spine during the process of close reduction. And these were the CT scan images which showed a unifacetal perched facet over here at C5-6 junction. So the next step was, now we got the MRI done, we have got the diagnosis, and shall we reduce it? So can we have one of our faculty, for the benefit of the audience, to let us know how do they proceed with the close reduction in the emergency department? Can we have Hadgaonkar sir for the procedure of close reduction?
Let's ask Neeraj, Dr. Neeraj or Dr. Pramod.
Yeah,
because Shailesh is keeping unwell, I think. Shailesh, are you okay to talk?
No, I'm there, yeah. We normally don't try the close reduction in the casualty, or that probably used to be there in the past, but nowadays it can be risky at times because there is already a unilateral facet dislocation and you really don't have that guarded judgment of reducing. There are chances of worsening or any neurological problems. I think it is always safer to consider, if at all, you should consider complete anesthesia and doing it under Shyam in operation theater for reduction, if at all, with Gardner-Wells tongs and very judgmental, slow traction. But I will prefer to do an open reduction.
Can I comment here?
Yes.
Yeah. So actually, out of 10 times, only one case you might have the problem which Dr. Shailesh just now mentioned. As you are reducing and patient is awake, so every time you increase the weight, even if it is a difficult reduction, you examine the patient neurologically. So many a times you are able to reduce it without any anesthesia, and you don't have much problem. In some situation, yes, it can deteriorate, and that is the reason it is better to have MRI and get an idea which is the case which is going to problem. But out of 10 patients, in 9, you will be able to reduce it without any problem. That is actually my observation.
Right, sir. So this is what we also attempted. We attempted close reduction on this patient. So there were pre-operative attempts at reduction with gradual increase in weight with 5 kg, 6 kg and 7 kg traction weight was applied. And finally, the reduction was achieved with the 7 kg traction weight. and the patient was intermittently examined neurologically, and he was perfectly fine. So now we have a successful reduction, and what should be next? Can we ask Neeraj sir for this? Shall we remove the traction and conserve the patient, or shall we plan surgery?
Well, I have not seen the CT scan. Actually, intermittently my laptop got off. But if there is no fracture and you can reduce the traction to whatever amount you have achieved to 5 kg probably. And if you don't lose reduction, maybe you can conserve this patient with rigid collar, maybe Philadelphia collar. And later on, if patient have persistent back pain, maybe you can consider surgery later. But if it is the reduction is unstable on reducing the weight, if the facets are jumping again, then I think you will have to take the patient for surgery.
Perfect. I think that is what happened. We had a successful reduction, and after removing the traction, as you can see, the patient again slipped, and there was again loss of reduction over here. And as Neeraj sir rightly mentioned, then obviously we need to consider surgery. And what kind of surgery would be considered? Shall we go for an anterior surgery or for a posterior surgery?
Samir, can I make a point here?
Sure.
I think for unifacetal reductions, I think that there are two important issues. I think for bifacetal, the closed reduction is easier than a unifacetal because the intact ligaments on the opposite side don't allow you reduction. And in your particular case, there is a small superior articular fracture,
yes,
and that will always slip out. If you see the third image on the CT, the right one, you can see not only perching, but you can also see that the upper end of that superior articular process is fractured, and that is probably the reason why this patient might have been at a higher risk of resubluxing.
Yes, this is perfectly mentioned and picked up by Dr. Aiyer, and that is what actually happened. Even after a successful reduction, we actually lost the reduction, we had to plan surgery for this patient. And the next question is whether shall we plan an anterior surgery or a posterior surgery for this patient? Pramod sir. Parasnis sir, would you like to go for an anterior surgery or for a posterior surgery in this patient?
See, this particular patient, anterior surgery should suffice. Just to make another point, whenever the reduction is very easy, remember that sometimes resubluxation can also be easy. Why is it easy sometimes? Because of the fracture. In the absence of neurological involvement, no radicular problem, and easy reduction, there is no reason for me to think that I have to go posteriorly and fix it. I would achieve a very sound interbody fusion anteriorly with sufficient amount of stability.
Can I make a comment here? Now, even for this case, so I don't think there is any role of conservative treatment. Unless you have a patient who is so bad for general anesthesia and you want to put the patient on halo. Otherwise, all subluxation and dislocation ideally should be fixed, more so if the patient is young and he is going to do the activity. So I think there is no role of doing the conservative treatment unless you have a specific indication for maintaining in collar or halo. So I think that message should be very clear that in cases of such type of unifacetal dislocation or bifacetal dislocation, one should not consider, just close manipulation and putting the patient on collar. Just in cases where there is a specific indication for doing that. And whenever one is doing the anterior surgery, try to maintain the lordosis, because we know the anterior plate, it is just a buttress plate. So not maintain the lordosis and lock the facet posteriorly, then there are chances that there may be problem. Otherwise, the anterior surgery is enough.
Very important point. Samir, you may want to wind up because you're running out.
Abhay, one point.
Yes,
this also, the reason this patient subluxated again is, it's similar to an Angst-Pont situation where the upper lever arm is big. There are two vertebrae which are fused. So the stress on that particular joint is much more than a situation where there is, a disc which is moving between the two vertebrae.
Right.
So there is longer liver arm.
Fantastic. Samir, you want to wind up?
Yes, sir. So basically, as Srivastava so mentioned, the patient underwent a surgery and ACDF was done, and the patient is symptomatically fine, sir.
Lovely. Thanks for that case. It was an eye-opener, and some things that we agreed upon was the need to do investigations for such a patient, the entire trauma workup. We agreed upon the need for close reduction, attempt at close reduction. And what we didn't agree upon was conservative versus surgical management. And I think mostly the message is that you've got to do surgery, and a few important points about looking at the fused segments above and below. Arvind mentioned that, and to lordose so that we lock the spine and extension. So the posterior joint, which is otherwise out of its soft tissue components, is locked in. Lovely case. Thank you so much, Samir.
Thank you, sir.
May I invite Dr. Rishikesh Mehta, another swashbuckling surgeon from Pune, to present the next case and involve the entire faculty. Rishikesh, over to you. Rishikesh, maybe you're muted.
In the meantime, we welcome Dr. Ram Chedda, this scientific chair for this symposium, who is joined.
Shailesh, you got to introduce Ram as the future president of the IOA. Ram is contesting for the post of the vice president, which effectively becomes the president. And the entire Bombay Orthopedic Society, Pune Orthopedic Society, Pune Spine Society, Bombay Spine, everyone has wholeheartedly supported Ram. And we not only have to get him to win this election, we got to make him win with a record margin.
Yeah, that is what is our wish. And yes, Ram sir.
Thank you very much. I'm indeed honored and most privileged. And it's like talking to my own family. Each one of you is a very, very dear friend of mine. We've all grown together. And I appreciate the effort that the entire Pune Spine Society as well as the Pune Orthopedic Society have gotten together with the Sancheti Hospital and have worked out this spine weekend. Unfortunately, it's probably not yet face-to-face, and I'm pretty certain next year it will be a face-to-face meeting. And this is just a preamble. And I'm looking forward to seeing all of you at the IOCON, which is in December 21st to 25th in Goa. And that will convince you that the next spine weekend or spine week, why just a weekend, should be in a physical format in Pune. And I'm pretty certain you guys will do a great job. Thank you very much for having me here. Thank you very much for involving me in this entire effort. And God bless you. Keep learning and keep sharing. Thank you so much.
Thank you, sir. Thank you.
Thank you. With Ram's charms, I think IOCON is going to be again a super duper hit. Rishikesh, over to you. Can you start your presentation and stick to 10 minutes? Thank you. Rishikesh, I think you're muted.
Rishikesh, aikala yet nahi.
I think meanwhile, can we go to Pramod and come back to Rishikesh?
Yeah, while you can softly give him a telephone call and tell him about the problem.
Yeah.
Pramod, you can present your case.
But we need Rishikesh to go off.
To unshare it. Yeah, I think Dr. Rishikesh has to unshare for me to share. So
no,
we are.
Remove your earphone, I think. Just that will solve the problem. Just remove your earphone, directly plug it, and increase the volume of your laptop.
Yes, sir. Am I audible now?
Yeah. Yes, Rishikesh. Go ahead. Thank you.
Yes, sorry. So this is a 39 years old gentleman which presented to me 3 years back. He presented with paresthesia in both upper limbs and lower limbs, tingling numbness, which has been on and off, but more predominantly since 6 months. He also complained of pain in both his eyes since 2 months, and his walking was reduced. He came to me after he had sudden onset imbalance of gait and bilateral weak hand grip, and he had difficulty in writing, signing, and holding objects. So this was the time when he presented to me. On examination, I found he had unsteady gait. He was Murex grade 3 actually. His both hand grip were weak, and surprisingly his reflexes in the upper limbs were brisk, but in the lower limbs I couldn't see that the jerks were diminished. Clonus was there, Babinski positive, and Hoffman signs was positive. So there was a mixed picture here, human signs in the upper limb, but I couldn't get those clear-cut disc reflexes in the lower limb. So at this juncture, I would can I ask Dr. Siddharth that what investigations would you do?
So in case of patient presenting with clinically cervical myelopathy with possible diminished knee jerk, maybe we are looking at a tandem stenosis with a claudication component. So I would advise for a MRI of, I will get MRI cervical spine, but include a screening of the whole spine. And if there is definitely lumbar canal stenosis, just have a word with the radiologist. If there is any significant finding, they can do a detailed axial cuts at the lumbar spine. A mandatory cervical AP lateral X-ray also at this time to see how is the alignment of the cervical spine. And then for the lumbar spine, I think I will take a call after the MRI for additional X-rays.
Correct. So we did the X-rays of the cervical spine, AP and a flexion extension lateral view. The extension and the flexion, there was no significant kyphosis even on flexion on the lateral view. This was the MRI image T2, which showed a significant cervical cord compression, most significant at 5.6, but he had overall reduced canal diameter in the cervical spine and multiple level cervical cord compression as evident here at 4.5, 5.6 as well. These were the axials which showed that the cord had completely become banana shaped at multiple levels. 3, 4, 4, 5, and 5, 6. So these three levels were significantly compressed, and the most significant compression was at 5, 6 level. You can see this black colored thing at all levels, which made me suspect that he has a component of OPLL. So we just did his CT scan as well, which showed significant segmental OPLL along with some changes in the front as well. Probably he had a dish variant. As you rightly said, because of the diminished reflexes in the lower limbs, we did an X-ray of the lumbar spine, flexion extension views, and this were the MRI which showed significant stenosis at L2-3 level as well and 3-4 as well. So he had compression in the cervical spine as well as lumbar spine. Both were very significant, and these were the axials of the lumbar spine, which showed significant stenosis at L2-3 and 3-4 level, borderline at 4-5. 5S1 was pretty okay. So at this point, I would like to open the discussion about the plan. How do we go about this patient? Just do cervical first, because the picture was he had predominant pain in the lower limbs, but more of neurological signs in the upper limbs with more tingling, numbness, paresthesia, weak hand grip in the upper limb. Just do cervical first and then lumbar, or do at the same setting cervical plus lumbar. Plus, I think there's not much a debate about the approach, but still, who would like to go anterior or posterior with or without instrumentation? So, Dr. Ajay Kothari, sir, please, can you take this?
It all depends upon the age of the patient, number one, the associated comorbidities, having a dialogue with the anesthetist regarding the length of the surgery. It also depends upon, you need to get your colleague surgeon on board so that two simultaneous teams can work together. So I think if my philosophy is that I always do the cervical part first, let the cervical myelopathy recover, and then eventually maybe after a few weeks to months, then go ahead and do a lumbar spine surgery. Because it's very difficult to differentiate the lumbar symptoms when there is a coexisting cervical compression higher up. So in this particular case, I would tackle the cervical part first, let him, recuperate from that, and maybe a few weeks to months later, depending upon his recovery pattern, think about doing the lumbar surgery.
Even with such significant compression in the lumbar spine, plus, he's complaining of predominant thigh pain in both the sides, still you would go for only cervical?
Yeah, that's what I said, that, although there is a L2, 3, 3, 4 compression which is seen, but in presence of cervical cord compression, such a significant one, I would still want to do a cervical first and then eventually counsel the patient that, he'll need a lumbar spine surgery, but I would definitely stage it.
Okay. Sir, and what about the plan, anterior, posterior?
I would do a posterior cervical laminectomy in this case.
So we did the same, but we did cervical plus lumbar together. So I did a cervical laminectomy C3 to C6. Plus in the same setting, we did L2 lower half to L5 lumbar decompression. And this is, I usually do a 3 months post-op MRI for all patients whom I do indirect decompression to see how much is the cord fallback. And we always counsel the patients that, if in spite of posterior cervical decompression, if the symptoms do not resolve, he might need anterior later. But in this patient, he had a good cord fallback and very good neurological as well as clinical improvement. So this was 3 months post-op MR, but we did lumbar also together in the same setting, and he was absolutely fine. So these were the pre-op and the post-op MRIs, which showed good decompression. And I usually do a every yearly to check the progression of cervical kyphosis, whom I do not instrument. So in this patient, you can see that there has been no progression of kyphosis 1 year post-op, 3 years post-op, and patient is doing very well. He just came to me 1 month back with a lower back pain. So we got fresh X-rays also, and even the lumbar spine is doing good, and he has no issues at all. He had just some
lysis at L5. There seems to be a lysis at L5. Probably that's the reason he has back pain.
Correct, but even the pre-op showed something, but he doesn't have instability type of pain, or there is no instability in flexion extension X-ray at all. He just have some occasional lower back pain.
Can I make a comment here?
Yes, sir.
So usually in this type of pathology where you have multiple level OPLL, this may be a segmental or it may be a mixed one. There are high chances of having OLF, ossified ligamentum flavum, in dorsal spine. And many a time you miss when you take a just midline cut of the MRI. So it is usually seen also in the facetal region. When you find there is a ossification in the region of the facets and there is a posterior cord compression. So just single midline thing, it might not work. And as you have correctly mentioned that axial cut is extremely important even in CT in dorsal spine. So usually these patients, they have combination. They have OPLL and also in dorsal spine, they have OLF. This I want to add that.
Point very well taken, sir.
Can I ask a question, Dr. Nene?
Yes, please.
Yeah, so this question is to you and to the other faculty members. There has been, a lot talked about in OPLL. If you don't fuse it, there is a progression of OPLL. So we studied the literature, because that's my talk, that OPLL progression is seen in 97% of people at 10-year follow-up, but the symptomatology which is there is only in 3%. So we've had a good number of patients with a decent follow-up wherein we've seen OPLL done treated with only posterior cervical laminectomy. So what's your experience of progression of OPLL in patient who has just been treated with laminectomy without fusion?
So personally, it's been very good, and we don't fuse them obligatorily. In fact, recently we had an OPLL on the follow-up MRI without fixation. The OPLL actually regressed. So I don't totally believe in the patchy literature that's come up about progression of OPLL. And clearly, if there are no symptoms, I'm not going to go looking for progression of OPLL. So I think my message is out there that I would not obligatorily fuse an OPLL unless there are other reasons to fuse it. I don't know what Dr. Srivastava feels.
Yeah, actually, when you have loss of lordosis to start with, patient is going into kyphosis and he has all these problems. So there is a definite role of fixation, and there you will try to even create the lordosis. Some of the, other Asian country people, they do actually decompression, interfacetal decompression to clear the roots, and they try to create the lordosis in those situations. So to start with, this patient had a good lordosis, so you need not fuse all the case.
Okay, so the K-line concept basically.
Yeah.
Fantastic. Rishikesh, thank you so much. Any specific take-home messages from you?
Sir, I usually, whenever I am going only for posterior approach, I always do a flexion extension view to rule out two things, that there is no instability present. And secondly, even on flexion lateral view, the patient is not going into significant kyphosis. Because if in flexion extension view, if you can see that the patient is going in kyphosis, then I would add instrumentation to my just decompression procedure.
Fantastic. But you've shown elegantly how tandem decompression can be done together, and indirect decompression in the neck can give a very good result, something that the community needs to know. Thank you so much, Rishikesh.
Thank you, sir. Thank you.
Can I call upon our next case presenter, the local boy, Dr. Pramod Bhilare, who's up and coming and rising. And Sancheti, watch out, you're going to have a smart new surgeon on your board very soon. Pramod, over to you for your case in the cervical spine section. Again, you're muted, Pramod.
I think the same thing, you can take out your headphones, Pramod.
Ajay, how often do you segregate your tandem stenosis? You mentioned that you sometimes take the anesthetists consent.
Am I audible now?
Yeah, you're audible now. Maybe we'll take that question later, Ajay. Go ahead.
Okay, I'll go to the case directly. Thank you, sir, for the introduction. So this is, I'll do a full screen first. So 45-year-old female, he presented to us with neck pain radiating to both the shoulders with restriction of movements of the neck, had a difficulty in swallowing, history of diabetes and hypertension as a comorbidities. She gave a past history 2 weeks back. She had a UTI with septicemia and shock, for which she, the organism or the bug identified was Pseudomonas, and she had actually received a multiple bag of antibiotics. And since her symptoms of UTI, she was having on and off neck pain. And it was profound when she presented to us. On examination, she had axial tenderness. She had a restricted range of motion. The power in bilateral upper and lower limb was 5/5. Sensory was intact. But on reflex examination, there was hyperreflexia which was present. Bilateral Hoffman's was positive, as well as planters were outgoing, but had no bowel and bladder involvement. So these are the X-rays. Any takers for the X-ray? Dr. Aiyer, can you see any different on these X-rays?
So we can see a large soft tissue collection in the prevertebral space, or soft tissue shadow rather, which could explain the dysphagia that the patient had. Also, if you look at the X-ray of the lower part of the spine, there is definitely a kyphosis with loss of disc space at 6-7 with increase in the interspinous distance. In view of the previous history of septicemia and with the large soft tissue collection, I think a possibility of an infective spondylodiscitis in a previously comorbid patient comes to mind as a primary differential.
Right. So very well said. These are the things which are very clearly visible in this lateral X-ray. Also, just to add on, there is a local kyphosis. So there is derangement of the sagittal profile of the cervical spine. These were the MRI features. You can very well see an abscess which is with a destruction of the 7th vertebrae, which is extending almost to the posterior half of the C6 vertebrae with a large prevertebral collection as well. The patient also on axial sections, you can see a nice prevertebral collection as well as an epidural correction compressing on the cord, leading to some cord changes and thereby myelopathy changes. We did the sagittal CT scan, which showed a massive destruction at the C7 vertebral body. Also, you can say there is a toppling sign, which is very well visible at C6, C7 level. And also on the coronal sections, you can see there is a lytic destruction of the C7 vertebral body, more eccentrically placed than centrally placed, more so on the left side. And also you can see on the axial CT scan, there is quite a bit destruction with fragmentation of those bony particles seen at the C7 vertebra. The blood investigations, as the next part of investigations were done, showed an ESR which was 86, CRP which was 94, and a TLC count of 5,400. The LFTs and serum creatinine were within normal limits. So coming to the management part of it, now we, as Dr. Aiyer pointed out, with the background history of septicemia with infection in the past, can we really give the patient role of empirical AKT here, or should we offer the patient surgical management directly? Any takers? Dr. Arvind Kulkarni, can you just highlight what exactly will be your further course of management?
See, first of all, this is not a subacute or a chronic situation. This has happened very quickly. So most probably it is not tuberculous, and with a positive history of an infection, UTI, right? So
Right,
there is a
UTI.
possibility that there is a metastatic, hematogenous spread, which has caused this particular infection, and
Right.
it's too short to cause so much of destruction also. So I'm not sure whether this is right. AKT should be given. See, the vertebral body is gone, C7. It is relatively unstable. I would go straight away and operate on this patient.
Right, right. So, Dr. Nene, any role for empirical AKT in your books, provided this patient didn't have any clear signs of instability, not much massive destruction, but a good collection with the background history of UTI with Pseudomonas isolated. Do you give empirical at all AKT, or you prefer the first line of drugs which were given for the previous septicemic episode?
I think AKT should not even be discussed here, because
Right.
it's totally out of place and there's just no role of AKT here. There is a
Right.
possibility that if you want to conserve because she's toxic, you can, on one end get a biopsy, on the other hand, continue treatment of the original Pseudomonas. But I
Right.
think, like Arvind said, I would agree that this lady needs surgery. Yes, Siddharth?
When I look at the MRI, it looks very typically a TB because the amount of abscess formation, the locations of the abscess, they look not, pyogenic wise. In pyogenic, you would expect not so much of liquefaction. Only that thing looks like it looked like a TB on the MRI, though the clinical history is contradictory.
Yes, so here there was radiological high suspicion of TB because of the subligamentous spread of the collection, the beautiful prevertebral and the paravertebral collection along with the epidural space, and relatively preserved neurology. So we had a high radiological suspicion, but yes, the clinical picture showed otherwise. We had a lot of past history suggesting that it can be more of a pyogenic. And in view of this instability, which was there, a clear toppling sign and a massive destruction at the C7, we did plan surgery for this patient. We did a C6-7 corpectomy. We had actually planned C7 corpectomy alone, but intraoperatively we found that even the C6 vertebra had a lot of soft, and it was entirely friable. So it was actually coming out directly. You can see on the approach, anterior approach, there is a collection which was aspirated. Again, it was looking more like a cold abscess, which was aspirated. But again, with the background history here, with the septicemia episode and the Pseudomonas, which was isolated, we were not sure whether to start AKT or should we continue antibiotic. So these were the lab parameters. We already knew that the patient had received a bag of antibiotics here, where there were a lot of other antibiotics which were given for almost 3 to 4 weeks. And when she presented to us, she was not toxic. She just had the neck pain with a past 2 history. 2 week back, she was completely discharged with all these antibiotics loaded for her. So these were the lab parameters what we received. We sent the sample for the gram and the ZN stain, the expert MTB RIFSA, also for the pyogenic and the AFB culture. This is what we had got. So from majority times, I think this is a very common picture. What we get that the first 48 hours, or rather 48 to 72 hours, whatever reports we get, we are in a dilemmatic condition like this. We are not sure what to start with. So anyone, Dr. Parasnis, do you involve the ID specialist here? Do you start mixture of the past antibiotic and the AKT? Because here there was a radiological suspicion of TB, or you just give the AKT to start with just because the patient had all the radiological features of AKT?
Involving the infectious disease specialist over here is mandatory. And some of these cases where we do foresee some complications or difficulty in diagnosis, we involve the person right before we send the sample. We ask them precisely, and is it worthwhile to tell everybody exactly how many samples you take and what cultures you send, like you said, pyogenic, aerobic, anaerobic, and what sort of bacterial and everything. It's mandatory because you have only one chance to get all the samples, and sometimes even sending for the fungal and everything. Here, clinically, everybody is suspecting, but all of us have surprises. It is not unknown that if it is a paucibacillary disease, it can still be pox. It is also not unknown that sometimes in a treated patient with previous broad spectrum antibiotic, you may not get any sample positive. So here, I think the infectious disease specialist probably will advise you to have antibiotics which covers most of the spectrum.
Okay.
Watch for some time because you already done the procedure. There is nothing left out to be done over here.
Right.
And see the clinical course of the patients, how he responds to the broad spectrum antibiotics IV for 3 weeks, and then take it forward.
Right, right. So I think very well point mentioned that what all samplings do you send for is three major samplings which are sent is one is for the stain, which is a gram stain and a Zn stain mixed with minimal saline to not allow the sample to desiccate and dry. The other sample you send is the expert and the RIF assay. This is a gene expert again with minimal saline so that there is not much desiccation or dryness. At the same time, there is not over dilution. Third, very important sample which is sent is for the culture, both pyogenic, AFV, and at times, as sir mentioned rightly, in discussion with the ID specialist, if there is a slightest of suspicion of any fungal growth which is expected in an immunocompromised, or the radiology features suggest that there is more of a fungal growth kind of a picture, then we send along with this all KOH mount as well as the fungal culture. Dr. Nene, many a times this even the ID specialist here was confused what to do because the radiological parameter had everything featuring TB, and also we had a Pseudomonas with us. So the ball was in our court. He said, "You tell us what to start." But
so this is a case which requires a surgeon to walk across to the histopath department, talk to the histopathologist that we are in a dilemma and you're the only hope that we have. And please tell us differential between a granulomatous infection and a pyogenic infection. And you got to sit on their heads and make them count because they are the most diplomatic and non-committal souls on earth. And you really need to push them, arm twist them, or even shoot them in the head to get the right answer. And I think this is the only clue that we are going to have. Otherwise, you're going to get it all wrong.
Yes, so exactly the fifth, the last but not the least, we had sent the sample for the histopathological report, which is again a mandatory thing to do. And we were hoping and praying that the person at the microscopic end will give us the right answers here. And not to our surprise, he gave the report as acute on chronic inflammation suggestive of some infectious spondylolisthesis. Now we were again in a fix whether to start AKT. Again, the phones were given to the ID specialist, and we were again in the discussion: should we give AKT? Should we give both? See how the reports fare out, because we had least of the support and rather trust in the culture report, which is usually the case because 50 to 60% of the time the reports are positive. But with
we'll have to get to the end because we have overshot time. Thank you.
Yes. So we did start the patient on AKT after a mutual consensus with the ID specialist, and we do give the AKT, which is as per the index TB guidelines, which is for total 12 months, which can be extended for 6 months, which is 2 HRZD plus 10 HRE, and closely observe the patient with both lab as well as radiological parameters. And the 4 weeks later, we actually got the report that the AFV culture seemed to be positive, and we did have a sigh of relief. We gave the patient the complete course, and now the patient is doing well. So the take-home message here was, though all the clinical part which were showing that the patient had UTI, septicemia, Pseudomonas growth, patient had symptoms around the same time, you can never ever neglect or rather discard tuberculosis in an endemic country like India.
Fantastic. Very, very good and rare case, Pramod. Thank you for that. We'll quickly move on to the second part of our session, which is the video presentation. And we have no one less than Dr. Arvind Kulkarni, the celebrated surgeon from Bombay, who does some great surgeries. And he's going to show us a very slick technique of posterior cervical microforaminotomy. It's a technique that we all should have in our armamentorium because it can bail us out from some major operations. Over to you, Arvind.
Yeah. Can you see my screen?
Yes.
Yeah. So I thank Shailesh for this invitation. It is always a pleasure to participate in the Sancheti Spine Weekend. Many a times we have gone physically there, by we, all of us, and this is the second time we are doing it on Zoom. So without wasting any more time, I'll go to the case. So this is a gentleman who has diabetes mellitus. He has significant left-sided radicular pain in the upper limb, and it's quite significant. It can be as high as 8 out of 10 in certain positions, and he's tried everything: collar, medication, physiotherapy, root block, with relief for a few days. So he, on examination, has shows that his pain is around the C7 dermatome, and swelling is strongly positive. And on flexing the neck at that particular position, he gets relief. So he has no neurological weakness except for the triceps weakness. So he has a lordotic profile of his cervical spine, and on doing an MRI, he has a disc osteophyte complex at C6-7, and this happens to be on the left side. So you can see that compared to the right foramen, the left foramen is quite squeezed. The root is quite squeezed from the front as well as the back because of this degeneration, because of degenerative changes. So these are all the options that we have. We know all these: ACDF, artificial disc replacement, discectomy, foraminotomy without fusion or disc replacement, anterior and posterior foraminotomies, and any other which we can discuss later. So we went ahead and did what I'm supposed to talk about today. So this is what we did. So arm symptoms only on neck extension. He has a positive swelling, as I said, and he gets relief on flexion. So this is how the patient is positioned on a horseshoe with horizontal bolsters to support his chest. And this is a 14 mm tubular retractor. So I want to pause here for a minute. So the tubular retractor should land such that you should be able to see this Y. So that is the inferior margin of C6, superior margin of C7, and the facet joint line. So this Y should be visible, because this is what you're going to decompress, as you see here, to see the root from its exit from the dural sac till its exits out of the foramen. So this is where your tube should land. So when you introduce these dilators, most of us are familiar with these dilators. You should make, it's not like the lumbar spine. You can jeopardize and cause a very deadly spinal cord injury if you're not soft. So you have to do it under visualization at each level, at the level of the fascia, as well as at the level of the muscle, as well as the level of the bone. You should visually insert these dilators without taking the risk of jamming it into the cord. Sorry. So once that is done, so this is the superior margin of C7 that I'm cauterizing, and this is the inferior margin of C6. So the soft tissue needs to be excised. So this is a 4 mm cutting burr that I use to drill the adjacent laminae, the inferior margin of the superior and the superior margin of the inferior. So localization is the key here. You should be on the right spot, and for that you might have to pull the shoulders down, especially if it is at C6-7 level and the patient has a short neck, and that also helps in stabilizing the neck and the shoulders. So this is how we achieve hemostasis with bone wax at each and every step. So we keep drilling till you can introduce either 2 or 1 millimeter kerrison ronger. So the hint here is that the patient has pain on extension and you de-roof the foramen the pain should go away. So, and gently and gingerly you excise the thinned out lamina. So there, you get a glimpse of the dural sac. And gradually come out laterally. So there are certain areas where it is extremely narrow. You can see the purplish nerve root, which is significantly compressed. The root is freed in the area where it is exposed. There appears to be some distal compression. So then you tilt the tube further laterally. And that is the root in its entirety. So this is the hole that was made after, to decompress the root. So this is a post-op image and this is a post-op CT. This was done for academic purposes. So we have published this. This is an Indian spine journal. And this is something similar to what we had published earlier for the lumbar spine. So if you have a hard disc and the patient has symptoms of canal stenosis, if he has claudican pain, you don't need to do a discectomy, you just deroof the root. So contraindications are cervical kyphosis, which might get aggravated. The patient may not get relief. And of course, if there is central compression. So this is a road less traveled. It's an option in selected cases. I may be doing 3 or 4 in a year of these. It is a motion preserving surgery, no implant. It's less expensive because you're avoiding implants. It's a faster surgery and avoids all the complications of anterior approach and carries all the benefits of MIS surgery. Minimal trauma, minimal pain, early recovery, shorter operative time, and as you see, appealing cosmesis. Thank you.
Fantastic, Arvind. That was very slick and very well demonstrated. Thank you again. We'll hold back questions for later. Thanks again. We are going to make a slight digression in the program because we have, again, a very celebrated and a very popular surgeon from the other side of the Atlantic or the Pacific, whichever way you like to look at it, Dr. Kern Singh, who's joined us again on on a weekend morning from US. So we'd like to give him the green. And Kern, if you're here, we'd like you to go ahead with your talk on multi-segment cervical stenosis, how I handle it. Over to you, Dr. Kern Singh, and then we'll go ahead with our regular program. Thank you, Kern.
Just to brief, Kern does only cervical spines on a daycare basis, and he discharges his patients in 4 to 6 hours. And he does high volume surgeries of MIS in cervical and lumbar spine. And we all read his books. We all read his books in MIS. He's a world authority, I can say.
Can you guys see my screen?
Yes, we can.
Okay. First of all, thank you for having me. I appreciate it. Shailesh kind of scared me before. He sent me a link, and it said that the lecture started at 1 a.m. in the United States. And I was like, I can't do that anymore. I'm too old for that. But I do appreciate you guys having me. It's always a pleasure to be here. I don't know why my video is not working, so I apologize for that. I was given the talk of multi-level cervical disease and how I manage it, and I think that my position has evolved over time. And with a limited amount of time, I just thought I'd give you just the highlights of the change. In 2007, I wrote a paper that eventually won the best paper at NASS, North American Spine Society, and it was on conflicts of interest in IDE trials for cervical disc replacement. And basically what I had wrote a paper was looking at arthroplasty and how the studies were biased by those surgeons who had a conflicted interest in arthroplasty. And that paper was often quoted and misquoted and been used in literature to either argue for or against arthroplasty. And actually, many of the governments, the insurance companies in the United States have used that paper to advocate against the adoption of arthroplasty. So, I go to the talk today, which is cervical spine practice and multi-level disease. How do I do it? And the evolution of my practice is that I do everything but a fusion at this point for degenerative pathology. And there are exceptions to that rule if it's traumatic, and I'm not talking about that, but I'm talking about single to multi-level disease, radiculopathy to myelopathy. All of that has become motion preserving. And by that, I mean either arthroplasty, laminoplasty, or what was just really nicely shown, a microscopic foraminotomy. Whether you do that tubular, I do it endoscopic now at this point, but I really don't think there's much of a difference between tubular and endoscopic approaches. But I do everything to avoid an anterior cervical discectomy and fusion. And that's been the evolution, the essence of this talk. So I take a very classic example. This is a 37-year-old dominant, right-hand dominant male, 4-week history of pain, neurological signs, deltoid biceps weakness, no myelopathy, x-rays are pretty standard. He happens to be a very well-known medical malpractice attorney in Chicago. And for those who don't know, in Chicago, we have the highest medical malpractice in the world. So the average spine surgeon who practices for 25 years, the average spine surgeon will have 20 lawsuits against him, no matter how good or bad they are. So standard flexion extension x-rays, I see a right side C4-5 H&P, parasagittal, I should say. And then the images which delineate the C4-5 H&P, and I'll show some zoomed images of that as well. And I apologize if it's a little bit blurry, but there's a foraminal component to that H&P. So we published this paper in 2013. This was published in Spine. My research team, myself, Alpesh Patel, who is a well-known spine surgeon at Northwestern, collaborated with us. We looked at our national databases. We found a disproportionate utilization of anterior cervical fusions, posterior cervical fusions performed in the United States, essentially for degenerative pathology. So across the board, instrumentation was being thrown in. I was listening to talks earlier today, and I saw a cervical laminectomy alone. Well, I don't perform that procedure. I think it's a underutilized procedure. I typically perform in the setting of a laminoplasty. I believe Abe had commented that he did not believe, or someone commented, they did not believe the literature regarding, the sparse literature regarding the need for a cervical fusion in OPLL. I also subscribe to that belief. I don't believe that a fusion is required. We have 10 and 15-year follow-up on people who underwent cervical laminoplasty. So I think that, the overutilization of instrumentation, particularly that's, traumatic, or I should say, life affecting in the cervical spine, has become so widespread. In the United States, it was going out the roof in the 2000s to 2009. We published a subsequent paper looking at from 2009 or 10, should I say, to 2019, and it doubled again. So this is the classic patient that we often see in the United States, which is multi-level cervical spondylosis and multi-level cord compression. The initial IDE trials had arthroplasty as contraindicated in this situation. And we can talk about why, and that was for the reasons of the FDA. The FDA wanted a very clean guideline for who would be indicated. Myelopathy was excluded. Multi-level disease, at least initially, was excluded. And unfortunately, the world bases their decisions upon the FDA. In large part, they don't have infrastructure. So a lot of countries in the world then base decision-making upon what the FDA. What the FDA determines for a clean trial does not mean what's most medically relevant. So in this situation, I oftentimes see what's done on the right. This is not my patient, but eventually a multi-level cervical fusion is done on the right. And I'm not arguing that these don't work. I do believe multi-level cervical fusions, anterior, posterior, do work. I've just evolved away from it. So in my practice, these patients, I typically become very focused on what I treat. I would probably advocate for a multi-level arthroplasty. Only 2 levels are advocated in the United States. A 3rd level has to be paid for out of pocket, or it won't be covered by insurance. I go back to the individual that we were talking about earlier before. So it's a right-sided C4-5 H&P. None of this is technically demanding. None of this is technically, very unique or challenging, but the concept is very interesting. And the concept always spurs a lot of debate in which the literature is very clear on the debate at this point. So this is a patient population that we all see. This right-sided C4-5 H&P, very parasagittal, lateral to the cord itself. To me, the options, which are very routine, are ACDF and whatever you want to talk about it, tubular foraminotomy or endoscopic, whatever you want to do, or cervical arthroplasty. The options 2 and 3, to me, at this point, I believe are the only options that should be on the table based upon the level 1 IDE trials. That is, an ACDF is in every single IDE trial with the cervical disc replacement has been shown to have been inferior. And this is coming from someone who wrote all the original papers saying that there were so many conflicts of interest in these original cervical IDE trials. At this point, 10 years later, I have to swallow my pride and say that I was wrong, that the conflicts of interest do not detract from the effectiveness of a cervical arthroplasty. So to me, at the end of the day, I don't necessarily believe we should be doing single level cervical fusions for degenerative pathology. I'm not talking about infectious, I'm not talking about traumatic, I'm not talking about oncologic, but cervical arthroplasty. Now, the question becomes what's in the middle, a tubular decompression or even open foraminotomy discectomy. I wholeheartedly support that. And I do believe that the unfortunate part is there's no level 1 evidence currently to substantiate, but it doesn't damn the patient from having a arthroplasty or secondary event, does not preclude them from having that event. In fact, I had a patient who was a world famous sushi chef in Chicago. There's something called the Michelin award winning restaurant, which means only 25 or 30 restaurants in the United States are given an award. He was one of them. He had a C7 T1 massive disc herniation referred to me by another surgeon. He had clawing of his hand, his sushi hand. He couldn't work. And I ended up doing a tubular, I should say, I did an endoscopic foraminotomy discectomy at C7 T1. He was back actually at work the same day the next morning, operating again. So to me, a motion preserving procedure is what you would want as spine surgeons. You can tell me the benefits of an ACDF, and I wholeheartedly espouse that. In fact, my early papers were on the benefits of the ACDF. But at this point, almost all types of arthroplasty devices and tubular foraminotomies in my practice have been incorporated. So the real question becomes the cost-effective analysis. And I understand I'm talking about single-level disease. My talk was multi-level disease. But I would take something simple first and then build upon that. So this is the most common form of economic analysis used in healthcare to date. We use it as a quality or quality of life adjusted years. And that's how the US government, payers all determine its effectiveness. And this is from a good friend of mine, as you guys know as well, Shiraz Qureshi, who's been leading the way in some of the cost effectiveness data. At this point, everything, whether that be posterior foraminotomy or cervical disc replacement, has been shown to be much more cost effective than an anterior cervical discectomy infusion in any situation with degenerative pathology, not by a small amount, but over 5 times, depending upon the situation. And that factors in the life-adjusted span of that patient and that procedure itself. You know, initially when we had arthroplasty hit the market, and we're 20 years into arthroplasty at this point, there was fears of implant failure. There were fears of wear and lysis and debris. We just don't see that. And so those were very isolated events. Some of them were metal on metal concepts. But at this point, you know, the devices that have been placed in significant numbers and have been put in without much consequence and sequelae. It's a technically demanding procedure, but the outcomes at this point, level 1 data, is much more impressive than anything else being performed. And this was also looking at the economic analyses in a systematic review of all. And this was the follow-up paper that Shiraz and Dan Rue and those others wrote regarding that pathology. So, you know, we look at this and we're like, what conclusions can we say? Well, it's more cost effective than posterior surgery for myelopathy. This is anterior surgery. And cervical disc replacement is more cost effective than ACDF for single level cervical radiculopathy or myelopathy. And the data is very, very clear on the single level pathology. So what about DDD with radiculopathy or multi-level disease, which is what I've been asked to talk about, which is a small subset of this. And this is when the data becomes a little bit less clear. There are no clean level 1 studies because only 2-level device has really been authorized in the United States. Only you have to go to centers in Europe, which have done 3-level arthroplasty. But this is a classic patient that we see. We see multi-level disease, we see some disc-based collapse, we see some foraminal narrowing in particular, and it causes some parasagittal and foraminal narrowing, some mild radiculopathy, no overt no overt myelopathy. This is a classic common patient that comes in, highly functioning, for which we have no good solutions as far as it concerns anything with restriction of motion. Foraminotomies, multi-level foraminotomies are very reasonable for arm pain, don't relieve much neck pain or axis component. And arthroplasty was chosen in this individual. This wasn't necessarily my case, but this is a representative case. So 15 years after the fact, I sit on the board of 2 major insurers in the United States looking to the data and the policy guidelines, which were probably based erroneously on papers that I wrote from years ago. And I'm advocating for multi-level arthroplasty. And we're advocating now for a 3-level arthroplasty device to be approved in the United States and to be covered under insurance, and for degenerative pathology alone. Where its tremendous value is in adjacent level disease. Unfortunately, when the trials were being done, it was deemed experimental because what happened, if many of you guys probably remember, when the IDE trials were being conducted, there was a small subset of groups that were advocating a hybrid fusion arthroplasty phenomenon. That is, avoid a 2-level disc replacement because it wasn't really indicated or approved. So do a bottom fusion, a caudal fusion, and then do a cephalad arthroplasty. And that became known in the literature as the hybrid cervical disc fusion procedure. The insurers dubbed that to be experimental, and the data was very poor on that, very limited. And so it really prevented the incorporation of arthroplasty in 2-level disease. Fortunately, the Discover trial with Johnson & Johnson, the PCM trial, the Mobi-C trial, all the other trials thereafter, the Bryan disc, further confirmed they had indications for a 2-level disease and have now been accepted. And now we're beginning our 3-level arthroplasty disease, or arthroplasty studies, level 1 studies to document the efficacy of that. In all 2-level disease patients, arthroplasty was superior to every other form of ACDF. But I would advocate adjacent level disease is the most significant. So routinely above and below, I will perform arthroplasty. I didn't show this, and I'm not showing it for today, but controversially, if it's a pseudoarthrosis, an ACDF that's been done, ACDF that's been done before, with the facets that are still preserved, I will take down the pseudoarthrosis and convert it to an arthroplasty now. So, you know, if you look at this in the United States, there's a very simple answer to be given. Everything is driven, a large part driven by finances and what the surgeon is reimbursed. To do an arthroplasty, you are paid approximately 50% less than, or a third less, I should say, overall with the facility side, 50% less than a anterior cervical discectomy infusion. For what is probably a more meticulous, longer procedure in a cervical disc replacement, you are unfortunately paid a third to 50% less. In addition, the facility is paid 30 to 50% less. You're talking about a swing of $13 to $15,000, depending upon what the device is that's utilized. So what can we say? What we can say is there's an expression in the United States about eating crow. And eating crow is knowing when you made a mistake, and that was me. I advocated against arthroplasty initially. I said that the data was conflicted, particularly in the single level studies. I was clearly wrong. My practice is almost entirely arthroplasty. I do see the merits of arthroplasty. I see it in multi-level disease. I think in a single level disease or 2-level pathology for degenerative pathology, I believe it is the treatment of choice. I believe that none of us on the panel would like a cervical fusion for degenerative pathology. And if we wouldn't do it for ourselves, why would we do it for our patient? Unfortunately, the technique is much more meticulous. At least in the United States, it's reimbursed much more poorer than an anterior cervical discectomy and fusion. The short and now the long-term results in level 1. I mean, so this is the best papers that we have in literature. And I'd argue that arthroplasty is probably the best literature that we have in all of spine because it's been level 1, it's been followed now for 15 years. The short and the long-term results are excellent and have demonstrated superiority over ACDF in every degenerative situation. And of course, proper positioning of the implant is important. I think as the evolution, more particularly the device has been simplified. Now, if you look at the Mobi-C, which is very easy to insert, no longer involves a keeled prosthesis with milling and all those things that were much more counterproductive. Now it's easy to insert. I think that the average surgeon can see a significant improvement. And I do believe that multi-level degenerative pathology is trending in the United States heavily towards arthroplasty. And as I see the 3-level arms being conducted or starting to be conducted, I think you will start seeing 3-level arthroplasty being done in the United States. It's already being done in Europe. And I think the rest of the world will also kind of follow suit once the FDA gives the approval for it. So to answer the question, going back to what do I do for multi-level disease? I coned it down to degenerative pathology because dealing with all multi-level disease is too hard to deal with. But multi-level disease in sagittally balanced individuals with radiculopathy and stenosis and even myelopathy, then arthroplasty is a treatment of choice. In those patients who have radiculopathy, foraminal narrowing, foramination piece, non-cord compression, then endoscopic or tubular foraminotomies is the treatment of choice. In those patients who have multi-level OPLL disease, severe stenosis with the favorable K-line, if we spoke about earlier, then cervical laminoplasty. But to me, an anterior fusion or posterior fusion is the last tool in the tool belt for degenerative pathology. So I once again thank you guys for having me. It's always a pleasure, and I always learn something from the talks that are being given whenever I'm joining as faculty. Thank you.
Fantastic, Karan. That was absolutely an eye-opener and beautiful presentation of some great results of multi-level disc replacements. Ajay, would you take over for the Q&A?
Yeah, so anybody has got any questions? Anybody?
I think the obvious questions is complications or of dislocations if you're doing multiple, like more than 3 levels sometimes. Karan, have you had any setbacks if you've done 3-level anterior disc replacements?
That's a great question, Abhay. So I'll say that, I've done now at this point in my career a little over 1,100 arthroplasties. The vast majority of those are 1 and 2 level disease. 3-level, because it's not approved in the FDA, is typically a cash-paying practice, a cash-paying patient. So I've only done arthroplasty in 3-level disease. I think the number we were just looking at to write it up, about 75 to 100 patients. So a smaller subset of that patient population. You look at that, the dislocations, a lot of times the dislocations were done in the early IDE trials, and those were in prosthesis, which were keeled. In multi-level disease, I no longer have a concern. I typically use, and I'm not advocating for this, I have no consulting agreements, but I do use Mobi-C for the simplicity. It's a non-constrained device, but I think there are constrained devices out there if there is concern with that. But I do think that proper fitting, no over distraction. And I think with the expulsion, if we looked at I think it was Dan Rue that published looking at some of the factors for expulsion early on, it was those patients who the device was placed into hyperextension. So a posterior release was not performed. The PLL was not released in those patients that were pit space collapsed. And so if you looked at it, the arthroplasty looked like it was Pac-Man or fish mouth open from the beginning. And so it was very contracted posteriorly, very wide release anterior. So I do look for a balancing on that, but fortunately I have not seen any expulsion of those devices. An interesting controversy of which I'm involved in the United States. I don't know if you guys may be aware because not really it's a popular sport outside the US and Canada, but there's a hockey player. There's a famous hockey player in the National Hockey League, the NHL, who has a cervical disc herniation, who's seen several spine surgeons, Some have advocated cervical fusion, and some have advocated a cervical disc replacement. I saw the patient for a cervical disc replacement, and he's a famous hockey player. He's traveled all over. Interestingly enough, the NHL, the league that runs it, will not allow him to have a cervical disc replacement because they believe that the risk is too high for him to go back to hockey, and that the disc will have an expulsion. Now and he is suing them for medical malpractice. Now here's the kicker, why I believe that is garbage. And people say, oh, contact sports. I do it on UFC fighters, I do it on boxers, it's all garbage. If you look at the data in the United States, if you are a member of the military, that is the Navy, the Army, the Marines, and if you are a special ops, that means the Green Beret, the Army Rangers, those are the ones who are the elite tactical forces in the world. In the United States, if you have a single level cervical fusion, you are not allowed to return back to service. That means you can no longer be a Green Beret. You can no longer be an Army Ranger. They require a cervical disc replacement. So we have 15 years of servicemen in the United States who have gone to combat into war, fighting, carrying 150-pound bags, etc., with cervical disc replacements. So the data is confounding. I don't believe that the contact sports precludes an arthroplasty. There's a lot of good literature now showing that the arthroplasty is a stable device once it incorporates. And I think this lawsuit will be very pivotal because he's a famous hockey player and he wants a disc replacement, which is, I believe, what everyone on this panel would want at this point, a single level disease with disc herniation.
Very interesting, Kern. Very, very interesting. Ajay, over to you.
So I think we would want to stop here for the want of the time, Dr. Karn. It was an excellent lecture, and thank you so much for your valuable time. And with a big lapse in the time, still you could make it. Thank you so much, Dr. Karn.
Thank you guys for having me. I appreciate it.
I think now we would start with the next topic, that is the talk by Dr. Anand Tambe. It's a pre-recorded talk. I think we would start it, please.
Hello, everyone. I am Anand Tambe. I am a consultant spinal surgeon, and I work in Manchester, in the Royal Manchester Children's Hospital and the Salford Royal Foundation Trust. Shailesh, thank you very much for asking me to be a guest speaker on this webinar. And when I was given this topic right at the beginning, I thought about what I was going to speak for a long time. I realized that there is nothing absolutely right or wrong, black and white, when you come to the principles of cervical spine surgery. It's more a matter of applying the principles of the surgery perfectly in the appropriate situation, making sure that the goals that we want to achieve are very clear in our mind. The basic absolute minimum premise that one needs to have is do no harm, or primum non nocere, which is a famous Latin saying. Some of the things which I definitely consider in my decision-making algorithm are the points I have highlighted on this slide, which we're going to go through slowly through the rest of this topic. The first and the most important thing is the concept of global spinal balance. The global spinal balance is a term that has now evolved following the work of Ames et al., where the head is considered to be on top of the rest of the body, at the top of the pyramid of balance. One has to consider this whole thing in togetherness, not look at the neck in isolation. This is an extension of the concept of sagittal balance, which was originally popularized by Lee Kuek et al. Have a look at this X-ray, which will now highlight what I was talking about, global spinal balance. This is the X-ray of a 75-year-old gentleman who has had a previous laminectomy for hematoma. And he is now developing myelopathy secondarily after a period of improvement. This X-ray here, one shows that there is potentially something not 100% right with this neck. It looks kyphotic. It looks as if there is no posterior bone stalk. but you don't really get 100% idea of what might be going on. However, the moment you look at this in comparison to what normal X-rays would look like, you realize that definitely the cervical spine is kyphotic. However, the proximal craniocervical junction is not terribly abnormal. But the moment you look at this patient himself in person, you realize that the X-ray is not telling us the whole story. There is a lot more going on here, which is going to make treatment for this gentleman quite difficult. In such a patient, it becomes mandatory for us to know what is happening to the rest of the spine. And in these situations, getting an X-ray of the whole spine is absolutely mandatory. Suddenly, the whole picture becomes clearer. One realizes that he has a true chin on chest deformity with a head drop. But in addition to that, there is something going on in the proximal thoracic spine. What is going on? To be able to assess the neck with reference to the rest of the pelvis, certain parameters have been added to the parameters already talked about for pelvic incidence. One is the cervical thoracic pelvic angle, which has a correlation between the cervical and the thoracic spine, which in this patient, as you can see on the left, is significantly more than what would be acceptable. The second angle is what is called as the thoracic pelvic angle, which correlates the proximal thoracic spine with the pelvis. In this patient, that angle is marginally more than what would be considered as normal. Hence, we are now starting to realize that by getting an X-ray of the full spine, we're not now able to try to place the head with relation to the pelvis. Carrying on further, there are a few more indices which help us. One is the chin-brow vertical angle, which normally has a range from -4 to 17 degrees. Very obvious here that the chin-brow vertical angle is significantly abnormal. Similarly, the normal sagittal plumb line, which starts from the C7 body, also is significantly anterior to the posterior superior corner of the sacrum. So now we have a very clear picture that this gentleman has a cervical spine problem, but he also has a problem in the proximal thoracic spine. To understand this even more, Ames et al. Have now come up with a terminology similar to the pelvic incidence. It is stated that the thoracic inlet angle, like the pelvic incidence, is a constant. This is the sum total of the neck tilt and the T1 slope. All these three together can now help tell us what the position of the neck should be with reference to the rest of the body, and we can then potentially think of correcting the spinal deformity based on these parameters. The other issue, which is very clear, is the fact that cervical lordosis is not an arbitrarily fixed value in space. It actually has a significant correlation and changes with reference to what is happening in the thoracic spine. For example, the picture on the left shows a patient with a significantly high T1 slope. In this patient, to try to maintain a horizontal gaze, as you can see, there is significant lumbar lordosis, which is much more than what is normally acceptable as 15. But maybe for this patient, this is still harmonious because the patient is compensated and is able to maintain the horizontal gaze. So what is happening here is that the patient, to try to maintain the horizontal gaze, is increasing the cervical lordosis. To explain this, actually, a ratio or a formula has been coined which says that cervical lordosis is equivalent to the T1 slope minus 16.5 plus minus 2. This has been validated, and which tells us that as the T1 slope increases due to a proximal thoracic deformity, the cervical spine lordosis will change. And if the T1 slope is more than 25, the cervical lordosis will have a significant compensatory hyperextension, which might then have problems with neck pain, which is something which is being slowly shown in some studies. Using all these parameters, Ames et al. Recently, with the International Spine Study, have come up with a spinal cervical
already overshot his time. So what do we do?
I would suggest get to the conclusion because it's a very long talk and we don't have that much time.
Okay, so I'll just go to the
concluding slides because there's news from Dubai that India is batting.
Okay, last.
Would potentially either mean a high chance of vertebral artery injury or accepting a smaller sized screw, which might potentially mean that my ability to reduce this is less. Under OARM guidance in this patient in theater, we tried putting the C2 screws, but we realized soon that that was potentially fraught with the danger of damaging the artery. So instead, as you can see in the images, I have put 2 crossed lamina screws, which are both 28 millimeters in length, along with the C1 screw, and we have managed to reduce the spine. This is an approach which I have used in a lot of patients, and I would definitely, in the presence of OARM, suggest that we use it. Thank you very much.
I think it was a good talk, but because of want of time, we had to cut it short. So thank you, Dr. Anant Ambe, for.
What we'll try to post it on the video on the YouTube channel.
I think that's
in its entirety.
I think that's a very good suggestion. We would do it, Dr. Nene.
Yes.
Coming to the last talk of this session, I would invite Dr. Neeraj Vasavda for his talk on cervical pain blocks, the relevance and rationale. All over to you, Dr. Neeraj. Yes, Dr. Neeraj, we can't hear you.
Okay, can you hear me now?
Yes, yes.
Yes, yes.
Okay. Can you see my screen?
Yes, we can.
So I'm going to finish this rapid fire round. I don't want to, be the wall between India and Pakistan. And reason for our defeat that, country curses me for. So, so I guess, before we begin, we know that, there has always been a root block around the block, before we operate. I just want to quote a very beautiful article, although in open access Lancet, Lancet Rheumatology came very recently in 2021, and they did a multicentric phase 3 open label randomized trial at around across 11 spinal units. They included all non-emergency sciatica, which is secondary to herniated disc, and symptom duration of less than 12 months. And they randomly assigned almost 80 patients to transforaminal epidural blocks and 83 to the surgery group. The group was almost pair matched group. If you look at the baseline scores were also similar. And this is the recovery at the 18-week, which is showing more or less comparable results to surgery when you give a transforaminal block. Even more than 10-point improvements were also equal in surgery and transforaminal epidural block. If you look at the complication profile, the complication profile as such for both the things are very docile, very minor complications, but complications are further minor with transforaminal epidural nerve block. When it comes to cervical, we do know that cervical disc fare much better than lumbar disc in most of the cases, specifically when they are having a soft cervical disc herniation. Majority of them get all right with short course of non-steroidal anti-inflammatory medications. So indication for blocks in this kind of situation is soft disc herniation, patient with radiculopathy, intractable pain, not responding to NSAIDs, no progressive neurodeficit. The contraindication is myelopathy along with the radiculopathy and a progressive neurodeficit. A patient like this where you have a tight foramen, where you have a bony stenosis, sometimes block may not be of much use. When you plan a root block, selective root block, we have 2 techniques. One is posterolateral technique, wherein you position a patient lateral, target your foramen and inject the medication what you want. And another one is anterolateral technique,
where you target your foramen anteriorly by tilting the patient's head 30 degrees towards the opposite side. If we see at the result, long-term and immediate long-term result, majority of the patient, they almost 50%, more than 50% of the patients studied in this group, around from 659 patient to 802 block, almost 50% has 100% relief after 30 minutes of the procedure. Only 25% could not get the desired relief. The complications are also very minor, most common being the vasovagal complication from the root block, no major complication with transforaminal selective nerve root block. These are the plethoras of complications which can happen, which include vascular as well as neural. Vascular, you need to take care of carotid and vertebral artery. The rest of the complications are quite docile and manageable for outpatient technique. When you try to give interlaminar posterior epidural injection, majority of the patients still would have a minor complication, but there are chances of having epidural hematoma, quadriplegia, epidural abscesses to some of the major symptoms of CRPS and causalgia also. There are multiple case reports which shows posterior interlaminar epidural steroid are much more riskier than giving a transforaminal root block. I would want to again, conclude my talk with, this a beautiful review article from none other than Nancy Epstein. And sorry for a busy slide, but would want to read slowly that too many patients with or without significant cervical disease unnecessarily undergo cervical epidural injections. This includes both interlaminar and transforaminal also. This injections has potential of complication like epidural hematomas, infection, neurodeficits, intravascular complication, even leading to stroke, which can be attributed to this particulate steroid matter. And they concluded that neither interlaminar nor transforaminal has been approved by FDA, provide no long-term benefit, are being performed for minimal to no indication. They contribute to significant morbidity and mortality in patients, including epidural hematomas, infections, inadvertent intramedullary cord injection leading to quadriplegia, brainstem or cerebral stroke. So if we compare this Nancy Epstein's article and the recent review, multicentric study published in Lancet, how do we conclude what should we do? So the article in Lancet specifically concludes that when you want to do an invasive procedure, when you start thinking of invasive procedure, epidural steroid, and that particularly transforaminal epidural steroid should be the first choice of any kind of invasive procedure. Thank you so much, and let's enjoy India versus Pak match. Thank you so much. I hope I finished quite quickly.
Perfect, Neeraj, right on the ball and a very pertinent talk. You really got all the points in. And true to every year's track record, the Pune Spine Weekend has really lived up to its mark, and there's so much that we learn. Shailesh, thank you so much for getting us together and getting such a fantastic academic program. I'll bring it back to you for the concluding remarks.
I would like Dr. Siddharth Aiyer to thank you.
So it was a wonderful session. The organizing team would like to thank Dr. Shankar Acharya, the ASSI group, Dr. Karne and Pune Orthopedic Society. We would like to thank all the session chairs, Dr. Chabra, Dr. Ajay Shetty, Dr. Abhay Nene, the speakers in the lumbar session and the faculty, Dr. Girish Datar, Dr. Guru Raj, Dr. Kundanani and Dr. Chahal. Also the Japanese Scoliosis Society with Professor Watanabe, Dr. Sakai and Dr. Yagi. The cervical session with Dr. Alok Sharan, Dr. Kern Singh and Dr. Anand Tambe for their talks. We would a big kudos to all the young brigade for sharing their case experiences, Dr. Himanshu, Mayur and Shumayu in the lumbar session, and with Rishikesh, Pramod and Samir in the lumbar in the cervical session. A big thank you to all our senior faculty, Dr. KV Menon, Dr. VSP Rao, Dr. SK Srivastav, Dr. Neeraj Vasavda, Dr. Arvind Kulkarni and Dr. Priyank Patel for participating heavily in this discussion. Big thank you to Dr. Ashok, Shyam and OrthoTV for helping us with this big platform and so that we can live stream it on the web and YouTube. Big thank you to Sancheti Hospital and the management, Dr. Parag Sancheti, for his support and help in conducting. Thank you to my colleagues, Dr. Shailesh Hadgaonkar, for planning out the entire conference with good support from Dr. Pramod Bhilare. Most of the work was done by them. I think Dr. Ajay and Ajay Kothari and myself, we had very little to do because everything was taken care by the chief himself. So that concludes the vote of thanks. I'll let everyone get back to their cricket matches now, I think.
Thank you, Siddharth, and thank you everyone once again. And we catch up next year. All the best for India-Pakistan match. All the best, India. Thank you, Pramod.
Chalo.
Thank you. Okay.
Okay.
Yeah. Bye.
Thank you. Thank you all.
Thank you, sir.
Thank you, sir.
Thank you. Yeah, Ashok, we can.
I think he's not at the terminal.
Ashok, are you there? Ashok? You can close, Siddharth?
No, we can all leave because I am the co-host. I think recording, he'll have to stop from his side. I cannot stop recording here myself.
Okay, I'll have to tell Ashok then.
Yeah, okay. Thank you, sir.
Thank you.